यहाँ से Good morning and welcome again to the second day of this interesting conference. First of all, I would like to thank you for the very productive discussion which we had, and we hope that today also will make an active contribution to the discussion. I have the honor to introduce the speaker for this morning. Dr. Mahesh Verma sir is our senior council member and also is emeritus professor. And when we were preparing the when we were preparing the one slide, I found that 2 pages were the awards and recognition which he had. So, sir, we found it very difficult कि कौन सा award डाले और कौन सा award नहीं डाले. So, please excuse me अगर मैंने कुछ award miss कर दिया. Sir has been the Vice Chancellor of the Guru Gobind Singh Indraprasth University, New Delhi, and a former Chairman of the National Accreditation Board for Hospital and Healthcare Providers. Dr. Mahesh Verma has been honored with the Padam Shri Award, Dr. B.C. Roy Award, National Science and Technology Award, and he has been conferred with rank of honorary colonelship in the armed forces also. He has been the past president of the Indian Dental Association at the national level, Dental Council of India, Indian Prosthodontic Society, Indian Dental Association, International College of Dentists for India, Sri Lanka and Nepal region, Perry Fortune Academy Award. That's all very, and numerous awards he has received. And above all, he's a very wonderful teacher. I'm sure that the session you are really going to enjoy. He puts the graphics and even video clipping and the important, interesting topic of accreditation, how the hospitals are accredited, what are the parameters, because nowadays we are concerned with the quality of services as well, even in the government setup. Yesterday, sir mentioned about the Indian public health standards. So, sir will also focus on how we can ensure quality control of services in our institution. So, if you have any question, maybe you can interact at the end of the session. Over to you, sir.
Sir, that is all. Okay. So, good morning, everybody. I am an opening batsman for today, this morning, and I hope, I won't bore you. I'm just here to entertain you and sensitize you. See, all of us are healthcare providers, healthcare professionals. And I think at the core of our heart is to provide the best medical care to our patients, isn't it? You may be a forensic forensic expert, and many of us come from different domains, but what is it? Why are we, where are we today? I think our commitment to provide the best, isn't it? That's our core mission. And that's why, how we are recognized today as a healthcare professional. And so I just want to sensitize you. All of us also, many of us are part of government setup, and how it happens that in a government setup, how the whirlwind of processes patients go through, and how we can, bring that the entire turbulation to semblance through, quality control to accreditation. So my objective of this session today is just to sensitize you, just to acquaint you that what is NABH and what is this accreditation process and what it can be all about. It's not moving. No, last time I said that we want a better resolution. Is okay now? Okay. So, yeah. So, quality. We all talk about quality, and, what is quality? Quality for a consumer, we are not talking about healthcare, but in general, quality is what delights somebody, which I would, I get delighted. Wow, that wow factor is quality. And this is not one-time activity. This is an act or a habit or an event. For us, healthcare, every day, we're going to make it better and better. So it's not just one type, it's a habit. I want to tell you that suppose, many of us learn cooking. When you do it again and again, you become a better cook, isn't it? So when we emphasize quality, we become a higher level of healthcare provider. So it's a continuous process, not an event. So now let us define quality, especially when we relate it to the healthcare, because as I already said, that the quality is something which will delight us, delight the consumer. So quality has to have a very distinctive feature, which is very characteristic, which can really, for us in healthcare, which will give us an improved outcome, which will delight our patient, and especially the degree of excellence. When do we say it's a something very excellent service? Is when we compare it with a similar service provided by somebody else. So there has to be, we are comparing it with a similar service. And if it is a product, because see, healthcare is not just service.
Yes, sir.
Many times we also have healthcare products, like suppose we are having a BP instrument. Every time you use it and you find it gives you a very accurate reading. So you say, oh, this is the quality inborn. It's QC, it's quality checked and continuous quality. So that is any product which doesn't have a defect, free of any defect. And the fourth one is fit for purpose. Today, patients come to you, for their need. We may have a service or a product which is very good, everything. But when it comes to usefulness, it is not serving a purpose. Suppose you buy a beautiful pen. It has a fantastic packing. It looks very glamorous. It's very nice. But when you start writing, it doesn't write well. So it is not fit for purpose. So that's a fourth character. The fifth one is customer. Ultimately, the supreme satisfaction of our patient or a customer. That is the highest level of satisfaction. So these are some of the attributes, and that's how we say 5-star. When we say 5-star, some of these things which are incorporated in a service, that's a quality. आवाज करो थोड़ा, आवाज करो. Can you? Yes. We'll go back. Can you increase the sound, please? Is it okay? Okay. It's near maximum. यहाँ से होगा ना, यहाँ से हो जाएगा मैक्सिमम. Sorry, I think it got, anyway. So what is the moral of the story in that video is that this is what happens in our typical hospital setup. We get swamped by patients, and our processes are not optimized. If you look at that video, Another moral of the story is that, both of them, what this is actually, you probably, have you seen Lucy, that old time comic which used to come on, I Love Lucy, Lucille Ball, the Lucy and Ethel, her friend, they are working on this video. So what their approach is reactive, not preventive. We have to be, if you want your processes to be optimized, you have to be proactive, preventive, rather than reactive. So, and this is what happens in a government setup, in a typical hospital. I'm part of a government setup. I'm not actually finding fault with it, but we can have 10,000 patients walking in a hospital one day, and we are supposed to manage that. So this is what happens. So how do we ensure a quality care? I think it has got some attributes. First is it has to be safe. It has to be suraksha. I think that's ultimate, that any injuries, any medication errors, isn't it? We have a lot of things which happen because of us. Another one is effective. It has to be prabhavshali, isn't it? How prabhavshali? The latest. We do minimal invasive surgery so that less complication, less stay, faster recovery. Patient-centered, rogi kendric. Today, what patient wants? Patient want personalized care, tailor-made care. Another one is timely. Emergent care has to be provided immediately. We cannot, only if you have a fantastic hospital, and if some emergency walks in and you're not able to handle it, that's not a quality service. Another one is efficient. It has to be efficient. That means no wasteful resources. Sometimes what used to happen earlier, you go to a physician, he will prescribe a test. You go to neurology, he will prescribe many similar tests. So what are you're wasting resources. So it has to be efficient. And finally, it has to be equitable, nishpakshata, fair. Are we giving the same care to a rickshaw puller versus a care to a minister? So you can only say it's quality when you are equitable. You are providing a care which is same, to anybody and all the stakeholders. And the quality has got many parallels. What is the umbrella of quality? One is quality assurance. Today, a lot of our products come quality assured. What does it mean? That means they have, this is a very proactive approach. A lot of manufacturers, they say quality assured. That means they have used certain guidelines to produce that service or produce that product. So in healthcare, defining, designing, assessing, monitoring, and improving of the quality. That means every decision, every interaction, every communication has to be patient-centered. Then we say it's a quality assured. The third one is continuous quality improvement, CQI. That means that can only happen if you measure the quality. When you measure, it has not reached that level. And every time you do it, that's a quality improvement. So there is a room for improvement in the healthcare service in the processes in the system. And that will only happen if you are able to measure it. If you're not able to measure it, you cannot improve. Then it's only a judgment that the quality is not there. And then total quality, TQM. I think today we are talking of TQM, total quality management. That means it becomes a culture. It becomes institutionalize it. It becomes a culture of your organization. I want to tell you, I was heading Maulana Azad Institute of Dental Sciences, and I was among the first dental hospital, government hospital in Delhi who got accreditation in 2011. So it was a big thing that a government hospital, of course, it took me 2 to 2.5 years to go through the entire processes and infrastructure development. So, but then, it changed the entire, from the worst in the country, I became the best in the country. I want to share with you that my same Same institution was de-recognized by Dental Council of India way back in 1995. And 2011 onwards, I became the NIRF #1 institute in the country. So how it happened? Because the accreditation, it tried to help me to transform it, just to turn it around. So that's a TQM. So that means it is in the heart of your mind that whatever you do will be focused on a quality. So how do you measure quality? See, this guy, Evidis Donabidian, he's actually father of a modern quality in healthcare. He was from Lebanon, and he went to University of Michigan. I think there's Dr. Goel, who studied in Michigan, who spent some time he went to Michigan. He's a physician and a public health specialist. And he founded 3 things. We call it SPO concept. He said that we can measure quality through our structure, through the processes, and through the outcome. He said, if we know our structure, we know our processes, what goes through interaction goes through the structure, and what is the outcome? What is the patient outcome? The experience of the patient, the entire outcome through the structure, processes, that is so this is a SP level. So this is how you can measure, because without measuring quality, you really cannot improve it. You got to measure the quality. So whose job is quality improvement? What do you think? Everybody's job. And quality improvement is not that it's some very secret recipe. No, it is small things which you do every day. I want to give you an example. आप सब्जी बनाते हो, उसमें जरा तड़का लगाते हो ना, seasoning. So what it enhances the sabji, suddenly. Or you sprinkle some special masala which really improves. So it's a small, tiniest thing, small things which will enhance the service, isn't it? So that's so it's everybody's, and the best part in a healthcare is that secret success. When you increase the quality, is not kept to you. We have to share it, and we call it a best practices, isn't it? What works best for you, you will also share with your colleague, so that we copy it, we emulate it, so that we can also ultimately our objective is to raise the bar of the service to the highest level. You have to do something next time with this, because every time I find you. No, it's okay. So, the moral of the story is that every little thing enhance the service, every little thing. And I think we in a healthcare, it's very important that these small things, just see, of course, the other part of it is that it has to meet the patient's expectation also. See, this guy, I haven't put the entire video, he wants to surprise his wife. and the wife is on the way. She's supposed to join him. She's around in the same mall, and he quickly wants to take that gift and surprise her by giving her a gift. So he's in a hurry, but the salesman is, striving hard that he's putting all those things, cinnamon sticks and all those. He's trying to make that gift truly, very beautiful, very fabulous, so that he gets delight. So that's the story. So that is what is excellence. When you do that, it is excellence. Excellence is infinite. When you take the service to that infinite level, that's it. See, excellence has no destination. Excellence is something which that pursuit which you keep on striving to make it harder, make it better and better. That is excellent. So, what is that journey of a quality cycle? It's a perpetual cycle. When you believe in excellence, and every time you want to make it better and better. So it's a stepped approach. It's not just you can do it one time. There are steps. You build capacity, by eliminating all the sundry mundane jobs, eliminating low value tasks. You strengthen the organization by training, by planning. You do planning. The third thing is you tell your staff how does it work. Unless you believe in it, you will not do it, isn't it? You got to tell the staff, how it works, how is it going to make that happen, and then you integrate that into your process, into your infrastructure, and then communicate very clearly what has happened. To your what's its intent, what's its purpose, what's its value, what value it brings, and finally you align it in your organizational objective or organization vision and mission, that so that it becomes your priority, and every time you make it. So it's a perpetual cycle, always continuous, raising the bar every time in your service. So accreditation is actually just the beginning. Many of us, we think that if we take an accreditation, that's the ultimate. No, because it will take you to this level, higher. You just here. You want to reach there, and every time you go there, you go higher and higher. And that is accreditation, because accreditation is just a beginning rather than the end of your quest to quality. And once you take an accreditation, doesn't mean that you got a quality and you remain with that quality. Every time you go to, and I will tell you how that assessment happens. So what are those strategies now? There are 5 strategies, to get that excellence. We are talking about excellence, but when you raise the bar, unlimited, first is that we got to shift. We will talk about this one by one. First is a shift in the healthcare delivery model. Today, don't you think our delivery model has changed? What has been our traditional model is patient role is passive. Olden time, what patient will come to a doctor, he listens to the doctor, he just gets the treatment, he doesn't doctor doesn't give him any option. Okay, he says, this is to be done, that is to be done. That's the end. For doctor, disease is the focus, nothing else. And physician does most of the talking, and patient may or may not adhere to, he may stick to the treatment done. But today, what is it? We say patient-centric care. What does it mean? It means that patient asks question. He is a partner. He is not just a passive person. And he discusses pros and cons with the doctor. And the doctor doesn't just relate the condition with the patient, but also his family, his quality of life, his other people in the other activities. And physician listens, and patient does more of talking, just the reverse. And patients are more likely to adhere to the treatment because it has been tailor-made for him, individualized for him. So this is the first thing. If you really want to, first strategy is you got to have, we have to change the delivery model of our care. The second thing is excellence. How do you bring excellence in your care? One is that you ensure a well-equipped healthcare professional, well-equipped. So not only they are well educated, well trained like all of you are, but you also be supported by a adequate equipment. That's the first thing. The second thing is, and they remain abreast with what is happening, what is recent in advancements, and finally, they practice evidence-based care, not what you think, but something which has a proven track, which has been tried, time tested and tried, and there's the evidence. So that is the clinical. That's how the clinical excellence will come. The third thing is data. I already said the quality can only be improved when you measure it, isn't it? So today, the data is most important because data will tell you what are the trends, what patient wants, and only data can help you optimize your processes. Isn't it? Data is the patient's experiences, the outcomes of your treatment will only be measured through the data. So data-driven decision making. Without data, no, you will not just hypothecate. You need a clear data. And the fourth one is safety, patient safety initiatives. I think this is more important, most important, because your quality care, as I already said, has to be safe. So you have to be proactive in mitigating risks, implementing all the safety protocols, and also cultivate a culture of safety. Do you know that every year we celebrate Patient Safety Day? Can I ask you which is the Patient Safety Day every year we celebrate? 17th of September. Who did it? WHO, World Health Assembly in 2019. They suggested that 17th of September be celebrated Patient Safety Day, where we make patients aware and also a professional aware that how the patient safety has to be supreme for us as well as for the patients. And the finally is technology. I think today we got to adopt and integrate all the contemporary technologies. And today, that's why we are moving to digital health today, isn't it? Everything digital. Our EHR, our all the telemedicine, all those things, because it is the technology, because they are the ones, if we really want to raise, we want to bring efficiency, effectiveness, better care, we can reach higher level of people. We want to reduce the cost, because technology also reduces the cost of the care. So all that can happen. So these are, no, this is VR, AR, virtual reality and augmented reality. So, we got to use these technologies, the contemporary technologies, because so all these things, all 5 strategies can really bring about excellence in the care. So the question is, should quality initiative lead to accreditation, or should accreditation lead to quality initiative? I think they go hand in hand. They're intertwined. Both are, they work together. Actually, both help each other. They are merged into each other. So quality initiative will lead to accreditation, and accreditation will lead to a better quality endeavors. So what is accreditation? Now we're coming to what is actually accreditation. One is it is not mandatory. Please remember that accreditation it's not you have to take accreditation. No, it's a voluntary process. The second thing is accreditation is a third-party assessment, independent assessment. How they will assess it? They will assess it to certain benchmark standards. They will compare it, and how we can relate to those established standards, and what we can do so that we can continuously improve our healthcare services. So this is the definition of accreditation by International ISQA, because ISQA is the global head of quality healthcare providers. Even NABH is part of ISQA. So ISQA says that it is a self-assessment, and how self means you are voluntary, you're doing it, you are seeking forward that you want to get accredited. So this all started the ecosystem of accreditation, not only healthcare, The Quality Council of India, which is the ultimate body, was started in 1997. Before that we had no quality concept in India, and this is a part of DPIT, the Ministry of Commerce and Industry, Department of Promotion of Industry and Internal Trade. Basically, it came for industry, and I think healthcare, was also thought of an industry. So it's a spin-off from the industry. So spin-off healthcare, 1997, and chairman of QCI is appointed by the Honorable Prime Minister of the country. And Gunavatta se Atmanirbharta. This is their tagline today. And I think Quality Council of India has done wonderful work. And they have been the chairmen of the QCI. The first chairperson was Ratan Tata. And I worked with these two gentlemen, Adil Zainul Bhai, who was the chairman of BCG, Boston Consulting Group, and Jakshay Sahu, who is currently the chairman of QCI. So my tenure of 2 years was half with him and half with this gentleman. So what is the structure? They have a council, body, secretary general. But what is the most important thing is that, like NABH, they have multiple boards. One is NABL, National Accreditation Board for Laboratories. They have NABH, which is National Accreditation Board for Healthcare. NABET, that is National Accreditation Board for Education and Training. So they also accredit schools and trainings. Another one is NABCB, National Accreditation Board for Certification of Bodies. There are so many bodies, and the bodies have to be certified. And the fifth board is NBQP, which is National Board for Quality Promotion. So this is actually bringing about quality promotion for all these boards, and there are certain special projects. You must have heard JED, zero defect, zero effect. It's a big thing in industry that we want. And then the PPID, Project Implementation Division, Project Assessment, Documentation Division, Research and Analysis, something. So these are, and then Finance Committee. So this is the structure of QCI, and they are the one who are creating an ecosystem for quality, because they want a quality movement. Now today, when we want to become Atmanirbhar, so the slogan is Desh Ka Standard. We want to have our own Desh Ka Standard. So everything what is services or products which are produced in our country has to be of a global, has to be compared to global standard marks. And all these are, so we're not just healthcare. Look at all these industries which are getting accredited, which is going through the accreditation process, in all their endeavors. And so it's not just healthcare alone. See, look at, and there's also voluntary certification system where voluntarily you come forward and get yourself, and you give you a mark. I want to tell you that in Ayush, when they get certification, they say Ayush mark. You remember, like egg mark. You remember? Olden time we used to have a food, and so it's like a voluntary certification. So they get all these. See, Z, they get this mark when the zero defect and zero effect. So all these are. So it's a really QCI is really involved in all these endeavors in different aspects. And QCI also, it is not just in India alone. It's a part of international bodies. So we have a mutual recognition, like Medical Council of India recognize the physicians from, of course, it's not doing it. You have a mutual recognition, so you can go and practice there. So if anybody in our country has been certified by a board, so that is accepted. Suppose we are sending something abroad, exporting. So if it is NABH or NABL, so it is accepted that, okay, yes, it is meeting the global standards. So, and then now coming to NABH. Now that was just ecosystem QCI, and NABH is one of the part of this QCI ecosystem. And of course, QCI came up in 1997, but NABH came up in 2005. And the first healthcare standard was laid out in 2006, so much later. QCI, was basically industry focused, but health came healthcare came much. And I'm sure you would hear of Dr. Girdhar Gyani. He was the first guy who was a chairman of NABH, and also he remained also for a little while chairman of QCI also, for a little while interim. And he was the one. Objective was, he came and met me in 2007, and I was wondering, what is he wanting? He said, no, we have to come and prepare I was involved in standards for the healthcare and dental. So objective was to propagate, adopt, and adhere. So standards, not one time, but you want to adhere it so that you keep on following it throughout. So, and the vision and mission, of course, we all know the vision at that time, that you want to be apex national healthcare body, and I think it is. Today, we look to NABH as the supreme, one of the apex body, which is healthcare quality. And the mission was that everything which we do has to be, all the healthcare and allied program has to meet the standards for patient safety and quality of healthcare, and based upon national and international standards. And through how we do it, self-assessment, and also external third-party assessment. So that was a mission of NABH. And what is the value statement? What does it do? Why are we doing it? One is credibility. When somebody says NABH accredited, we think that this organization is providing a very credible service, value-added service, responsiveness. That means it is responding to patients' needs, patients' requirements, industry requirement. What is happening? Because healthcare industry is all the time continuously very effervescent. So it is continuously improving service. The third one is transparency. Everything is all transparent, openness in communication for all the stakeholders, patients also, and healthcare providers also, and innovation, because every time you go to innovate, bring something new, creativity, how you bring change, and so that there are new ideas, you all continuously taking the bar of the services to a higher level. So NABH, NABH also has to global record. Do you know NABH also gets accredited? NABH accredited the hospital, but there is a team coming from abroad. They sit 3 years and 3 days, and they go through the entire process of NABH. So because NABH also be accredited, isn't it? And it's part of the institutional member of ISQA, council member of ISQA, and also the institutional member of Asian Society. There is a ASQA also, ISQA and ASQA. And, so you look at it, see the International Society for Quality in Healthcare, External Evaluation Association, they have accredited standards for hospital 5th edition. And there's a time that they will be until April 2024. So even every 3 years, every time there'll be a higher standard, there'll be more standards incorporated. What is the global benchmark also have to be ensured that it is meeting all those global standards. So similarly, all different cycles. So what are the core activities? What does NABH do? Most of you think that they only do accreditation. No, they do accreditation, but they also promote quality through a lot of other things. Nursing excellence, certification, laboratory certification, policy projects. NABH is involved in so many projects of the government, like Ayushman Yojana mission, NAM, and so a lot of other activities, IC activities, public lectures, advertisements, and education and training, very important, skill and knowledge of the staff. All the time they're doing webinars, seminars, how to do assessors. So these are some of the core activities at NABH. And you look at it, most of you think that they only do accreditation. They do accreditation for these areas, but they also do certifications. They also do empanelment. All the CGHS and ECHS and medical value travel facilitator empanelment. See, Heal in India. Have you heard of Heal in India? So some of these big hospitals, Apollo, Max, Fortis, all this, they get assessed for medical value travel facilitators so that people can come here and for medical tourism. So these are the, and then projects, the certification of this Ayushman health and wellness centers. How they ensure that they are of a standard quality. So all this is done by it. And the new program which came up in 2023 was digital health, care homes, stroke care center, and dental care. While I was there as a chairman, some of these new programs came. So look at it, almost 20,000 institutions in the country, 16,200 accreditation, and 4,200 empanelment, today at the moment. And what is our way forward is we want to be 100,000, isn't it? So we want to be there. The last person, last healthcare center in the country, we want to reach there. That is the mission. And how it started, as I said, the first standard came up in 2006, and over the years, how these programs have added. And as I told you, in 2023, digital health started. We started a program. We started care homes, old age homes. We cooked stroke care centers and entry-level dental clinic certificates. So all these were done in 2023. So these are some of the recent initiatives of NABH. These are all standards, all they are published standards. You can buy them and you can go through it. That's how when you start doing accreditation, you have to buy a standard and then go through it and see your preparedness, how you are, where are you. So these are Deshka standard, that is objective, committed to ensure healthy lives and well-being, because SDG 3, healthcare is the most important. Health and education is most important of 17 SDG, which we are striving, to achieve. So what does NAB also carries out? Many trainings. They do training for knowledge and skills for assessors, because assessors have to be trained. There are implementation, how the programs are implemented, awareness program, assessors conclave, webinars, and National Healthcare Quality Conclave, like we had on 17th of September this year. We had in Ashoka Hotel, where patient safety, big congregation, about 5,000 people in a program doing. So these are some of the activities which NABH is carrying. And they have a lot of, because it's a mouthpiece for a government, Quality Council of India. So part of G20 Health Working Group, Ayush, NHA, that is all the digital health mission. All those are digital health missions, part of it. You would be surprised that NABH also does inspection for all the homeopathy colleges, like MCI inspection or DCI inspection. Homeopathy colleges are inspected by NABH. I think almost 245 homeopathy colleges in the country have been assessed, inspected and assessed by. So also we recently did gap analysis of RML and Safdarjung Hospital, and we provided them entry-level certification. And then, of course, as I said, medical value travel facilitator, Heal in India, part of Heal in India initiative. So, and then also NABH has a lot of collaboration with other bodies. FOXY, which is a federation of Obstetrics and Gynae Association. So all their assessments are done, in so many other Nat Health and Smile Train, which is cleft lip, Smile Train, for all those things. So, it was very interesting when our PM tweeted, "Congratulations to team at AIIMS Nagpur on this feat, setting a benchmark in delivering quality healthcare services." Oh, what happened? I just have a couple of minutes and I want to finish it soon. Okay. So now let's see what happened. What is the procedure very quickly? See, this is the cycle. How do you get? You quality improvement, you decide, then obtain standards, then you review them, you identify the gaps. If there are gaps, yes, you go to work on it. If there's no gap, you apply for NABH. NABH, there will be assessments, and if assessment is satisfactory, they will get a recommendation. But please remember, recommendation is for 3 years, and after 1.5 years, there will be a surveillance assessment. That means, are you doing fine? or you just got in and now you're sleeping over it. And then there'll be a renewal assessment. And every time you do surveillance and renewal, you are actually assessing much higher standards. See, to begin with, it is fine, but then when you go ahead, I will tell you how to do that. So when you want to apply for NABH, you should be at least 6 months in the industry, and all the standards should be in force for at least, must comply with all the applicable standards for at least 3 months. And then your occupancy, bed occupancy should be at least 30%. And it's not that you want to do it in piecemeal. You have to apply for the entire facility in that healthcare organization. So this is the entire process. They say that you can do it in 60 days, but it doesn't happen in 60 days because there will be a lot of non-compliances and this and that, and you'll be given time. So this is the cycle from 0 day, from day 0 to day 60. One can actually, if you are prepared, can get NABH accreditation. And these are different type of assessments which is done by NABH: pre-assessment, final assessment, and I said surveillance assessment, which is midway in the cycle, and the renewal assessment after 3 years. Now you're going for a new cycle. So that's it. And then other times there can be a focus assessment, some complaint in some area, so you will just do assessment that area. Verification, sometime, okay, you have done non-compliances. They said, I have done the compliance, so I'll verify it. And surprise, sometimes there's a complaint. This fellow is not doing. So suddenly you go and check it. And so, the 5th edition has got 102 core, which is, these core standards are checked at every inspection. Commitment, when you're doing surveillance, that means in surveillance, core and commitment. When you are doing renewal, then your core, commitment, and achievement. And when you are going higher level, then all the 4. So it has got 10 chapters. The standards have got 10 chapters, 10 standard, and 650 objective elements. So these are the 10 chapters in that standards. If you buy the standard, these are 10 areas where we have standard, and these are 10 chapters here. All the chapters, these are the standards, 100 standard, objective elements, 650, core, every assessment, commitment, when you're doing surveillance, achievement, when you are final assessment, and excellence, when you're going for renewal. So every time when you go, your benchmarks also improve. That means you cannot be stuck with just what you started with. And we have a scoring system. If no compliance or less than 20, you get 1 mark. 20 to 40% compliance is 2 marks. 40 to 61, 3 marks. 60 to 80%, 4 marks. So 81 to 100%. So nobody is 100%. So if you are able to reach at least 81%, you will get full marks, 5 marks. So that's how we do it. And then what is the outcome? Recommended, not recommended, inactive, abeyance, suspension. Sometimes you get a complaint, you're not doing it. A lot of non-compliances, suspended. Forced withdrawal. You suddenly find this fellow is misusing it. We ask them, okay, we force withdrawal or voluntary withdrawal. Sometimes you say, I don't want to renew it. That's all. So these are different categories. So how do we do it? It's not just you do it. You have to submit the key performance indicator. As I already said, quality has to be measured. So these are KPIs. You know why? They have to be measurable. How you are measurable? You collect it through data, and then they will complement the best to practice framework. And at a glance you can make out that are you doing well? Are you doing okay? Or you need improvement? So all these KPIs, see, this is how. Are you rock star? Are your standards are adequate? Needs are. So when you are all these KPIs, you are supposed to every quarter, you go to upload it on the website, and at a glance, you can see how well you are doing and where you need improvement. So that's how it's done. And so to conclude, I think the patient safety and quality assurance is the hallmark, is the most fundamental for us in healthcare. And this is the mainstay of healthcare accreditation. And accreditation is a very active and a dynamic process. It's not one-time activity. And it has to meet the patient's need. And we have to give them the best possible care. Bottom line, what we say, what is bottom line today, which I want to give. And So that why we do it? Because we are really committed to provide the healthcare standard, which is the best in the world, which is meeting the best standards in the world. So final video, and then I'm done. So the moral of the story is that we have to raise the bar, everything we got to do so that we provide, not only we provide the best care to the patient, but also delighted. It is individualized, it is tailor-made and customized for him. And every little effort, what can be done to raise that bar is truly welcome. This picture taken during one of the patient safety, 17th of September, one of the conclaves in 2003, and all our big wigs in the industry. The chairman was somewhere here of our, here is the Jakshesa, he is the chairman of KCI at that moment. So thank you so much. It's a wonderful, I've just taken 5 minutes extra because of a little goof up in the technology here, but thank you. It's such a pleasure to meet you and speak to you, address to you. Thank you. Thanks so much. Thank you. Bye-bye.
Thank you, sir. Thank you so much for such a nice presentation. And as I said, he is a wonderful teacher, and I think all of you now agree. He has made this important concept of quality to very clear to all of us. And so thank you so much for your time and support. So if we have one or two quick question or remarks, we are welcome. Otherwise, we'll start with the second. One or two remarks from a question, queries. And all these video recordings will be available on our website because some of the participants were saying that these recordings should be made available. So we'll provide you the link, and all these recording of all the speakers will be available. So you can download and view them. And yes, ma'am. Please, quick one question. And
Sir, if we want to get our hospital accredited because it's a government hospital, so first we should get the gap analysis done.
Yes, firstly you take a steepness standard and try to understand the truth you have. Firstly you have to self-assess yourself.
Correct.
Procure the standard and see where you are.
Okay.
Are you ready for that? Because there's no point filing for
something you will not get, yeah.
If you're not prepared. So firstly, you have to self-assess. When you feel, yes, you're all ready, then only you.
But sir, like you were saying that you did that the team did a gap analysis for Saptajanga names. So that is what they would have done, like probably written, take.
That was the entry level government Ministry of Health wanted.
Okay.
See, because it's to get a government hospital. So you can ask for a gap analysis.
Yeah, and that's what I wanted to do. Can we ask for a... So that would be actually more effective rather than us doing ourselves, probably if do something. Okay. And then probably gap analysis and then assessing.
You also know you are not.
At least rectify 50 of them and then.
You cross meet your objective and then you get a gap analysis for a further, the finer areas.
Okay.
And then you close the gap.
Then you apply. Thank you so much,
sir. Sir, I think the government of India has made it compulsory for government hospitals also for NABH accreditation.
There's nothing like compulsory, but desirable.
Desirable. I just want to reinforce, sir, what you said is very correct. In fact, there is a need that NABH accreditation should be done even for all hospitals.
Yes.
It's something like that. Like you sir mentioned about that quality and accreditation. Both are interlinked. But in fact, if the accreditation actually forces someone to go in for quality, this is this way only. So like if suppose this is mandatory, So what happens just to implement in a hospital about all the quality care initiatives, it becomes difficult. When you put up in this way, like this is via hospital is undergoing through NABH accreditation. So these are the requirements everyone has to adhere. So then adherence becomes easier.
No, no. See, I'll tell you, problem is, see, it needs lot of paperwork. It needs lot of infrastructural change. You know, see, if you look at the standards, the requirement is like, I want to tell you, your OT has to be modular OT. It has a HEPA filter. You know, your flooring has to have a dadoing. You know, so your lifts have to, you know, your fire safety, isn't it? Now, to most of the hospitals do not have a fire certification. So these are some infrastructural challenges because those hospitals were built 50 years back. Now, so that is a big challenge. And then you need manpower, you need processes, you need computerization, you need system for data collection, you know, everything. So this is in a government system. We are all the time, what are we? We try at 100 patient OPD mein baithe yaar, main niptaun kaise isko? You know, see, all those. We don't have any, कि हमें आज मैं इतने ही patient देखूंगा. So this is a big challenge. So, but what I would advise you that you can think of taking entry level certificate, which is easier. Entry level is checklist based, very easy. Full accreditation is tough. You know, entry level, it's actually enticing you to take accreditation. So go for an entry level, and then of course, once you're doing well, then you can upgrade to a full accreditation.
Thank you so much, sir, for your valuable time and support to the academy. And every time I think sir comes, and every time new things are, we learn new things from you. And we look forward for your support, continued support. I request Dr. Sanjeev sir to just present a moment.
Wow, wow, thank you. Every time I carry a book from here. Sir, please do. Thank you. Thank you so much, sir. Thanks, sir. I'll leave. So.
I think before you come to the topic, you need to tell them about National Quality Assurance Program. Ministry is doing a lot, maybe 5 minutes on that, and then you can come to the topic. Thank you.
I was thinking about that only.
Yes, yes. Thank you.
Thank you.
Ready?
Thank you. After a wonderful session, we are going to have another very interesting and important session on team building. Yesterday, we were discussing that in the health sector, which is a very complex organization, we have to work as a team, right from the specialist, super specialist, down to the nursing officer and other support staff. So for this, again, we have our eminent speaker. Sir has been formerly the director of the National Health System Resource Center, and lot of experience because at National Health System Resource Center, they have been involved in National Health Mission and also have focused on training program for various categories of people. So today in this session, perhaps sir is going to share some of his experiences, how to build a team, what are the difficulties, and how we can overcome those challenges for team building. So over to you, sir. Thank you.
Thank you, sir. Good morning, everyone. So before I come to the main topic, I must mention here about the National Quality Assurance Standards. We had a talk, excellent talk by Dr. Mahesh Verma sir regarding the NABH. So NABH is for the private health sector, and of course, and also all the government tertiary care hospitals. From Ayushman Arogya Mandir level, that is the sub-center level, PHC, CHC, district hospital, we have National Quality Assurance Standards. And these standards too are ISQA accredited. In fact, I take pride in the fact that the NHSRC manages NQAS, and the ISQA accredits the standards, the training, as well as certification process. All three accreditations are given to NQAS, whereas the training process of NABH is not accredited by ISQA, despite two visits of their teams. So that's where we score above, in fact, NABH as far as NQAS is concerned. NABH has maximum about 35,000 hospitals in the country to look forward. Only 16,000 were created and 4,000 were other certifications given. We have 2.09 lakh facilities in the country. An honorable PM last year especially lauded NQAS, but then gave NHSRC an added task that's certify accredited 50% of the facilities by December 25 and 10% by December 26. It's a very difficult process. We have 42,000 odd certified till date out of 2.09 lakhs. And we also have a self-assessment tool for the district hospitals. So up to from 50 bed to 500 bed hospitals, it's a software which is available. And all the guidelines are free. You don't have to buy anything. You don't have to pay any fees for any kind of certification. And even what the district hospital labs, which are earlier being certified by NABL, that is also being stopped now because we have come up with standards of integrated district public health labs and also block public health labs at the block part of block public health units under PMB at the block level. There are standards and NQAS for those also. 3 IPHL and 4 BPHLs have already been certified recently, just within the last 1 month, 1.5 months. So that's where, for all government facilities. Now, as the next step, what we convinced Government of India is, and we are making the NHRC is making the standards right now, about the district hospital getting converted to medical colleges. So all those medical colleges new which are coming up, we will have very soon. We'll have standards for those also under the NQAS. So it will be only tertiary care institutions and those other medical colleges which are already established. And but the new ones which are coming up, we are taking them in the ambit of NQAS again. And NQAS has got a lot of public health focus, which is not the NABH, of course, rightfully as per their terms, this thing that is restricted to the hospital building, whereas NQAS has got a public health focus as such. And anyone visited the part of CRM, Dr. Sanjay Pandey is here. He's part of CRM team, Common Review Mission. Anyone else also? I don't recollect. So please become part of a CRM team of the which is managed by NHRC and Ministry of Health, which is annual event where we go to 18 or 19 states in every year and see the facilities there. See the facilities and you'll find a difference between NQAS certified and non-NQAS certified. And similar procedures for 3 years. Every 3 years certification has to be redone. And there's a self-certification process, self-certification gap assessment, and then followed by state certification and national certification. So again, instead of entry level and all, we say self, state certification and national certification. So there are 3 levels as such which are there. So I'll stop here, but then I think—
I want you to spend 1 more minute on Kayakalp.
Sir,
All the central institutions are eligible, and the first prize is 5 crore rupees.
Yeah.
AIMS Delhi has got it. I don't know if any one of you. Tell us about
so
that.
that's a good point. Thank you, sir. In fact, because all of you, if you're working in these central government institutions or tertiary care institutions, Kayakalp is for both the all public health facilities up to DH level also, and also tertiary care. Up to DH level, it is managed by the states. States have their teams to do this. For the central, NHFW team is there, which is nominated by the central government, but we train those assessors who go on ground to assess the Kayakalp. And there are 8 major domains in Kayakalp, which includes quality and patient safety also, and the more focus on biomedical waste management. 8th one we added last year, 2 years ago, about the environmental management. So that's also again something which I think all of you must apply for Kayakalp and get certified under that. That will also make your facility, bring about sea change in your facility overall, and it's applicable for all. Under the NQAS, we have 8 areas of concern. Each area of concern has got standards. Each standard has got a list of measurable elements, and each of these measurable elements have got checkpoints. Okay, so it's a huge process. Both and Kayakalp is easier. Easier means assessment is easier, simplified. There are tools for that. Again, all those are available on our website, on an SRC website. You can read those and get involved in Kayakalp. Thank you, sir, for that. Yes, sir, right.
Thank you. I'm sorry I diverted from your topic.
No,
I thought it is important.
No. Thank you, sir. And what happened is that of course, there's a lot of learning from NABH because NQAS came up in 2013-14 only, and before that there were no defined guidelines. And to give a push to the maternal and neonatal safe reduction of MMR and neonatal mortality rate, the Lakshya standards were also released. So there are various names, and Muskan came up subsequently. Now we submitted a paper to the government, and the discussions have already started. to have just like NABH, the branding of NQAS instead of Lakshya Muskan separately, it will be NQAS as one entity only. So that will take some time, but that's also efforts are on to that. So coming to the, anyone wants to know further this thing about NQAS and all, we can have a discussion later over a cup of tea or see the website of NHSRC. All guidelines under QPS division are already there. When I joined, it used to be called as QI division, Quality Improvement Division. We then got it changed to Quality and Patient Safety to give focus to patient safety as also very, very important when we talk of quality, whenever we talk of quality. Okay, so coming to the today's talk, and it's a continuation from the last evening's talks of conflict management by Dr. Sood sir, and also what we all had a discussion about the negotiation, advocacy, collaboration. So, and as Dr. Sood sir also mentioned during his conflict team and showed some of the slides, that function of leaders to produce more leaders, not only followers. That's I think one of the important functions. And it's not about finding the next best. It's about recognizing and cultivating the potential in every person. So every person can be a leader. Every person, and you know, my learning is from the armed forces to a large extent. Of course, subsequently from the other organizations too. The mouse code. Yeah. So in armed forces, we have commanders at every level. Has anyone heard of this term? You would have thought brigade commander and all, isn't it? No, we have Langar commanders also. So he is a Langar commander. Even when in visiting GOC or Lieutenant General visits, so he also tells them, okay, Langar commander, can I enter your this thing? Can I enter your cookhouse? Okay, so that's the kind of culture which is there. So he's a Havaldar, but he is a Langar commander. He is a commander because he has got chefs and the other people under him. So at each level there's a section commander. We start from a platoon or section, platoon commander, section commander. There the company commanders, and then the commanding officers, officer commanding officers depending on the size of the unit. And then of course we have the brigade commanders and all. So if there's a commander from very beginning. So every man or every woman, every human being, wherever you are working, you are in charge of some area, and that leadership has to be there at every level. That's I think which is very, very important. So why and team building is part of the leadership part. So I'll just of course a lot of you have been discussing about leadership and all. My take on leadership is I'll just share two words instead of other jargon and all. It has to be empowering, and it has to be inspiring. These two words I think for a leader are very, very important. The rest all follows in the wake of this. So team building is definitely as part of a leader. Without team building, you won't be able to lead your team. So of course, these are the various benefits. 4.5 years I was in NHSRC, and 36 years prior to that, as I mentioned in the last evening also in the army, out of which 8 years I was in and out. But of course, that gave a huge different kind of experience to me, international as well as planning commission, erstwhile planning commission of Government of India, and also working in AIMS for almost 20 months and almost a year in JNU, not working as such, learning and also part of the various projects and all. So those experiences combined. So this is the organization which I led. And just like this, you see there are 8 technical divisions, each headed by an advisor. Just like this, all the hospitals and healthcare organizations are horizontal organizations. A leader can't say that I know more than anyone, because it's a horizontal. Everyone who's heading a particular team or a department is the best expert in his or her own right. So that's the kind of difference we have from various other organizations which are not in healthcare, where the leader may say that, okay, I know the maximum as compared to all of you. It's not the case. I can't, as a commandant of a hospital, when I commanded the Leh hospital, I couldn't have told a physician that I know more than you, or a surgeon, young surgeon or major, that I know more just because I was a brigadier. Similarly, a surgeon heading at AIMS or any tertiary care hospital, any INI, can't tell a physician or anyone else, or even a lot of other super specialist surgeons also. So that's where the team building and all comes up, and how you again think of the concepts of negotiation, advocacy, collaboration, and cooperation, and also the conflict management and leadership taken in that perspective. So anyway, this is the organization which is there, and the quality and patient safety division I already mentioned about. So this is the feedback which one of my advisor did in this activity last year, sorry, before the second talk of here which was there by NAMS only, unknown to me, and it was unlinked anonymous poll was there. So how the current generation, the younger generation thought about the leadership. So this was 2024 when it was asked. This is what the youngsters gave in writing. It is unlinked anonymous, and they were told that no, ED will not be informed about this. Is just be taking a poll. So that's the kind of the inputs which came. This is what the seniors wrote about. They were asked to compare the previous and the current incumbent. That is, I was there. Then no aspersions on previous incumbent, my just immediate predecessor. But then this is what the team, the leaders, there's 8 technical divisions. That time advisor was only in 7. So those what they wrote. This is what they wrote. But what is important is one is accessibility. Well versed in procedures. So your knowledge or competence is sine qua non administration as well as profession in whatever profession you are. Confidence, minimal red tapeism within your organization, clarity of thought, and meeting only for larger issues rather than calling meeting on every occasion. Systems approach, experimentation for the team, and also long-term vision and flexible working hours, which I mentioned earlier. I could do it in NHSRC, but that again depends on the context wherever you are. For the younger ones, saying as such that their opinion to be valued, and now as when you were talking of the younger generation who's becoming part of our workforce, they have very sensitive, a lot of sensitivities towards they being heard and their opinions being valued. So this we need to take, give more and more. Independence and support and guidance again has to be there more and more. So how can we empower our team? So there's just few key points. So autonomy, responsibility, accountability. Some of these words don't gel together as such as it is. You're giving autonomy, at the same time you're talking about the responsibility and accountability also. But whenever you're giving autonomy, you as a leader can't be going into laissez-faire attitude. We have various styles of leadership. We have various models of leadership. I am not going into that. Those are available in your reading material as well as on net. A lot of papers are available. I'm not discussing that theoretical background here. But with this, and of course, the slides will be shared with you. With this, then you read those various models, and then you decide for yourself what kind of model you would like to continue in your life, and also which ones work better at what stage, and how which ones can be mixed. Along with autonomy, you have to make them also responsible with certain outputs and outcomes, and also accountability also. That if it is not done, then what kind of actions will be taken? Not punishments, but their accountability so that they improve in future. Communication, of course, here has to be there, exemplary and of soft skills. So you're leading by example. That's another. That's repeatedly being said by everyone. And a culture of learning and development where everyone knows that yes, there's a new learning. It's not that they come in healthcare, especially. It's not that they come to the office and they do the same thing again and again. Some learning has to be there for them. And but I must share with you my first address as ED of NHSRC in 2021. There's all staff which we hold every month in NHSRC. So there I mentioned clearly after initial introductions and all, then I said that I know about all of your work and all. I've read about you all. But anyone who is working in NHSRC for 3 to 4 years and not getting a next promotion must look for avenues outside. And promotion NHSRC is not automatic. It is not like assistant to associate to professor depending on papers and your years of service. No. If a consultant has to become a senior consultant, he or she has to apply again. There'll be external candidates also. Again, there's a written test and interview process, and then only the selection takes place. So there's no guarantee that same person will continue. Same for lead, same for advisor. So at every stage, there has to be an open advertisement, and where anyone can apply, including internal candidates. And the board is one expert, public health expert, whom of course ED nominates. One is nominated by the Ministry of Health, and one third one is the advisor of the concerned division. So there's a lot of independence also for selection over there. So my advisors got annoyed with me. It was my first month only. So after that, all of them came to my office that this is not the way to tell the youngsters. ये सब छोड़ के चले जाएंगे, ऐसे कोई बात अगर if someone is in this kind of public health, in this kind of job, 3 to 4 years is a good enough time to, if you're not getting a higher this thing, you must go out. Otherwise, you start doing things by rote. So that's why in January this year, I told the ministry that, okay, I'll complete 4 years in March. They said, no, be there for 6 months more. Let us select someone new. So 4.5 years I completed September. I said, thank you very much. I'm going. So you select someone else so that some new ideas again come up instead of one person only continuing. So same thing. That's what I thought, and that's what I told, and it gave us a lot of good dividends. A lot of them went out for 2 years, came back also within my tenure, only at a higher post. So that's what happened, and that's how people improve. That's why they keep on reading. So just I think this I'm not going to repeat all this. You all know about it, but ethics, attitude, commitment, and all. So mentorship is very important. Whenever we are, because I was talking about autonomy and responsibility and all, and accountability, but you can't have that without mentorship. So mentorship has to be at every level. The juniors being mentored by immediate seniors and also by the top leadership also. And in that mentorship means rapport building and direction setting, and also progress, working environment, issues from the mentee perspective. And not only mentorship here, if you recall, yesterday I mentioned about the CHOs, community health officers, mid-level health provider. Earlier sub-centers had only one ANM. Sub-centers were open only 2 to 3 days in a week, only 3 to 4 hours, hardly any drugs diagnostics available. And ANM had to go do a lot of outfield work for ANC related and all, ANC and child health care. So with the community health officers, who is the nursing, 92% of currently those are nursing officers background, with the 6 months this bridge course, 500 hours minimum, and 8% are Ayush background. So there, what we realized that they need some kind of mentoring. So we started this mentorship program in 2022. And so mentorship is required everywhere, within organization as well as when you talk of outside also. So of course, that's a big health systems as such. The CHO is part of health systems. So anyone who needs support, mentoring has to be there, rather than off and on support that, okay, you do this, then we'll tell you whether you've done right or not. No, that's not the correct approach. So that's continuous mentoring has to be there, where mentor and mentee interact with each other. Inputs are taken from both. And mentees also give feedback on the mentors. That's part of ours. That's how we built in the CHO, this thing also, that they also give feedback. And of course, the autonomy and all I've already mentioned. Two-way mentoring I've already just mentioned as such. So there's a Herzberg's factors of motivation. What are the motivating factors? There are some inherent motivators as such. If you see the ASHA program in the country, they get an incentive. They don't get paid. And their job involves a lot of walking and all. Out of 10 lakh ASHAs, about 8.5 to 9 lakh, I can say very confidently, are they do the entire work self-motivated. There are one who are into politics and who are getting who want that they work only 3 to 4 hours a day. We did a lot of time motion studies. So a lot of the sample size, if I can extrapolate from that, the 10-12% are those who work 2.5 to 3 hours a day only, that to 4 to 5 days. There are majority who work 5 to 6 hours or more per day, and that is selfless service. So that motivation is inherent sometimes. But again, these are various factors that achievement recognition. So again, ASHA program also, that's why we said that states must start honoring them regularly to that achievement. Similarly, within the organization also, when you are leadership within your department or within your organization, achieve recognition. The work itself as such, when people enjoy the work. So that's why everyone, we should identify people who are ideal fit, not square pegs and round holes. It's the ideal fit which is required, where you enjoy the work. Responsibility. Even the junior most person, if you give the responsibility that, okay, you are responsible to get this done, a sense of responsibility comes up, and the outputs definitely improve. The advancement opportunities also, they feel that yes, if I do this thing, I learn something new, and tomorrow I can get to do a higher position or better position. And organization policies is the hygiene factors, what you can do. So those are something which are lot of inherent, but you can add on. Here it is your job, that overall policies, your administration supervision, how good is the organization. From the government perspective, I can talk about administration as such, like human resources for health in the health sector, especially in the government as such. one of the most, contentious issues as such, a lot of disgruntlements in human resource for health. So one of the states, Odisha, anyone from working in Odisha right now? Okay. So Odisha, what they did, we had a lot of discussions in 21, 22, and we had an excellent secretary health over there those days. So now anyone going to a remote posting, one is there's a hard area allowance. So she was asking me, and we discussed about, how army has the high altitude allowance and field area allowance, which are more, and as compared to the people working in peace, and some kind of guarantee that, okay, when you're coming out, you give 3 choices, within those 3 choices, you'll get a post, one of the posting. Now, when someone goes to remote areas in Odisha, one is the allowance. The second is next posting order after 3 years date is already given to him or her. That on so and so date you will be relieved and you will be posted to so and so place. So that's the kind of, the administration. So it's the governance and administration become actually are one of the most important factors. And you see building blocks of health systems, which you apply in your organization also. The governance and administration, the healthcare technology, everyone has the appropriate technology for health within your organization. Healthcare financing, adequate financing is available to every department in an equitable manner as per their requirements. The involvement, community process as we call it in the health system, same involvement of the entire community of your organization in all the discussions and all. Then again, relationship with supervisor, work conditions, personal life, work-life balance is there. There are a lot of proponents, like in NHRC, we didn't have work-life balance. That's there. But then there were different ways we could tell people. I started at, okay, we had only 135 sanctioned positions when I joined. Of course, a lot of external consultants and a lot of people who could hire on short-term consultancy and all. Total strength was 200 plus. When I left about a month ago, we had 300 plus permanent and plus other, this thing combined total is crossing 400 now. I said hire more people. We went to government to get more positions, hire more people. So if someone works over the weekend and someone works entire night because the document is required next morning, he or she is given one off in the next week. Or they can combine 2-3 off, combine with their leave and take it at the end of the month or whenever they want. So that's the kind of, so personal life, that's where at least then youngsters said that, okay, no problem. We have no problem working entire night because we know I'm going to get a compulsory off someday. I'm ready to work on holidays on Saturday, Sunday because I know I'll get an off somewhere next time. And with more people in every division, there of course more people are available. Someone is busy, really busy in some family commitments, then someone else can be given that work. Status and security, of course, salary and financial incentives, that whatever the best one can do in the delegation. So delegation is not only just saying that, okay, you do this, there has to be clear-cut roles and responsibilities, who will do what and what are expectations out of this. Start with small delegations to the people who join new along with mentorship. The errors. So errors and what was mentioned by NAB, by the previous speaker, and also NQAS also, what we mentioned very clearly, that the errors are not to be punished as such. It is a punishment culture for every error. And same thing comes in all of the work which we do. Then people will get scared. Because if anyone who doesn't work will never commit any error. People who work definitely commit errors. Of course, you as leader have to decide whether it's a deliberate error or it's a repeated error and all. That distinction has to come in. But unknown errors and unknowingly the errors which come up unknowingly, how to support and guide so that those don't get repeated and they learn from their mistakes. That kind of culture has to be there. People should not be scared of making mistakes. That okay, I've done this and it may or may not be good, and I'll get scolded if it is not made correctly. That kind of culture is not to be there. So review level of delegated authority. I'll mention here one important delegation. I became commandant of the Leh hospital in 2014 as a brigadier, and within 48 hours there was a closed head injury, and it came late in the evening. Of course, air evacuation is possible only in the mornings from Leh, maximum by afternoon. Otherwise, Air Force planes and all, generally the last flight was 11:30, 12, not after that. So I had a young surgeon who was recently posted from FMC after finishing his MS general surgery, and I asked him ki kiya. He said independently to nahi kiya, by role nahi kiya, because they said it might cone and all, the closed head injury. I had a maxillofacial surgeon So I called him. I said, you assist him. Otherwise, we'll lose a patient by morning waiting for the evacuation. They did that. First class, excellent outcome. Next day, I got a call from my MG Medical who was sitting in Udhampur. ये क्या कर दिया? Why have you got it done? Evacuate करना था. मैं कहा सर अगर patient मर जाता है, and I said I am running a 300-bed hospital with all the basic specialties. So what use of is there of my sitting here and my specialist sitting here if we have to wait for a closed head injury case to be evacuated next morning? Is any high altitude में surgery? I said सारी surgery करवाऊंगा till the time I am here. So delegation, so that I could tell it to him as to a major because I thought no, but more important is my job rather than telling him ki nahi sir, okay sir, I'll agree to you with you sir. So you have to sometimes disagree also. But my surgeons were happy that yes, that was delegated, that yes, you do it, go ahead with it. If anything responsible, I said, I told that major, I said, anything happens, you catch hold of me because I told them to do it. So that's the kind of delegation we need to give. And that same surgical team, after another week or so, there was a burst abdomen. And not Army, this is an ITBP guy. And there's the old shell which got burst, and the burst abdomen. The brigadier equivalent of the CAPF and all, ITBP and all everyone was there. Everyone said कि sir ये तो it's almost dead. तो इसका देख लो क्या करना है. Luckily during working hours everyone was there, and otherwise DMO used to have to call someone. And there's a 6-hour surgery they did on that patient in high altitude, standing at 11,000 feet, and that patient walked out of the hospital. So the then Home Minister, now Defense Minister, visited the hospital because it was message had already gone ki we have almost lost him. Okay. So he had just had a minimum feeble pulse and rest everything. Whether it was, we could have just started the IV and started this, but immediately moved to OT. Luckily, I had 2 anesthetists this thing because one was always used to be on TD2 Glacier and all that they both were there. So that, and of course, this is just a beginning. Then we started managing. So I said no, we will not be in a culture of transferring patients next day. We'll manage all here only. We will not transfer unless until there's something seriously this thing, otherwise we'll manage it. So that's the kind of delegation you have to give to people that, okay, we have trust in your abilities. Similarly, in your area, wherever you are, that this thing, and same NHRC also, we used to tell the youngsters, okay, prepare this document which has to go to ministry. Or even simple thing like parliament question. Parliament question is not simple. Parliament question is very, very serious actually, not simple. I take back my word for this thing because it is vetted by the minister, and then it goes to stay in parliament. So that answering of that, and also any kind of document or guidelines which are made, start from the youngsters. Let them make errors in writing or this thing and all, guide them. And there are various levels of checks and balances as such over there. So that's what I've written in the last one, adjust as per the progress, development and organizational needs of all this thing. And feedback. It has to be plain and simple, constructive, not abusive and all कि तुम कुछ नहीं करते तो कोई काम नहीं करते और यहाँ सिर्फ बोल दो बहुत बढ़िया किया है. No. Even that, but this is very important, and I'll say yesterday, or Dr. Sood also mentioned yesterday, and in public when it's positive, and in private when it is a negative feedback. But again, both has to be very, very specific and consider that you have done this. This is what your excellence has shown. This is where dedication has shown. This is because you were competent enough so you could do it, and that's why it has come up with. Or when it is negative, these are this thing, but with your experience and expertise, you could have done this. So along with negative, you should also give that in future, this is what is expected from you, or this was expected from you, that's why the job was given. That's the kind of feedback which is required in all of our interactions with our team or such. And of course, as leader, you should also be open to receive feedback always. Again, this is, I repeat, I will just quickly go through it. Conflict resolution, TK model, which is there. So collaborating, coming back to both the yesterday's 2 presentations, is a combination of those 2. So that's what, it is there. Instead of competing, instead of compromising, avoiding, accommodating. A lot of time we try to compromise. Okay, ठीक है, कोई ठीक से नहीं सुन रहा, तो कोई बात नहीं, छोड़ दो, or avoid. No. As leader, then it's not a long-term sustainability. You can do it for a few months. ठीक है, मैं तो छोड़ दो, देखता हूँ. That laissez-faire attitude when it comes, and the leader, you lose your grip on leadership and you lose your grip on the entire organization. So that collaborating one which is there. So leaders' own emotional intelligence is very important. You should be self-aware, you should be self-regulating. It's not that you say that I am leader no one, is checking me or no one is seeing me. So I can continue with the way I want. That kind of self-regulation is there. And change management. So any newer things which are there, how to manage those, how to get those things done. It very crucial for the entire health system, but also within the organizations also. A lot of changes, expansions take place, a lot of changes take place as healthcare evolves. That change management becomes very important. How your own self-motivation and social skills, definitely. So that's why, because of my social skills only, when the previous speaker was talking that Ayushman Arogya Mandir NABH was done, I kept quiet sitting over there. I said, no, I'll talk later. And even if he had been sitting here, I would have spoken from here in a different way. Ayushman Arogya Mandirs are done by NQAS, not by NABH. Okay, even including PHC sub-centers, PHC, CHC, DH, all are done by NQAS, not by NABH. Okay, and one more thing, yes. PMJ gives a gold certificate and also IRDA gives a gold certificate, equivalence of NABH as well as NQAS. Any facility which is certified by NQAS also gets the same incentive what is given at the any facility which is NABH certified. A lot of private hospitals come to us, to NSRC, that give us NQAS certification, but NSRC doesn't have the bandwidth, doesn't have adequate number of the assessors, because 2.09 lakh pehle wo kar lein apna public health wala, then it's the private later on. Yeah. No, 15% only, whether it's NABH or NQAS, anyone. So no. And both certification no one actually needs also. You are either NQAS or NABH. So what I wanted to convey was that it is not below NABH. NQAS is same. Rather, we are one up as far as our training is concerned. Great.
On this, I just want to make a comment.
Sir, please.
Remember, I was on field visit to Tamil Nadu, and we visited a district hospital, and they were all worried, sir. National quality assurance done by private sector, they came, and we have a budget of 3.5 crore. We have to redo the OT, we have to redo all the floors. And then they didn't know about it. It was when NQAS had just started, and they didn't know about this. I said, no, why don't you take up through NHSRC? And they were very happy. Within 3 months, they completed the task. It was done at almost no cost. So keep in mind what is the difference. Because if you're only focused on flooring and walls, then civil work is very expensive. So keep both these in mind in your work if you want to meet national standard. NQAS is national standard and connected with ISQA, international body. So just wanted to comment.
Thank you. So is the leadership challenging or easy? I'll come to the likely challenges first. There's a clarity and alignment. So your own clarity to your vision and mission of your organization, alignment with those, and also the objectives which you have set for yourself as a leader. So everywhere where you are leading the department or the organization, institution, or even any kind of body, you have to have written kind of your own clarity and for your own alignment and accountability. How to build accountability by the team. So and similar kind of clarity and alignment of the team also. Once you are very clear, then you will be able to clearly convey to your entire team that this is what is required, these are the objectives, and this is how accountability is being built. So there's no punishment culture, but accountability has to be there. So that accountability, and that can be linked with various promotion or other kind of incentives or disincentives. Feedback, we have already discussed. Performance measurement, we have APAR, ACRs in the army, and civil it is APARs. But along with that, now it is time that there are certain kind of other performance measurements are also there, like Donabedian model of quality, which Dr. Mahesh Sharma mentioned, which we also use, structure, process, and outputs and outcomes. Similar kind of thing you can look at in your own organization also. So it becomes an year-round performance measurement, not as a Damocles sword hanging over everyone's head, but at a quarterly or any kind of event and all, you can make that, okay, these are the indicators where performance is being assessed or measured, which will then help in the APAR also annually. Delegation, I think we have discussed earlier, but there are certain people who resist any kind of change, who resist any kind of accountability and all. How to deal with that? I'll come to it later on. Empowerment, again, circle of safety, which there's a book also by this. I'll give you a reference of that. Very interesting to read. So that circle of safety is there. Coming to this again, accountability and delegation and all, that they know that, okay, we have confidence that within whatever we are doing, we will not be, there no punishment and all will be there. We'll be mentored and we'll be supported for our future growth. That kind of circle of safety has to be created. A lot of time that resistance and readiness to accept all this comes from either individual fear, again blaming or persecution, probably their previous experience, or thinking that, okay, maybe we blamed if we commit any errors, or it can be organization also. Lot of people question delegation. So the example which I gave you fits in here again, that my MG might want to question my own delegation, that why have you done this? Okay. So of course, same one came and visited and all and rated me very high subsequently, and also army commander also visited. That's different game story altogether. So your own superiors sitting somewhere else may question your delegation. How to now employ your negotiation advocacy skills to convince them that no, this is what I am doing and this is what will benefit. Similarly, even for a director of AIMS or director of any institution, Ministry of Health, they may also question that what is being done, or even the president. So again, how to convince them and all that is your responsibility as a leader. So your own chintan or self-exploration, that are we a team? Are we a good team? Are we an effective team? Is it why isn't our team performing? And am I doing? And is it being those not ready to empowered or part of that? I'll come to these. First one is, are we a team? What makes a team? So this, which one is a team and which one is a group? Anyone? This one is a team? Okay. Okay. Yeah. Yes. Okay. So I think this is it. So this again, similarly from collaboration as such, a team is committed to a common purpose. They are interdependent with each other, and the complementary skills and shared leadership roles. So, in fact, over the years, I have seen when I was a young officer, a lot of time, a lot of conferences in our hospitals or even FMC and all. One department's conference used to be organized by that particular department only. But nowadays, every conference, other faculty members from other departments are also part of that organizing committee. So that kind of team building has started, I think, two decades ago. In the previous century, till 97, 98 and all, it was a single department only, that you do your own, no one else is helping you. But that things have changed now. That's just one example which come to my mind just now. So that kind of team building has to be there, similar in all activities. So every department's function has to, other people also get involved. Not only as an independent member of finances only, but also in the entire organizing committee as such. So just for the team building, I'll just share one example with you, that in 86, I was in Dras. Dras that time was unknown to everyone. Now, after the Kargil war, people have come to know where Dras is. And so it's the world's second coldest inhabited place. Altitude is only 10,000 feet above mean sea level. But because of the wind chill factor and all the location in a bowl as such, I have seen minus 52 degrees centigrades, not Fahrenheit, but centigrades. Minus 55 was the actual one, but that year when I was there, it was minus 52 degrees centigrade. So one convoy got struck in at Jazila Pass in November, the last convoy of that season. So a sudden snowfall of 36 feet over within a day or so, about 18-20 hours. There was no major or other youngsters of the infantry unit over there, only CO and myself and one officer from service ASC attached, and he used to wear a cervical collar. That means he was physically unfit as such even at that young age. Others had gone to lay for an exam and all, and majors were there commanding their own companies at various heights. You all know the Tololing and Pathar and Latok Aksar, all those X's and all. So I was given the responsibility, okay, you lead the patrol also, and I was a captain, young captain of the medical corps. We were never taught patrolling and all. So that's my first patrol. So how to, get that entire team together. So I had the 2 JCOs, junior commissioned officers, and 16 other people. We total 18 plus my buddy volunteers, 19. So that experience taught me how to lead a team, how to build a team. 6 to 7 feet of fresh snow, you can't walk. Your foot keeps going down till it freezes somewhere and you stop and then you lift up your leg and go with it. So they told me कि साहब आप end में आओ हम रास्ता बनाएंगे. I said नहीं. Everyone will lead on its own. So I said I will start. So 150 meters and all, you can't move beyond that. So after that, the leader used to be on one side, then the second man takes over. Okay. And he comes in the end so that he gets the freshly paved paths. So that's the way you walk over there. Okay. Then we early morning and all, when the next day the sunrise and also there. That time there's a small avalanche also. How that time I got the team together. Then over there in 8 days we evacuated people, and to evacuate people through helicopters and also get the dead bodies from the captain's ward and all that to come back and again then get them evacuated. That needs a lot of effort to build a team, and that really gave me an experience and insight into how to build a team and lead a team over there. So are we a good team? What makes a balanced team? There's a shared vision, of course. I think these are all repetitions of what we already discussed. Every member complements the strengths and emotionally bonded with each other. Certain do's and don'ts: appreciate, accept, acknowledge availability, accessibility. There's an open door policy. I think there's some discussion yesterday. I have followed open door policy in the army as well as in the civil. That's for 4.5 years at NHRC also. I have followed an open door policy. Anyone can walk in any time. Of course, it many times affect your own thinking and all. NHRC, this thing was very clear, open door. This thing, Saturdays I used to go to my office when other team members are not there. So at my own thinking process, other work and all, I can do the entire Saturday and work over there, work there. And of course, the criticism, complaint and condemnation, this you don't do to each other. Efficient and effective teams. So are we getting the quality work done? There's just a aside, you can read it later on also. It's not a missing. So alignment in thought processes and vision, that's collective approach and motivation, ability to work on behalf of the team as a leader. Effective processes. So instead of the top-down approach, it has to be a balanced one where you listen to everyone. The coordination, communication, channel of flow, adaptability. In times of crisis, instead of losing your temper, instead of shouting at everyone, that's where again you're organizing an event of a very high grade and some kind of problem comes up. That's a time when if the leader starts shouting and screaming and telling, oh, you have not even done this, you've not done this, that's where you lose your respect of your team. So that's the crisis tells your team how effective a leader you are and how efficient a leader you are, how you handle that crisis, how you manage those crises. So again, I've already shared these experiences earlier. How to empower those who resist. This I think was discussed earlier yesterday too. So I had one officer, this thing. In fact, in my career, 2 were there. One was when a young age when I was officer commanding a health organization in Ramgarh, Kent, now in Jharkhand, and another one was in Leh. But generally, otherwise, I've been lucky to get very cooperative teams as such. Army somehow is because of the army orders and all, Army Act and all. A lot of that, but sometimes you get certain kind of people. So I had one officer who was the logistics officer of the thing, and he was one which I can use the word of rogue. He was a rogue. He knew the rules and regulations, intelligent, very sharp, but always working against the organization, to the detriment of the organization. And the logistics and all have got access to a lot of the funds, fund management, and they attend a lot of meetings also on behalf of the head of the organizations in the station. So they're talking about the organization and also making snide remarks and all. So how I started handling him is first identify the source of resistance, what was there. Then I started discussing with him, talking to him. And then I started getting the feedback from that, okay, you tell me that you say that hospital, this is not right or this is not right. You tell me of each department, what is not right. You tell. Then I'll come to your department subsequently. So that's how gradually, and there's a time, in fact, eventually at one stage, he told me that, sir, you keep on, telling me to do my work like this or that. So I'm putting on my papers for release. I said, no problem. But think about your family and all, you're going as less than 20 years of service, you will not even get pension. You are a major only right now. Today he's a full colonel in Delhi only, and he comes and meets me regularly. So that's how you get to involve people who are left-handed. I could have left him, and as in army, that's the power. In fact, in civil, many times you don't have. I had the power. I could have nominated any of my medical officers there to do the logistics, and I told him, thank you very much. You just sit in your office. I had that power, but no, I didn't utilize it. Okay, I said no. I will get work from him only. And that same officer subsequently did wonders for the organization, which we got the Army Commander's citation also for the hospital. And so that's how, and also whatever he did, rewarded him and celebrated that, okay, this is what extra work has been done. And of course, my own leadership style and all also, so own leadership you have to adapt from time to identify those who are reluctant or don't want to work or work against the organization. Again, what are the challenges, barriers and challenges? These are the various ones. So, but if you are, an effective and efficient leader, you will address all these, the mistrust, the conflicts, the hidden conflicts, lack of autonomy, I already mentioned, rigidity. Again, as a leader, you can't be rigid and can't have same approach with everyone. And you can't be rigid also that, okay, no, what I have said is right. This everyone says is this thing. And again, hidden agendas of others, that also you need to understand. And employee retention, leadership bias is also there. So your own competence, communication within the organization and also with the outside world, and also responsibilities. So this my first wave, COVID wave, when MG made this thing, that was a very. I had 10 big hospitals and I had 18 field hospitals in the entire command area. None of them were prepared for COVID. So, but then on 9th of March, I presented to my army commander and everyone that this is the possible scenarios which we are going to have in 2020. And based on that, we started working. By May, we had 2 of the hospitals with the RT-PCR labs because I could convince my DG. I requested the ICMR DG also that time. And one of the machines, 2 machines were, shifted from somewhere else. So to that region because we didn't have anything in Rajasthan. And I was in Rajasthan, Haryana, Punjab, some units in Jharkhand also, scattered almost all over. And so then we started, hospitals, buildings were good, so we could convert them into the various thing, isolation and all. And so that's a kind of, experience which gives, and that's where the leadership again comes in, and the support which I got from my own leadership. And I'll share with you. The army commander is equivalent to a secretary to the government of India, and army commander has got huge powers as such within own command. And they generally, for medical is just support, but in COVID they realized the importance. And I was in Bathinda one night in the month of April only. So I got a message that Army Command want to speak to you. We got connected. He says, what are you doing in Bathinda? I said, I traveled today. I visited the hospital in the evening. Tomorrow again, I'm in a meeting. Then I'm meeting the corps commander also here. And tomorrow, then I'll start. I'll stop in Hisar and come back. He says, no, my MG Med can't be out of Jaipur for any night because of the COVID. So in future, you will take my helicopter wherever you go. That's why that photograph earlier in the previous one. So wherever I had to go, I had to leave early morning in the helicopter, do my entire work and come back at night, back to Jaipur. Okay. So that's the army commanders, that's his leadership. That no, I need MG Med for all support and all. So you go in the morning, come back, do your work and come back. So that you are here and you're available for all, because that was a very dynamic situation that time. And armed forces were under a lot of stress as such, and working with the civil also. So for even for creation of the isolation quarantine centers and all. So that's leadership which tells you that Army Command realizes the importance of the medical advice and the medical setup. He said your Colonel Health or I had brigadiers also with me, 2 brigadiers. I said they can stay overnight. They take them along. Let one of them stay. You do give the entire for entire day. You come back. They can come back next day. So, and supportive supervision and availability and all, and this we already, I think, discussed. But again, micromanaging, that's something which is, my first posting as a specialist in Allahabad, I was the Assistant Director Health of FORDIV. So there's a full colonel, I was a major, no, I was still a captain. I did my MD immediately, I think. So, very first day he said, and talking of 1992, he said, make guidelines on obesity. Obesity that time people had not started thinking about. So I said, okay. I was fresh, MD. I said, so he says, kitne din mein bana loge? Along with all the other work. I said, by tomorrow. He says, acha. So he went for one meeting. I was working in my office, and then after that was his office toward the end of the corridor. So after coming back from the meeting, he again peeped in my office. "Wo bana rahe ho na?" So every time when a senior officer peeped in the office, you go to stand up. I said, "Yes, sir, bana raha." Plus, a lot of other work was also going on, and I had just joined. I was looking at my area. I had 3 brigades scattered in Allahabad, now Ayodhya, that time Faizabad, Lucknow, and also the health cover of all that, and working with the field hospitals and all. So another meeting after a few hours, he was going somewhere downside to meet GOC and all. While going again, asked me. While coming again, he asked me. So that's it. I really got irritated. So 4th time, I want to tell him, "Sir, kal tak bola hai, ban jayenge." But then I controlled myself. Okay, that micromanaging should not be done. Once you have given a task, you have given a clear task. You also ask that in case of any help you need, I am here, and you need any discussion now or subsequently. Once it has been decided and a timeline has been given to you as a senior officer that okay, at this time you will get it. I don't think you should be doing micromanaging. That leads to lack of that people come to know that okay, people don't have faith in you. So that again is the leadership's sign. But that's a good learning for me that yes, I should not be doing it later on subsequently when I'm in this position. There's a few important suggested reading as I mentioned earlier. Malcolm Gladwell actually this book, not only on the others, Leaders Eat Last by Simon Sinek, and also 5 Dysfunctional of a Team by Patrick this thing. But Simon Sinek talks about the the circle of safety, which is very, very interesting as such. So thank you very much for a patient listening. Any questions on all?
Thank you, sir, for covering this topic very comprehensively and sharing your experience as executive director as well as in the army. So thank you so much. You have made this presentation very clear, and I think the key points message we have taken. But since the next speaker has come, I will request only 1 or 2 quick remarks or queries on this presentation. Yes, sir, please go ahead.
Style of management.
Yeah, even in military, I didn't go for military style management. See, in the armed forces is the arms and services, and in services also the medical corps is unique. So that's what I mentioned. Ours is a horizontal organization despite being in services. Infantry CEO can tell a youngster that I got commissioned, I did NDA so and so, and I have done all these courses which you'll be doing over the next 20 years. I know much more than you today's date. Okay, and in medical corps we can't do like that. So similarly, I followed that only. But yes, in army you are wearing your uniform. The discipline is there. So I'll share another example with you. As an MG Med, when I went to Jaipur. First 2 meetings, whatever we discussed, I had 2 brigadiers, 3 colonels, 2 lieutenant colonels, and my commandant of the hospital, nearest one also, I used to call him for meeting. And first, so they got surprised, my own core team, that why are you calling him brigadier of the Jaipur hospital? I said, he's next door commandant. There are other commandants of other hospitals and also I can't keep calling them otherwise. But let him also discuss and know about these. And so for everything, it was yes. At the end of second meeting, I told them that next weekly meeting, if for everything there's a yes, then I don't need any one of you. Then I can do whatever I want, because whatever proposal I'm saying, whatever I'm thinking that we need to do work like this to improve the health situation in the entire command and this thing. So then I don't need because I'm not getting any input from you. And that changed that thing. From next time onward, I started getting inputs from them. Then the discussion started taking place. So that's the kind of leadership I think you must inculcate, one must have, instead of only didactic kind of directionless.
And then the team diagram, it showed a chaotic kind of this thing, don't we need hierarchy also?
Hierarchy you already established. So see, that's what it's not that democratic means that anyone can say anything. It has to be to the point, to the specific point, and also valid, cogent replies. Okay. If someone starts talking something else, then as a leader, again, it's your responsibility. You got to show your leadership also some places. Yes. And I have shown that also. I'll give an example. There's a gynecologist, there's a maternal mortality, which is very, very rare, even in the army as such. Our figures are much, much lower than the actual maternal mortality MMR of the country. So one case, and I gave counseling, and I wanted her to be marched up to me. So she was on leave, which I didn't know. The commandant told her, and she just came in a casual salwar kameez and entered my office. So I checked her out. I said, no, get out of my office. So you got to show your leadership also that no, even you're democratic. They know that you're accessible, you're approachable. But no, this is a formal matter. You have to come in uniform. You will be marched in by my stick orderly who's in uniform outside in a proper process. She used to be a resident in FMC when I was faculty. So she thought I can take that liberty and all, and I can walk into the maid's office and he's, meets in the evening also and also, okay, that's okay. But no, that's where that hierarchy has to be clear. But that hierarchy, if I tell her in the evening, no, you are a colonel, you were a resident when I was faculty, okay, that time I spoke to you, you're a colonel now, but I am major, I will not speak to you. No, in gym and all and parties, you need to speak to everyone. But in office, such kind of disciplining matter, the hierarchy has to be.
Thank you so much, sir.
Micromanagement.
Please speak into the mic. We don't know what you are asking so that we all can benefit.
Sir, my
Thank you.
question about the micromanagement. Yes, I think so frequent micromanagement not required as in your case, but totally, I think it's somewhere it is required so that you can remind the people to whom you have assigned the task so that it can be done in time.
Okay.
Monitor.
So I'll in fact I mentioned there only that once initially when you're giving any task, you need to be very clear in your mind, or rather after the meeting with the team, everyone should be clear in their mind that what are the timelines, what are the tasks with each of the timeline, and then you manage as per those timelines only. So if you have said that okay, this document or this work has to be done by tomorrow after 24 hours, then don't ask before 24 hours.
Yes, sir.
Okay,
Yes.
that is there.
Yes.
So all that PERT and other CPM, other models of management, please see those also. See what is the critical paths, which is the most crucial step in a completion of any project. See how you want to manage it. So that depends on you. But micromanaging again will not lead to much of result. But if micro, rather I'll say stage-wise management, the predefined stage and timings, that will be definitely effective.
Okay, thank you, sir.
Thank you, sir. Thank you so much for your support and blessing to the National Accountant. And we look forward for your blessing in future also, sir. Thank you so much, sir.
We don't want snacks, we want break. Break is going outside, snack is. So, मुझे तो yes. Yeah, carefully, yes, you want.
Friends then.
Yeah. For 2 years.
Okay, now we have another very interesting session on legal aspect in hospital. And I must say that this is a session where maximum questions are asked from the participant. And for this, we have Professor Siddharth Satpathy, sir. He is the head of the hospital administration department in AIIMS, New Delhi. And he has vast experience of more than 2.5 decades at AIIMS. And he has authored several textbooks on hospital planning and management, and also on management of waste in the hospital setting. More than 75 scientific articles published in national and international journals related to hospital administration. And he has served as a very important member of several committees related to accreditation, NABH, and also he has been the guest faculty. Again, he is coming to NAMS, helping us, as well as to other institutions like NHFW, AFMC, and Sanjay Gandhi PGI, and so on and so forth. So he has a vast experience, especially on the legal aspect of the hospital. And sir, we are really grateful to you for your time and support to us. Over to you, sir. Thank you, sir.
So can I have the slides, please? So there are a couple of caveats that I want your. I'll be just walking around. So there are a couple of caveats. First is that I'm not a lawyer. I am a doctor just like you, and so whatever I'll be speaking today about legal issues in healthcare, you have to take it with a little bit of pinch of salt, right? I'll try to make it, explain it in a non legal language, because sometimes what we find is that the legal language becomes quite tortuous and it becomes very difficult for people to understand. So my email ID is there in case any one of you wishes to correspond with me about the presentation or about any issue that you may be facing. So So basically, hospitals are very, very complex organizations. And why I say they are complex organizations is because they are complex with regard to the manpower, with regard to the equipment, with regard to the processes, with regard to the departments, and with regard to almost everything, right? The Constitution of India is the fundamental law. We must never forget that, because that is the source of all our law-making processes, of our law-making institutions, and those, authorities or those positions which have all been mentioned in the Constitution. So how do we get connected with the Constitution? We get connected through what is called the fundamental rights, right? So the fundamental rights and health are inextricably intertwined, especially Article 21, that is protection of life and personal liberty. Unlike other countries, India does not have a right to health. The right to health is under the right to life. That is Article 21 of the Constitution. There are many judgments on that. So wherever you will find, whatever quotations are there in italics and in red, they are basically the judgments that I have quoted from the Supreme Court or the High Court or other, courts, which you can also refer to and, go back and see. The second thing in the Constitution where we are concerned and the government also is concerned are the directive principles of health policy. That is Article 37, 38, 39 and 47. They cast an obligation to take care of the health of the population on the government of India. And when I say government of India, I am not referring here only to the central government, but also to the state governments. And health being a state subject, when I say a state subject, the Constitution has three lists, as many of you would know. We have what is called a central list, we have a state list, and we have a concurrent list. So the respective, governments can enact legislations depending on the subjects which are there in those particular lists. So health is in the state list, and you will find later on in this slide that there are many state governments which have actually enacted laws with regard to the healthcare institutions in their respective states, but not all of them. Some of them have, some of them have. Okay. And knowledge of the salient acts, rules and regulations is now and gradually in the future becoming more and more essential. You might have read in the newspapers recently about, Dr. Bisoi's case at All India Institute of Medical Sciences. As I speak, the FAMES authorities, FAMES executive has, passed a diktat, or you can say in the GBM that, we will all protest this because of, certain procedural issues not being followed. So law is becoming more and more important, especially for administrators. Coming to definitions very quickly, legislation is a system of rules usually enforced through a set of institutions. Okay. And it affects everyday life and society in a variety of ways. There are different authors which give different classifications of the laws, but the most commonest one would classify them into four categories. First are the statutory laws. That means the laws which are passed by either the state government or the central government. And the second are what is called the regulatory laws. So broadly, these would be divided into two categories, that is the civil law and the criminal law. Criminal law is against the society, where the state, takes the responsibility to punish the person. And the civil laws are between two individuals. The fourth category is what is called common law. And this is based on judicial precedents and the decisions of the Supreme Court and the High Courts. So India was ruled by Britishers for a long period of time, and because of this colonial legacy that we have, it has been said by the Supreme Court way back in 1950 that the courts in India will follow what is called the English common. And English common law is not written.
Case laws.
Case laws are also part of the common law, right? So these are the three, four categories that we need to keep in mind. Let us look at the legal landscape in India. So suppose, now we have a lot of, national law universities. And, they classify basically the entire legal system into 7 or 8, categories. That is constitutional law, criminal law, civil laws, jurisprudence, judicial authorities, and the quasi-judicial mechanisms, which are basically the, the commissions that are there. Okay. Archaic laws are still there in India, despite the government, making some, efforts to, remove a lot of them. Many of the archaic laws still, are there. The process of law making again is being questioned in the recent past, because many times laws are being passed and then you will find a large number of amendments to those laws, because probably at the time of passing the laws enough amount of discussions have not taken place. They have not been referred to parliamentary committees. There is a lack of consensus building and such issues. Coming from the general laws to medical malpractice cases, there are 5.2 million cases, as per the recent reports which are there. Pendency in the courts is around 5 crores. And this is a parliament question in Rajya Sabha this year only. And it says that there are 5,500 plus vacancies in the various lower courts and 33% vacancies of justices in the high courts, right? There is a very serious and critical need for judicial and police reforms in the country. Unfortunately, I would say that not much effort has gone in that direction. Some tidbit things have happened, not much, and there is a perceived or actual interference in each other's areas. Democracy operates on 3 pillars, the 4th pillar being the media. And there is, this perception that each one of the pillars is, interfering in the activities of the others. And this feeling is mutual. Coming to the hospitals, all hospital standards in India, whether it is NABH or JCI or NCOS or whatever the case may be, all of them mandate that all the statutory provisions, about 100 of them, give or take a few, must be, complied with before the accreditation is possible of that particular hospital. With this, broad classification of laws, I've just, taken this slide from the net. So if you see, there are 2 broad categories, international law and national law. In the international law, there will be public international law and private international law, which is also called the conflict of laws. In national law, you will have public law as well as private law, and they can be further, classified, as I said, administrative, criminal, civil, then law of contract and law of torts. Indian Penal Code has now been changed. We will see it in a slide. And private law in India, again, is Hindu law and the Muslim law. Why is this important? Without knowledge of applicable laws, we are ill prepared to handle certain issues with legal connotations, and decisions taken with the best of intentions may be rendered invalid if they do not conform to the law of the land. A reversal of the decision through judicial process shows management in poor light and also erodes the credibility of the management, and the affected party may walk tall. They may challenge the superiors. They can subvert the discipline in the organization. You must have all, experienced. Some people go to the CAT, get a reversal of the judgment, and then they walk, choda ho ke ki bhai ab kya kar loge dekhte hain, right? So that's why for the administration in the organization, it is important that we know about the laws. Now, this slide again is a slide which tells us about the broad categories or classifications of laws governing the functioning of the hospital. The first is laws governing the functioning of the hospital. Second is educational qualification, practice and conduct of professionals. So 8 broad categories. What I will do is over the next 40-45 minutes, I'll try to touch upon the important things in each of the categories. It is not possible physically to concise or, in a single lecture to cover all the laws in detail, right? So let us see each one of them. First is laws on hospital functioning. So the ownership of the hospital is very, very important because it is covered under the Societies Registration Act or the Companies Act or the AIMS Act in case of All India Institute of Medical Sciences and PGI and many others like SGPGI, IGIMS, Nizam's Institute, the Sher Kashmir Institute, many of these, institutes were actually enacted through an act of the parliament or the respective state government on the lines of AIMS. 1956 AIMS was set up, and on the same lines, many of these institutions were set up. Public hospitals, the ownership is either the government or the concerned act, rules and regulations. All three of them are important. They operate first at the level of the act, second at the level of the rules, and third at the level of the regulations. The distinction being, rules are generally made by the government, act is framed by the parliament or the state government, and regulations are made by the concerned organization. Coming to hospital buildings, that is the National Building Code. So you have the NBC 2016, which is the latest National Building Code. And recently, this year only, there was something on the WhatsApp saying that this is not a mandatory code and government issued a circular, which I think probably, it may be right from a legal point of view, but at the ground level, it can create issues, right? So we'll come to that as well. Then you have fire safety, then you have Electricity Act and the rules framed there under the Lift License, Lift and Escalators Act, the respective hospital, nursing home or establishment registration. So each of the hospitals, in the different states which have enacted legislations are first, they have to be seen in the light of that particular act, as you will see, subsequently. So this is the circular that I was, referring to, which says that the National Building Code is voluntary in nature and it is not mandatory to be followed. We have had instances of bridges collapsing in the last couple of years, 3 or 4 of them in the country. We have had issues of, buildings collapsing, some residential areas also, buildings, in the NCR as well as other places. So I don't know whether, what effect this is going to have, but this clearly says that it is not a codal provision and it is not mandatory, it is recommendatory in nature. So this is again an issue which, I think we need to know about. These are the salient state legislations that I was telling you about, right from 1949 till 2007. In these states, the establishments or the nursing homes will be first, managed through this act. Whenever there is a problem or the matter goes to the judiciary, they will invoke the provisions of this act to examine the matter. Okay. Coming to educational qualification, practice and conduct, these are some of the, acts, rules which are required. So the Indian Medical Council Act, the Professional Conduct, Etiquette and Ethics Regulations of 2002, 2009, 2003 was enacted and then again put on hold because there was a lot of, pressure from the NMC and the Indian Medical Association and others. The National Medical Commission Act of 2019, the Indian Nursing Council Act of 1947, Dentist Act, the Pharmacy Act and the Paramedical Council Act, and recently the, Healthcare Allied Professionals Act as well. The third category is again not that much in the domain of other clinical, specialties, but more in the domain of hospital administration and the drug selection committee or whatever committee you may be having in the hospital. So this deals with safety, storage and sale of drugs, the Drugs and Cosmetics Act, the Drug Control Act, the Narcotic Drugs and Psychotropic. I am just telling the names here because these names should be familiar to you, because once in a while you will come across some case or something where it will fall under this act. And when it falls under that act, it is not physically possible for any doctor or any person to remember everything. That's why lawyers' chambers have, the whole wall lined with, books and judgments. That is because it's not humanly possible, right? So whenever a case comes up, you need to look up that particular thing. That is all available in the internet as well. Then sale of drugs, the retail drug license, CST, VAT, of course, not gone. The GST Act has been, replaced the other tax regimes. This is again, the GFR, which is very important for the entire hospital and the administration and hospital administration, because the entire procurement, which is about 40% of your total budget, and all that is covered under the GFR by and large, right? So coming to management of patients, Births, Deaths and Marriage Registration Act of 1969, the Epidemic Diseases Act, which was invoked during the COVID pandemic. The Indian Contract Act is important. Section 13 deals with consent. The entire, whenever there is a matter which goes to a court of law and it pertains to consent, the court will look at the Indian Contract Act and then see whether it is meeting that or it is not meeting. The Mental Health Act, which was amended in 2017, the MTP Act, which was amended in 2021, the Transplantation of Human Organs Act, the PCPNDT Act and rules, all these are important from the management of patients' point of view. We'll see some of them little briefly. So this is the Mental Health Care Act of 2017. It says that the mental health patients will be treated on the same lines as those which are having physical health issues, right? It also says that, somebody who's committing suicide because of a mental health problem, there can be no criminal case which can be initiated against this person. The third thing which was amended is that if there is a mentally, mental health patient is a mother and has a, small baby, the baby will not be, separated from the mother. So 3-4 main things, and all drugs and medications will be provided by the state just as it is being done for the other patients. So these are the 4 or 5 main, amendments which were done in 2017. Poor people must get free treatment, and then free medicines for mental illnesses should be provided at all government facilities. The MTP Act 2021 amendments, most of you would be aware because it is now 4 years and a lot of cases have happened. So main things is that the ambit of the act covers unmarried women also. The gestational age limit for the fetus has been increased from 20 to 24 weeks and beyond 24 weeks. Once in a while, we get very interesting cases which we try to cover in our departmental seminars. There was one case where the rights of the mother versus the rights of the unborn fetus was discussed and debated in the medical board. So there was one member of the medical board who gave a dissenting note in the medical board report, and when the matter went to the court, a 2-judge bench, so both the judges of the bench also had differing opinions, right? So in such a case, what the courts generally do is they refer the matter to a higher bench, that is a 3-judge or a 5-judge bench. Generally, except for 2-judge benches, all the benches would have odd number because the presiding judge, who is generally the senior most judge in that bench, will have the casting vote, right? So, so this is again very, very interesting and important as well, because all the MTP cases generally at AIIMS, what we do is we form a board where our senior residents or junior residents are generally member secretary, and you have members from the clinical departments who. And many times, because it is a time-sensitive matter, it creates some amount of stress for our residents also, because they have to run after the faculty members to have meetings almost on every day or an alternate day and submit the report to the court of law. So things can get a little bit, tight at times. Breach of women's confidentiality will attract a fine and/or imprisonment up to 1 year. So all the cases, the names must not be divulged. So you can give some code number, MTP 001/25 or whatever, and then that should be sequentially, serially numbered, all the cases. And MTP can be performed only by specialists. Coming to PCPNDT Act, registration is under Section 18, renewal every 5 years. Written consent from the pregnant woman and non-disclosure of sex of fetus under Section 5, maintaining the records under Form 5, in Form 5, and submission under Section 29, and creating awareness through signages. So this is an article that we have published in the Indian Journal of Radiology very recently. I think this year only it has been published. So one of our residents carried out the renewal of license at AIIMS, and we decided to pen it down on paper so that any other large tertiary care hospital can actually go through, look at the steps, look at what are the pitfalls that can potentially happen, and then take corrective measures, right? So these are some of the pressure points of the PCPNDT Act. The Form F, minor unintentional errors should not lead to imprisonment. Responsibility for any wrong form filling should be borne both by the patient and the doctor, because initially that information is coming from the patient side. Decoy operations government sometimes does, and to find out if there is any malified intention or something. And there have been instances, you can see down below there, couple of nursing homes in West and North Delhi, they have actually sort of caught, nursing homes which were doing with a malified intent. And clear understanding needs to be developed about what are the things in that. The fifth category are the medico-legal aspects. I am aware that quite a few of you here are from the Department of Forensic Medicine and Toxicology. So I have learned, this from the forensic medicine teachers. So I need not, tell you, but this is again very, very important. The law of privileged communication provides an overriding thing from the principle of, privileged communication. The doctor-patient relationship is supposed to be sacrosanct. It is not supposed to be disclosed except under certain circumstances. We will touch a little bit more on the Consumer Protection Act because that is something which is quite important. Recently also, it was in the news, the very famous VP Shanta versus Indian Medical Association of 1995 judgment, because two judges of the Supreme Court, I'm forgetting their names, they in one of the cases last year, they said that this judgment needs to be revisited. And that is why they send it up to a higher court of 3 judges. But then the current Chief Justice and 2 others very recently, a few months ago, they have decided that no, we will not tinker with the VP Shanta versus Indian Medical Association judgment, and it stands as of. Some sections of the IPC have now been repealed. I will show that in a subsequent slide. Arbitration and Conciliation Act, again, only for hospital administrators. It need not be for the clinicians and others, because every tender that a hospital floats will have 2 or 3 paragraphs on this act. It says that agar hamari ladai hoegi, yani vendor ki aur hamari, it will be first covered under this act. We will try to sort out the matter. If we can't sort out, then we'll go to the judiciary, right? Then Information Technology Act and the Right to Information Act. Again, few slides on this, because Right to Information Act, many of us in this room would be thinking that it is actually, a punishment for us. I have seen both sides of the, coin as the CPIO of AIMS and also now as the FAA, and also as the FAA. So, it's a double-edged sword, I would definitely agree, but then we will come to that when we discuss it. These are our new criminal laws passed last year in the last session of the 17th Lok Sabha. There was a lot of furor because it was said that there was not much debate. The opposition walked out, but these 3 important laws which repealed the Indian Penal Code and the Criminal Procedure Code were by the Bharatiya Nyaya Sanhita, the Bharatiya Nagarik Suraksha Sanhita, and the Bharatiya Shakshya Adhiniyam. That is the how the evidence is collected by the witnesses. So the government claimed, this is again from the newspapers, that the new laws signify the end of colonial era and old wine in new bottle states the opposition. But these are the law of the land as on date. So you will have to forget the IPC and start remembering gradually. The Delhi police also had lots of workshops so that, if someone goes to the police station to file a case, so they again, mentally they go back to the IPC, then they have got those small diaries nowadays, and then they, look at the newer provisions and then put it in the newer provisions. Okay. Some pros and cons. Again, there is one website which I keep on visiting that is called the PRS Legislative, website. And they do a very good, critical analysis of most of the laws so that you get both sides and you are a little, independent and maybe correct. So there is something called a zero FIR, irrespective of the location of crime, because that used to be one of the biggest issues. Online reporting of cases allowed, electronic summons allowed, copy of FIR to be provided to the victim, mandatory crime scene videography, forensic investigation needed in cases with 7 years of rigorous imprisonment. These are some of the pros. Some of the cons could be police custody for 15 days, can be more than that, depends on the police. We know how police, behaves. Detention of the under trial if more than one offense can be increased. power to handcuff for economic offenses. So tomorrow, those people from hospital administration, if you are in charge of the stores or in charge of the hospital, and then some economic offense, is found out or, thought of, there is a chance of, handcuffing as well. Solitary confinement, fundamental rights are suppressed. Section 106 of the BNS replaces Section 304A. So this can potentially, again, a news item, potentially it can, look at more trouble for the medicos. Coming to the Consumer Protection Act, these are the basic, dates that is presented to the Parliament, 1986, 19 December, 3-4 days of debate, passed in the Parliament on 24th December, promulgated on the 15th of April, 1987. Amended 3 or 4 times, once in 2002, once in 2019, once in 2020. The BEAR Act has 4 chapters and 31 sections. The troubling thing is many of these, negligence cases find their way into the headlines. And now with the booming social media and all that, defamation or, somebody being defamed, in the social media or in the media becomes very easy nowadays. So many times this plays out in the media, but then obviously media is not the right body to take a call on this. The right body is either the regulatory authorities, that is the DMC in case of Delhi, National Medical Council or the National Medical Commission in case of the Indian or the courts of law, right? So very briefly again, just 3-4 slides to sensitize you. I'm sure all of you are aware, but then law is a little peculiar that sometimes, you have to exactly, use the same words so that the meaning is understood in the same way, right? So the one in bold is the legal definition of, a negligence, breach of a legal duty to take care. Sorry, I think I'm not using that. Yeah. So, breach of a legal duty to take care which results in damage, and it must prove 3 things. There was a legal duty to take care, this duty was breached, and this breach caused the damage. The connecting points between 1 and 2 and 2 and 3 have to be established by the complainant, except in those cases which are covered under the principle of res ipsa locative. That means the thing speaks for itself, where these 3 things have to be rebutted by the person against whom the charges or the complaints are lodged. The classic example of res ipsa locative is, unwanted or retained surgical objects after an operation. There, it is the surgeon or the operating team or the hospital administration which has to say how and why that happened, right? So unexpected developments, complications and risks inherent in medical care do not imply negligence if these have been explained to the patient. So the first and foremost mantra for reducing any potential charges of medical negligence is have an open channel of communication. But then this is easier said than done. After 35 years at AIIMS, whenever many of the patients who get admitted at All India Institute through me or, through connections, many times they have come back to me saying that, sir, हमें information पूरा clearly नहीं मिलता है, timely नहीं मिलता. So this is something that I think all medicos need to be constantly aware of and try all the time. You may be thinking that, yes, I'm doing a great job, but then once in a while during the fag end of the rounds or somewhere, these things are getting missed out. Okay. So this is again taken from Modi's textbook of forensic medicine and Lord Wright, who gave the, canons of medical negligence. So I'll not go through the definition. We will look at, 3-4 important cases, because when a matter goes to court, these are the cases that are discussed and, the decisions taken accordingly. The first case is Bolam, that is Bolam versus Frian Hospital Management Committee, 1957. Bolam was being treated for severe depression intractable depression, not, responding to the usual, medications that were prevalent at that point in time. ECT had come up as a experimental, therapy, and the doctors said that should we try this out? And the attendants agreed. And then when ECT was being given, the muscle relaxants were not given, right? There were two schools of thought at that time, and this person had a fracture, and then he finally died. Case was filed. Your battery is running low. Should I close this? Okay. So the case was filed for non-administration of muscle relaxant, manual restraint, and no warning of risks. And the matter went to a single judge bench, that is Justice McNair. He ruled not negligent if the actions are in accordance with a practice accepted as proper by a responsible body of medical professionals, even though other doctors adopt a different practice. That means in medical profession, many times you reach a point where there can be two modes or methods for treating a particular patient. If you are following method A and not method B, and something wrong happens to the patient, no medical negligence can be attributed to you. I'm talking about the most core things, not going into specific, general discussions, right? However, it is the duty of the doctor to inform the patients or the attendants of the risks involved in the treatment. From there, sorry, what happened? Okay. So the second case is Bolitho versus City and Hackney Health Authority, 1997. Bolitho was a minor. The claimant sued the city hospital for severe brain damage due to failure to intubate. The court examined expert witnesses from both sides and agreed with the defendant witnesses. The agreement was based on the logical analysis of the case scenario by Lord Brown, Brown Wilkinson. He was the judge, like Justice McNair in the previous case. So this is a doctrinal shift. That means what is correct for a patient moved from the medical, fraternity to the judicial fraternity. Because in the medical fraternity, there was a difference of opinion, and the judges relied on which medical opinion was more logical. That means that is why it is called a doctrinal shift. They say, like law, medicine also follows logic in most of the times. So if there are two different versions, we will tend to follow what is more logical. So this was the second landmark case. All three landmark cases in the United Kingdom. And, we will follow, because I said at the beginning, we follow what is called the English common. So this is a doctrinal shift, giving more power to the judiciary to negate illogical expert witnesses. All of us are expert witnesses if we are called to a court of law to depose, right? And this is the last one, 2015, Montgomery versus Lanarkshire Health Board, UK Supreme Court, 2015. Nadine Montgomery was pregnant with her first child. She had type 1 diabetes and was concerned about the size of her baby. She inquired during ANC visits. Risk of shoulder dystocia was not discussed, and plan was made for a normal delivery. During delivery, shoulder dystocia occurred, and a 12-minute delay caused cerebral palsy due to hypoxia. She went to the court, and a two-judge bench, along with 5 other judges, decided that the doctor should have provided all the information and allowed her to take decisions regarding the modality of delivery in her case. So you see how the power, seems to be shifting, right? If we look at the current status of medical negligence cases in India, this is 2022 data. There is, a large number of, cases pending at all three, the district forum, state commission, as well as the national commission. Now, the 2019, amendment to the CPA, the first thing that we must remember is Before 2019, 1 crore and above 1 crore used to be at the National Commission. Penalty above 1 crore. Now 1 crore is at the district forum. So you can imagine that the potential chances of very high sums of cases being awarded, penalty being awarded will definitely be there, right? So that is the main important thing. They have also allowed in the 2019 amendment that you can settle cases of medical negligence through mediation, which is a good thing, which is a welcome step. We have already seen that there are far too many cases as backlogs. So if through mediation some of the things can be solved, why not? Okay. Some genuine concerns when we are talking about legal issues, laws, society and medical professionals. We are aware of the violence in the society towards the healthcare givers, and that is definitely a cause for concern, right? Rule of law or rule of rulers. I tend to believe that in India, it is more rule of rulers than rule of law, because your economic heft and your social status plays a role in what justice you are meted out, right? The menace of corruption, right, is still there. Demand supply gaps and inequitable distribution. It is possible that in a certain case, if the matter goes to a conscientious judge, then the healthcare authorities may be absolved of whatever charges are framed because of this demand supply gaps and inequitable distribution. Social media use and the effects. This is going to play out in the future also. Delay in judicial processes and backlog of cases. There is obviously urgent need for reforms and transparency. We don't know when that's going to come. I used to end my lectures on Consumer Protection Act with this slide. And this is a journal, Medical Law Cases for Doctors, which I have been subscribing to last few years. So very interesting journals, and sometimes when I get free time, I go through that, because I certainly don't want the tombstone on the right hand side where it says that the person died because of negligence of the doctors, right? Obviously, any sane-minded person would choose the left one. So coming to RTI Act, again, very few slides. I am not here to discuss much in detail. The Right to Information Act, the Indian government version is actually one which is the Maharashtra's template, which has been taken and borrowed, and the same one was enacted in 2005. If you ask me, one of the most significant legislations in the country which enhances democracy or democratic processes, my vote would go for this, because before this act, there was hardly a chance that you would get to know about the doings of the government in writing in front of you. Okay. So this is what right to information is. You can inspect, you can take notes, you can take extracts, you can take copies, take certified samples, and obtain information in any mode. This is the flow chart. All of us are aware of this. When I was the CPIO, I used to handle about 750 to 800 RTI applications in a year. And we are also recently, thinking of launching a faculty development program for our own faculty, for all the CPIOs at the institute. We have about, 50 of them. So these are some of the salient judgments by the CIC, the Chief Information Commissioner. Annual property return is personal, but then some organizations have decided as a policy to put it on their public domain in the website. PAN number is personal to the person, need not be disclosed. MR versus JIPMER, DPC minutes and the connected proceedings are not exempt from disclosure. However, the ACRs connected for DPC are exempt. Untraceability of information is accepted in case the PIO has made a diligent search to trace. Then applicant has asked for a huge amount of information in a pre-designed format. Information available in the office is not as per that format. So whenever somebody is asking for a large amount of information, you can use, section 7(9) to say that this will, adversely affect the functioning of because it will divert a lot of resources in providing this information. And we are not, collating or collecting this information in this way. But it is prudent in such cases to allow the person to come and inspect, right? And many times I have seen that if you allow them to come and inspect, some of them do come up, most of them don't. But then once they come up and then they see the systems and the processes, one of them, at least I remember few years back, he, came to my office with the store person and he said, I'm not going to file any, RTIs, to the stores at AIIMS because I know that, things are going quite well, right? So here, this is CIC has no power to inquire into why, how, and in what matter a decision was taken. Information relating to investigation that has been completed can be disclosed. Interpretation of a given law, rules, or regulation is not information. It is in the realm of opinion. So that may not be provided. This is a very interesting. If the question has the word why in it, why was this done? Then there is this, OM of the Department of DOPT, and this is based on Dr. Celsa Pinto versus Goa State Information Commission in writ petition number 419 of 2007. It says that if there is a why, then you can say that as per the DOPT circular, I am not expected to answer this question, right? So then there was an amendment in 2019. The proposed changes to the tenure, salaries, and service conditions of the chief information commissioners resulted in opposition walking out. Almost all the former CICs and activists are not in favor of amending the RTI Act. Honorable SC has reaffirmed his faith in the ensuring transparency in the electoral bonds case. So there are some of the amendments also. Then we come to safety issues in hospital premises, the Boilers Act, the Indian Explosives Act, the Gas Cylinder Rules, the Atomic Energy Act, Prevention of Food Adulteration Act and Rules, the Prevention of Violence Against Medicare Persons and Medicare Institutions in 25 states, I think 27 now, this is a little old slide, and the POSH Act. This is again very, very important. The need for a separate law was, first laid down in the Vishaka guidelines by the Honorable Supreme Court in 1997. A very famous case. Those of you who are more interested can, actually go through that case. That case is available. Bhamri Devi case, I think that's the, So this case revealed the hazards that a working woman is exposed to, and the case of Rupan Deol Bajaj and another versus KPS Gill is one of the landmark cases that gives you, the entire spectrum of what the POSH Act, deals with. One of the ex-chief justices of India was also Ranjan Gogoiji. He was, a target of a allegation, but then there was a lot of furor in the media because the Supreme Court itself, which, had said that every organization should have an ICC, interestingly did not have an ICC of its own on the basis of their own guidelines. So they had a different internal committee which looked into it, and then they somehow, the report was not made public, and, things happened. Okay. So these are some of the things that you need to do: create and implement an anti-sexual harassment policy, constitute an ICC, give them the necessary training to function independently, employ awareness programs, posters and notices, and statutory annual report filing. Very, very important. Nowadays, it is becoming more and more important, right? In fact, interestingly, some of our faculty members in my department have put cameras in their offices. And I asked him why. I said, I have been working for so many years, I have not put it. He said, sir, aajkal mahal sab theek nahi hai. So he is decided to put, cameras in his office, 2 cameras, so that whatever happens in office is recorded. I said, well, that's again, something to be thought of. So Employment of Staff, Workmen's Compensation Act, Payment of Wages Act, Industrial Disputes Act is important because we get strikes, and strikes, lockouts, all that is covered under the Industrial Disputes Act and the Trade Union Act. We have the ESI Act and the EPF Act also. So all of your manpower tenders, all of that, is covering this. So these are the objectives of the Industrial Disputes Act: promotion of measures for securing and preserving amity and good relationship, mechanism for investigation and settlement of industrial disputes between employer and employee, employee and employee with right to representation, prevention of illegal strikes and lockouts, relief of to workers in layoffs and retrenchment, collective bargaining. This is very, very important. It's a separate lecture actually. It is not, I'll not be able to cover, too much of collective bargaining here. So hospital is, considered as an industry as per the triple test, which is, given by the Supreme Court in this famous judgment, that is Bangalore Water Sewerage and Supply Board versus Rajappa. In that judgment, the Supreme Court has said that hospital is an industry. So these are the industrial disputes that are covered, collective disputes, individual disputes, okay. This is the definition of strike. Cessation of work by a body of persons employed in an industry by acting in concert. 3 essential ingredients: plurality of workmen, cessation or refusal to do work, and concerted or combined effort. It includes under its ambits all forms, methods, etc. These are some of the conditions to be fulfilled. Very recently, FAMES also was thinking of doing something, but then we are bound by the code of conduct, which the Delhi High Court has said, and it is not possible to go on strike, right? So if strikes, the only 2 or 3 sort of like the bank unions generally, and the trade unions, and sometimes the transport unions, they give the proper notice and go on strike. All other strikes generally in the country are actually illegal. We may not do something, we may get positive respite from the court of law, but then as per the law of the land, these are all illegal strikes, right? So there are a lot of implications. Cannot claim wages, can also be punished, okay? So coming to Contract Labor Act, these are some of the acts again. So just very briefly, outsourcing of non-core services. Private sector hospitals have outsourced more number of services. Government of India is also, doing a lot of outsourcing. But there's a lot of confusion, with regard to the act, so long as the matter is under the, executive. Sometimes, people say that this is a manpower tender, this is a service tender, you can have KPIs. But then once the matter goes to a court of law, the only act is the, Regulation and Control Act of 1970. So more awareness sessions should be there so that people understand the nuts and bolts. They are aware of, what the provisions are. Better working conditions for contract labor will ensure feeling of identification with the establishment. And wherever, regular employees can be recruited, should not be opened for contractual labor, is my opinion, because that is what the act says. And the act was enacted in 1970. So either we change the act or we don't do it, right? But then somehow no one has thought about it, and it is, going on. So these are some of the other labor laws: the Factory Act, the EPF and Miscellaneous Provisions Act, the ESI Act. This I have already covered. Coming to environment safety, this is the last category: Air Prevention and Control of Pollution Act, Water Prevention and Control of Pollution Act, the Environment Protection Act. Biomedical waste management rules, very important because they fall under the Environment Protection Act. The e-waste management rules, solid waste management rules, respective municipality bylaws, and some provisions of the Bharatiya Nyaya Samhita, earlier IPC. So to conclude, ignorance of law is not an excuse. A very famous, quotation, and it is a fact as well. My tip would be that if possible, the administrators should have good, cordial relations with the judiciary and maintain that. Because once in a while, you can still have a scuffle with the executive because it will be finally decided by the judiciary. So it's better to be on the right side of the judiciary all the times. Appoint a trustworthy faculty member who has aptitude and interest in legal issues as the officer in charge, who looks after the statutory issues and the legal issues in the hospital. Understand the distinction between civil and criminal cases as they come up. Organize sensitization sessions for concerned staff and officers. Have a dashboard of red flags. These red flags could be POSH Act, it could be, some of the labor laws, it could be the PCPNDT. So whatever you feel that, a little weak in your organization or hospital, develop some sort of a dashboard. We are also in the process of, doing that. It is get published very soon. We have a, mechanism that we are, doing, and take professional counsel as soon as possible as you come to know about that particular case. So with this, I think I will end the presentation. I'm sorry I had to be hurried because I started a bit late, but then I will take whatever questions there.
Thank you, sir. Questions and reflections, if anyone of, yeah, please go ahead. Pass on the mic.
Hello. Sir, thank you, Dr. Satyapati, first of all, for such a nice lecture, which always we listen in PGI also to you. Two things I just want to get a learning from you on this. One is that the new NBC code, which
Check if the mic is on.
order which has now come that
keep
it is
it
not
closer to your mouth.
mandatory to follow the NBC code. Now,
We are all, not to, they have not said not to follow.
it is not obligatory. Yeah.
PNS of the IPC. And it is recommendatory in nature. That's what they said. So there is nothing.
So how to entangle with the municipality and the engineering wings which are there in your locality, quoting this, how can we do it?
What I've come to know is that the government became very bothered with the ease of doing business, right? And now ease of doing business versus healthcare as a service sometimes can have absolutely, divergent opinions and ramifications. So keeping that in mind, that is why they have issued that circular. I really don't know what the fallout is going to be, but then we may see the fallout of this, another 5, 6, 10 years down the line when new projects come in and then the hospital administration or someone says that bhai ye to NBC mein nahi hai, aap isko kyun kar rahe ho? But then yes, it also this OM doesn't state it, but then there have been case laws after that where it says that wherever provisions of the National Building Code 2016 are implemented through the municipal bylaws or the law of the land by the local authority, they become mandatory. So you see that window provision they have kept. So it will depend on the local authority to take a call whether it is correct or not correct or whatever the case.
For example, sir, in fire safety.
So even if it is their part of the. Let's stick to those.
No, no, sir, just a
who raised
comment.
their
I'm
hand.
not asking any question. I'm just adding on to it. Just like fire safety, it is a part of your mandatory requirement and it is covered in NBC also.
Yeah. So,
NPC is a huge document. It's a 4,000-page document, right? So what they have basically said is it is more recommendatory in nature because all the 4,000 odd pages may not be actually translatable on the ground. Some of them that could be in an ideal setup or something. Many of that has been reduced down to laws, local laws, right? Wherever it is part of the local laws, that is mandatory.
the second question, sir, I want to know your opinion because it is implemented. So regarding increasing.
We can't hear you. Can you keep the mic closer, please?
Yeah, sir. Increasing the in cases of rape and where there is a abnormality in the fetus, increasing that age from 20 to 24 weeks. So what is your personal stake? I personally, whenever I see such things in the hospital and I am a member of that, don't you think that it causes more agony to the mother by increasing for 4 weeks more? Should the judiciary be given this power to increase it?
So, you see, at the time of amendment, they must have consulted the, medical, not that the amendment, comes out of air. I mean, I'm sure, and normally the system is that whenever new laws or amendments are passed, we generally, as a civil society, we sometimes, lose sight of that because the rule says that it has to be, for wide public dissemination, inviting comments from all stakeholders for a period of 30 days, right? So many times it escapes the notice of people. But then while you may have a point that your point of view may be correct, the other side is also sometimes correct. That many times the second level ultrasounds, when they pick up those things, things get a little late, and a little extra time actually helps also. In many cases, we have seen, we are actually carrying out a study also, which, at some point in time we'll publish, to look at that after the amendments, what has actually happened.
That was primarily the reason why it was made.
Yeah, so there were many people who were going to the court saying that, sir, ab to hamara ho nahi sak raha hai, and now I have to carry this, baby with fetal abnormalities, which is going to become a, problem for the entire life, right? So there are both sides, of the coin, and I think this decision has been taken at the highest level, and now it is almost 4 years now, so I think we'll have to follow it. There's no
Yes.
other way out.
We can move to the next
Sir,
question.
my
And next
question is
expert is
related-
already here, so
Sir,
maybe last
related
question.
to rules or laws related to medical records.
Medical records.
Yeah. So what is the policy and for how long they should be preserved, or what
The
the?
law in India is very clear. It says 3 years, and this is in 2016, right? So, but then at AIMS, what we have done is we have decided to follow the earlier OM of 1970, right? So, and the reason for that was that in the meeting we decided that AIMS being, academic and research institution, if we keep all the records for 3 years, it is not going to help us in our research objective, which is a mandate of the institute. So we decided that it says minimum 3 years. So it gives the floor level. It doesn't give you the ceiling. And the ideal scenario could be that you keep all records lifelong, and that is sometimes not possible. So what we have done is that we are, transiting into digital records, digitizing most of the records, and then keeping it at least for a period of 10 years. And maybe because some of the departments at the institute, they keep their departmental records for even 30, 40, 50 years. Because at some point in time, they would like to do a longitudinal, thing of 50 years and publish that, right? So 3 years is the minimum that the government mandates. उससे कम तो आप कर नहीं सकते. उससे ज्यादा अगर आपके पास वैर विथाल है, आप करिए. आप अपने डिपार्टमेंट का एक पॉलिसी भी बना सकते हैं कि भाई हम डिसाइड किए हैं, जैसे हमारा 10 इयर्स का है, राइट? तो आप वो कर, हमारा आज के दिन में जैसे आरटीआई में कोई पूछ रहा है, एनीवन इज आस्किंग बियॉन्ड 10 इयर्स, we just give that letter from the medical superintendent that all records beyond that 10 years have been destroyed following the due process.
Can you use the mic, please?
Could you? Yeah.
Cannot be covered in an hour.
Okay.
For the two as well as 2 weeks. So, same is actually a full chapter 7.
Okay. Thank you.
I think this session could have been taken for days. Each one of the act needs a separate session. But in the interest of time, and Dr. Katoch, all of you know him, is already here despite delayed flights. So thank you so much, Dr. Satpathy. It's an honor to give you a small recognition. Thank you.
Okay, friends, we have another very interesting session. As I said, that the highlight of this particular course is the Meet the Leader session. So today again, we have a very eminent personality in the medical specialty who has headed 2 organizations. Dr. V.M. Katoch sir is with us. Sir started his career in ICMR in 1978 at Jalma. Then he became the director of that institute for 8 years. Then he joined ICMR, and he was the first secretary DHR come Director General ICMR. And again, he spent nearly 7 years over there. And sir has a vast experience of guiding games and also JIPMER and many other organizations. Has a lot of publication. You can see more than 350 publication. And sir is unique in the sense that he is fellow of all the science academies, all the 4 science academies, sir is fellow. And we are also privileged to have a fellow of National Academy of Medical Science. So, sir, you have a lot of experience as an administrator, as a leader, and we like that some of your experiences as a leader in these institutions. What are the challenges you felt, and how you overcome those challenges for the benefit of our party? Over to you, sir.
Thank you, Dr. Sood. I have come earlier also to talk here on the same, but I forgot about these 20 points, which were talking points which were given by Professor Kapil to me last time. But nevertheless, they are there actually, and Dr. Sood has flagged them. See, most of us, most of you are in those leadership positions or aspiring to be on a higher positions. Or at least you have interest, that how the leadership works actually. When we think of this subject, actually, there's nothing, there's no solution for anybody. There's nothing like a example for anyone. But I think for people like us, we are the living fossils, I'm telling you. Because fossils tell you evolution. And we are still talking. And fossils also do talk. That evolution, that gives you that you evolve with the time. And there's a continuity actually in any society, whether up to 47, we were under a different rule. After that, we have our own rule. But then again, that different kind of rule by different leaderships in different states, in the union governments also. The private sphere is changing. So I think in that ecosystem, there's no discontinuity, but this is always a continuum. So the lessons from the history, they are not useless actually. They are useful to some at some point of time. Because when you think of our lives, we learned from our seniors actually, whom we watched. And watching them was very subtle actually. You were not aspiring what will happen actually tomorrow, why you are there actually, why you're watching. But you watch them, there are those impressions go into your mind, how they conduct themselves. And I think, but when you go into that position, then it is not a straight away using a one model or the other model. There's nothing like universal model. It is a hybrid depending upon your temperament, your skills, and your intuitive feeling, what you want to do actually. I think that intuitive feeling in the end matters. As a doctor, that also matters. In the last, it is your intuition only, what is the right or wrong. That the AI may be tomorrow guiding you, but it won't be guiding you to beyond any point, because this euphoria is very temporary one. This will die out in, I think, few months or few years actually. And then you will start realizing that discovery is different. So, and discovery is your own actually. So when you think of, the career, when I give you my examples, when we joined ICMR, because we got selected there. They wanted I think 15 medical people to be recruited directly. And we were the first batch in 75. And so we entered. And we loved science, and we loved the image of the ICMR at that time, because it was already a glorious organization with long history. So it was a euphoria, young medical people with a euphoria and getting trained. See what that, I think, edge which gave us actually, which I think which you should be giving to the youngster, because all of you are senior people. But you should be mentoring the other new generation, that they have to be all-rounders. They should not be tubular people with a tubular vision, knowing one specialty, one subject. If people want to be leaders, or you see the spark in them as a leader, then I think they should be all-rounders. Whether we hate civil service, but the point is they have the capacity to synthesize, because they are trained that way, they are picked up that way. And they are able to condense anything into a small solution suiting the political master of that time actually, and the environment of the people also same time. So when you think of the medical leaders also, their temperament also should be same. See, like a head of a surgery becomes the principal or the director, he or she has not to look at the surgery only. He or she should have a temperament to nurture everybody else. So I think the first capacity, when you walk into those shoes, when I think in 2001, I walked into the administrative position. Till that time, I think you were growing as a professional actually. And I think everybody should be a successful accomplished professional to the whatever area you choose actually. I think that's, if you're not good in your subject, then you will never be respected by anybody. And you can't be good in everything also. So as your specialty is concerned, you can be good only few things only. And this all of you know actually, all the people sitting here who, I understand, I know the biodata of a couple of you earlier also. So I understand, you have tried to focus on something and that's why you are respected. I think, so that part is, leave aside that part, but that becomes the benchmark of entering anywhere. Then when the leadership position comes, then the question comes the same, which I pointed out, that I was based, because I was very introvert looking at my area only, my laboratory. A couple of years in the beginning when I joined that, the Jalma Institute in Agra was a hospital created by Japanese. So it was their focus was on the medical side only. So they had excellent medical units, they had excellent surgery, all created by Japanese, but then very successfully carried over by the Indian people who took over after that. But there were no labs. One lab was electron microscopy, headed by one of their directors of that time only, a pathologist actually, neuropathologist. And rest all came during the Indian period when we were there. So in the beginning was the challenge of creating your own labs, getting funding for that. But then as a director, the job was to nurture everybody, and that time you cannot think of, of your own. I think the worst sufferer during my period was my lab actually, my department. Because obviously then sitting in that chair, the goal was to nurture everyone. So then, and I think if you don't try to do that, I think then of course, your history is written very differently afterwards when you leave. So you should, so I think you should be, the best point which I thought was, I started really looking at everybody in a different way that time. Even the people who were, literally my competitors, because it is a direct post, selection post, it was there. So I was about 7th in the seniority also. There were 6 senior to me. So the point arises then there were 6 senior to you, so how you deal with them? I think what thing which I did was actually, I give you the example today also, that the seniors, one headed the medicine, one was the head of surgery also. Then the senior most person, earlier also, I always used to walk to him actually when I'm going out. I've been a very disciplined person in entire lives. So I used to walk to him, sir, I'm going out and I'll go for half a day or for 2 hours or 4 hours, I'll come back. So when I became the director, I never started calling him on phone. Never asked my peer to call to him. I always walked to him the way I used to walk earlier. So, that I think ultimately, that gave a thing that his seniority was respected actually. Because ultimately he was an accomplished professional in his own area actually, though we are not considered fit by the committees to be a director. But then ultimately he should be respected for what he is actually. But then now the second question used to come, then they can't play politics afterwards. So that means if you are heading the committees, you have to really say that this is the end. Final responsibility lies with me. So I think they keep on postponing some meetings. Today the OPD was very heavy. Today this is very heavy. Today this is very heavy. I said that, sir, nothing will happen like this. This meeting will be on this date, this date. You scheduled it at 3:30. By the time the OPD is over, there's less one. The other people, consultants, let them set that time. So no meetings will be postponed. There will be statutory meetings on this day, this day, this day, this date. And after your recommendations, you can't bypass the laws. But after after my final decision, there's no debate or thinking again and again, because I saw that happening. Those people used to do early with the earlier directors. And then I think you will be facing those situations in your career also. Many times after the decision is taken, people start talking, isme gadbad hogi, isme gadbad hogi. And us waqt agar if you start reverting, then what happens? It creates the chaos lower down actually. So that means the highest, the chain of command becomes totally weak actually. That means the person who is taking a decision on the top looks like a stupid fool actually. So I think neither you should do yourself, nor you should, after if you are in that position, allow that to happen. I said, sir, if something goes wrong, after my signatures, only the DG can review. That means this decision will be implemented. So I think that it's a humility coupled with that genuine humility, not only showing to the people, That means respecting the age, respecting the seniority, respecting the independence of your colleagues or whatever level they may be. And then I think you be firm actually. I think that really is necessary actually. That becomes very necessary because that's the model I adopted in my life actually. So I think with none of the seniors ever openly I argued with them. Even if they have a different opinion, I just listen. But otherwise, if I had to talk to something, I'll talk to them separately, independent, nothing on the record, nothing, no junior will know, my PA will never know what I talk to my colleague. So I think that really created a harmonious type of relationship, even with the people who were opposed to me earlier, because they were bitter, they were by competitiveness that comes everywhere, in every sphere there is there. Every sphere, we feel that we are better than the others, why he or she is moving much faster, because we never try to look that way. I think this is a common character everywhere in the world actually. I don't think in India everywhere is the same. So, but then if you conduct that way, that becomes a harmony actually. Then actually the second was again taking a plunge, which I'll say, which is something very difficult that happens. If you say somebody has been opposed to you, then you have to take a decision on administrative responsibilities. I took administrative responsibility that I made the person who was the bitterest critic of me as the head of the administration. Now he can't oppose me after that, It is everything goes through him. He gets involved into that. So that politics around that situation goes off actually. And this is human story. So the unions, others who play the politics afterward, for them, they can't do anything because same person is heading the administration actually. And I'm still the director. I'm still say if you're a vice chancellor somewhere, you're still the vice chancellor. So I think giving responsibility to the people who are not your friends, I think you should try to look at that part that there should be no coterie after you reach the chair actually. So and if we are able to do that, I think that gives a sense of neutrality. You feel lonely. Many people feel insecure. But if you feel insecure and you just you pack the administration or the committees with your favorites, I think that doesn't create a confidence outside actually. So I think having confidence in ourselves and having and taking a plunge, that becomes a very important point if you really want to succeed in the end actually. But then who defines the success actually? This is to be decided by others actually. You can't say I'm successful. Because many things you do are successful, but all the things you're not successful actually. So you fail actually. So you should be humble enough to accept that you are a failure in somewhere. If you fail something, you take back that you move, you change your course actually. But don't take. I think in my opinion, if you start taking back your decisions, then you can't succeed actually. Because I had seen that happening to two of my earlier directors who were excellent people, and one director whom I rate very high, he was a surgeon. Very famous surgeon, but a wonderful scientist also at the same time. He could understood all subjects. But when the final decision used to come, I think he used to many times take back. And then the unions became habi unke upar. Unko laga ki yaar ye to ghum jayega baad mein. And at that time the administration starts collapsing actually. So I think he was the best director our institution had for long years. I rate him very high, much higher than me. But then only this one quality of taking bad decisions that proved I think that led to a collapse, which was difficult at many stages. But overall his score remains still very high because he was an intellectual, he was a thinker, he could give to others. So I think these all qualities, when I look back, they were important on those 7 years, because I think based on those 7 years, my image rose actually, because people had seen me operating as a director, people had seen me collaborating with others, people had seen me trying to how to nurture the juniors who will get a good competitive funding. Because I think that your investment, rather than trying to suppress others, should be on promotion. Because if you people spend your energies in suppressing others, that means the general staff, even your colleagues, then your energy is wasted there actually. So let them do what they want to do actually, because still you're the boss actually. So I think you should be nurturing the right people who produce the maximum. So even your 20% of your staff who are excellent, their 20%, their performance goes 10 times higher. So the institution's performance still is very high actually. Everybody was not cooperating. In my experience as when I was a director, I could not bring out the best from the people who didn't want to work actually. Rather, I avoided them. Okay. So I just totally avoided them, but I didn't allow them to cross the line. But the point was, the people who were the best, they were given the time to survive. They were given the time to, produce maximum. They were given the support to produce maximum. So the overall institution profile rose suddenly very high actually. And then, building those collaborations, which you ultimately, and build your collaborations and let the others build a collaboration. Because my area was a TB, my area was mycobacteria, my area was that leprosy. And in them, the area personally, which in my laboratory I had developed, they were based on the genomics, they were based on the molecular epidemiology, they were based on the diagnostics. And their network created the networks, about 38 medical colleges, helped everybody. And in all those 38 medical colleges, beside the acknowledgement, I never allowed my name to be put as a co-author. See, the point arises, people should not say you are snatching the credit of others. And that's very important as a professional, but that's much more important when you become the director, vice chancellor, or a head of a major institution. I think that's the one thing which I found were very, very productive. And that, I think, created a wavelength, a good positive vibes for me when the position was rising here. Because I never knew anybody could succeed. Anybody, even the 5 people who were shortlisted, I think all were excellent people actually. And their careers were no way inferior to me. So I was no way superior to them. It is only the cabinet secretary and his committee who picks up the secretary. And I think they picked me up. So that was my destiny actually. So it's nothing like that I was superior to anyone. So there was no, I think, a special characteristic which I'll say was superior. I think only thing which played a part positive in my favor was, see, in the leadership positions, if those positions are, and is a fair play, if it is a fair play, and quite often it is a fair play, many times it is a politics also, but quite often it is a fair play also. They look at, how is your philosophy towards the others, how you will create a new thing, how will you innovate something, how will you actually change the working productivity. And I think for the job as a secretary, I think that was the only thing which the cabinet secretary and the committee focused on. They said, you leave aside your biodata, leave aside what you want to do. Their main emphasis was ICMR is ICMR, but the department is a new department. And most of the functions are overlapping with the other departments. So how those will be coordinated? Will they create more chaos in the government? How they'll improve the productivity of health research? So I think that for each of you, when you look at, something, a perspective of that kind of a perspective, how will you coordinate others? How will you synthesize the philosophy of others without interrupting them, without irritating them? And my philosophy is very simple. That one question which I think possibly tilted the scales. I said, sir, nothing doing. Let everybody do what they are doing. So that means no department to be disturbed. Let the mother child do what they are doing. Let the Department of Health do what they are doing. Let the labor and the social justice do what they are doing. But we will, and ICR is working on the zoonosis. They are working on the nutrition. Let them do what they are doing. We will create a coordination mechanism, a committee of 8 secretaries, and which will never be chaired by the secretary head as such. He or she will be only a member secretary, a coordinator. It will be chaired by the senior most secretary. So that means all conflict is over. So no senior will ever feel. So any senior secretary on that day is a chairman, he or she is a chairperson. So I think rather than trying to be central figure for everything, if you give the chance to others, and then let everybody's agenda be synthesized by you. I think that becomes the very important part as a success. Not I say successful, but a useful leader actually. Successful is to be countered by others. When you move from the chair, and when I left in 2015, see, look in 2020, assess in 2025. And assess in 2030 if you are still alive, or you're gone. Yes, you are gone. But the history remains there actually. So people judge you when they'll judge from their eyes. You can't be talking for yourself that I'm a great person, or I'm a bad person, or he or she is a good person, because that judgment is to come by others actually. So I think in that context, that nature of, being a coordinator, if you like to be a coordinator, if you like to be playing a subtle role without disturbing others, I think that becomes the most productive way of working actually. It is a difficult actually. See what happens when we reach to the top positions. I'm telling you, I'm finding a problem with many. I used to find a problem at that time also. What the people do actually, they please the masters. So like if you're a vice chancellor, you want to please the governor, you want to please the chief minister, or you are or you want, if the central side, you want to minister, HRD minister, you want the PMO, you want to keep the PMO in good humor. So all the time, if your eyes are focused on only pleasing the who matters, then you don't look at the people whom you're going to serve actually. And the people whom going to serve, then you must first identify them. Your policies, your agenda should be fulfilling the agenda of others actually. If your agenda is only to survive and be in the good books and being so-called powerful, so that means you are in the good book of everybody who matters, then ultimately history judges you that way only. The time will judge you that way only. When you also retire, you will also judge yourself that way only. And I didn't do that. I was subtle. I was calm. I was never trying to put my opinion to the others. But then whatever agenda was laid, those schemes which were created, schemes which, ultimately took 4 or 5 years to nurture. And ultimately they became a ground. And I tell you that story I would definitely want to share with you. Because the ICMR is a ICMR. You imagine in any twin role. ICMR is created in 1911. Though for 50 years, I've been a part of the ICMR as a scientist, as an administrator. But ICMR is nurtured by so many people. ICMR is nurtured by the medical college people who created the projects, who wrote the science. But the DHR it was my destiny to be the first secretary. Then the question arose, what should be the agenda actually? And the agenda, I called that time, 149 government medical colleges. I'm talking about 2008. So all principals were invited, directors were invited. So I wanted to know them, what they want out of the department. So the department had few lines only. But there are 10 lines actually, that's all. And 10th line was ICMR. 9 lines were one line each. Okay, this function, this function, this function, this function. But under that function, how it will serve the people actually? That's the issue actually. Does that opinion should come from a center only, or should we consider the consideration of others? So all the principal directors were asked actually, okay, what you need for your area, what your area suffers from, what is the maximum area which you think should be a priority. So their opinions were taken. Then I took the opinion of all the chief secretaries of the states also. Bureaucrats, many of them had a very seasoned opinion actually. And ultimately their agenda synthesized with agenda of the medical people. And then also coordinated by my colleagues who were all IAS officers. All joint secretaries were IAS officers. Ultimately, they could transform them into the schemes. ICMR could not do that actually. ICMR can do a scientific job so well. And that many of us, as a medical people, we do our job very well. We know our subject. But when you want to nurture that, you become a principal, or you are a director of an institution, or you're vice chancellor of a university, then it's not your life only. You're looking at others. So that agenda, you must discuss with them actually what they want. And in fact, most of the schemes which came today, which are on the ground today, whether they're virology schemes or the scheme on the multidisciplinary research units, rural units, those ideas came from the users, what they want. So what is the deficiency in their area? So agenda was the feeling of the people, then synthesized by the bureaucratic mind. But then the challenge was getting it through the cabinet. It is a new department. So first finance minister was very positive, but he became the president then. So then ultimately everything was back to the square one. So then convincing the next finance minister again, up and down, up and down, up and down. Those are different stories. But then what succeeded in the end, because I was talking the same agenda in a different ways every time, looking at the question of the MPs. There's a committee of 50 MPs who guide the ministries, health ministries' total agenda. So I was presenting the same to them, listening to their comments. Ultimately, it had, and every member of parliament, they are very sharp characters. They know what will come out of it. So they say, हमारे लोगों के लिए क्या है? इस एरिया में क्या मिलेगा? इस एरिया में क्या मिलेगा? So then your schemes become people-centric actually. And in the end, after a struggle of 4 years, they were the schemes which were popular among all the politicians, rather from whether belonging to DMA, DMK, SJP, BJP or Congress, everybody. And it had opponents also in all, but it had the feelings of most of the parliamentarians across the board. So question arises, when you, in a particular area you go, the political people cannot be sidelined. They have to be at the center stage. But then it has not to be one politician. You're actually, your skill lies how you take everybody along without confronting anybody. Maintaining your neutral image. I think that taking a side of a particular side or becoming a very close to a one openly with somebody, then that becomes very detrimental because the other people will never help you actually. So I think as an administrator and for medical people like all of us, when we are in the positions, choosing particular, I think, side, meaning becoming on the one side or other side, I think in the end is very lethal actually. And I've not seen a successful example, that all the people who have rose like this and they fell like also like that. And then the people who are on the side, who judges? The medical people judge, other people will judge. Opinion about a particular profession will be given by that profession only. So their opinion is always negative actually. I think that was a one part which I thought it was on the positive side of it. Negative side, when you look at my side, it's not everything was positive actually. And when you look back, what were difficult, what the things I should have done differently? They were, the people who worked with me for life, for example, for long years. I could not become very rough with them. I think that was something as an administrator was not a great, I think, quality. Because in the end, when I was looking at, I used to make a list of everything that this is to be done, this is to be, I used to give to my joint secretaries, give to the other people, then I follow it up actually. So anybody meeting me across anywhere, his or her will not be forgotten. It could be a chapadasi, it could be a scientist, it could be any rank. So giving attention to everybody, giving a reply to everybody, and decision to everybody. Whether decision is in the favor or against, doesn't matter. You can't favor everybody. You have to take a decision, that's all. But no case will remain pending. I think the person's life that should be over. That, that I think was the crux actually. And in that context, when it happens, in the end, I counted my score when I was leaving. My second term was ending. My score was around 85%. 15% were left. I had done all. Now 15% could not be implemented. Even if 85% was a big score, but those 15% again could have been on my score. It could have been 100%. It could have been 95 also. It could have been 97. And all those files were lying pending with somebody, officers who were my favorites. And those, I had worked those people for long years, And somebody took leave and they went somewhere, somebody took this way, that way. I mean, I was not rough with them. I could have been very rough with them, and I could have, had I been very rough with them, I think they would have been implemented. This again would have been implemented. But I should have shifted the thing from them to others. Again would have happened. So I think as an administrator, in the end, you should have, I think that decision, that you should have the capacity to pull out. You should have the capacity to take action against even the people whom you regard well. They were not bad people anyway. They have not done anything wrong actually. I didn't leave anybody, I'm telling you, because I'm telling you the years as a director general, as a secretary, and also, I think I presided over 2 NIPERs, NIPER Mohali twice, NIPER Hajipur, then ISL Trivandrum, AIMS Madurai, Jipmer. My decisions were long decisions. They were recent decisions. When at Jipmer, I decided more than 2,200 cases. Because that old institution, a 200-year-old institution, Jipmer completes 200 years, starting from the French days. So it is a long history. So the people came at different times. Sometime it was a central government institution, Ministry of Health, Dharmantri Medical College, then became an autonomous institution. So there were a lot of complications there, but one of the very fine institutions, professionally, a huge output. So it was a very satisfying experience. But one point which I'm saying you that no decision of mine ever got overturned by a court actually. Reason was very simple. I used to give a very long decisions actually. Anything done by the person who has done wrong, inquiry committee report versus my opinion, that will be reasoned decision. Why I agree with the inquiry committee, why I don't agree. But the person is given chance to be heard or not given chance to be heard. His opinion or her opinion recorded there. In the end, some decision is to run about 18 pages, 20 pages, 25 pages. My seniors used to, some of the lawyers used to advise, don't give the long report. The judge will come heavy on you. I said, nothing doing. It should be an opinion, a judgment on every issue raised by the concerned official. And should be the judgment on everything. And I think none of the decisions so far, I mean, I retired again more than 10 years back, 11 years back, 10 years back. None decision has come back actually. No decision was overturned by any court because court looks at only one thing. I think that's a very important for you as an administrator actually. When you rise to those positions, if your decisions are reasoned, judges, they don't go into the depth actually. If somewhere you have just decided without giving the reason why you have done that, why you accepted one version, why you have rejected the other version, courts take that line only. There was no application of mind here. This is the standard line put by the courts. Courts will never put a line if it is your reasoning is there. They respect most courts, every court I saw, in my opinion, they all respected the opinion when it was a considered view actually. This is the reason why it is wrong. This is the reason why it is right. And the person has been given the chance to represent also. Person has been given a chance to be heard also. And I think that way, that is one complication which again this slows your functioning as an administrator actually. So when you become you are heading an institution, organization, university, I think that becomes very critical, very important, and I think that matters at that time actually, because if a lot of decisions get stuck in the court, people stop taking recruitments, they will take a beat, everything go into a spin actually. I think that's become very important, that part way. Another, I think, again, one option you have, that's your temperament, I tell you. And that's purely your subjective, I tell you. You can be a fighter, you can be a negotiator. So you can be a fighter like KPS Gill, you finished off everybody. Or you can have a patience like Narasimha Rao. These are the type of examples, Narasimha Rao is certainly one of the, I think, to my opinion, one of the best prime ministers India ever had. See, under him, the liberalization of science, liberalization of the administration, all everything happened during him only. So whatever the India is there today, of a liberal India with growing everything, that all started with him. But he was a silent person, he had a lot of patience actually. And he without talking, he would take a decision, he could implement anything actually. So whether he was handling Kashmir, he was handling Punjab, or he was handling the science and technology, that time only the liberalization happened. That means the directors, vice chancellors, they could import the thing directly. Otherwise, before that, we used to go to the Udyog Bhavan for every permission actually. So that all stopped during his period only. That time, this senior, junior, that big people will be given grants. Then this small grants for young people, for everybody. This all happened during his period only. So I think a visionary leader, but a non-talking leader. So as a top person, you should not be talking too much. That's, I think, one very important part. If you have a guts actually, and your skills are of sometime taking a harsh decision, but then you should be clear that can you implement it? See, many times you take a decision against your employees. Those employees will go to a politician, or they will go to your superior, whosoever is there. And that time, usually the opinion on the superior or the politician is कैसे ये problem diffuse हो जाए. वो कभी आपके साथ नहीं होंगे. They will never be with you actually. And you feel totally alone. So leader is alone. So when you are alone, that means you have to be responsible for your decision actually. So then you should be very clear. Can you do it actually? There is nothing like a rule there, I tell you. This is purely opportunism. They want the thing to work. So mostly directors, vice chancellor, they are made their scapegoat. ठीक है, कि भैया इसको छुट्टी पे भेज दो, इसको ये कर दो, ये वापस कर दो, ये कर दो, तो आपका फिर सब चीज कोलैप्स हो जाती है। लेकिन अगर आप में आपकी स्किल बोलती है कि आप नहीं उसको, यू विल सेल थ्रू, यू विल डिसमिस 20, 30, 40 पीपल एंड एट द सेम टाइम यू विल सर्वाइव विदाउट द सपोर्ट ऑफ योर सीनियर, ठीक है, तब आप करिए वो। अगर आपको लगता है कि ये नहीं हो पाएगा, अपने सीनियर के माइंड को जानते हैं आप, और आपको लगता है सीनियर आपका साथ नहीं देगा, ये देगी, तो बेस्ट इज अडॉप्टिंग ए कोर्स ऑफ ए मिडिल पाथ. Leave a room. Don't fight with your juniors, or don't. I mean, should have a lot of patience dealing with this type of people, whether they are colleagues, they are the unions and your staff. Patience चाहिए उसमें, उनको थका दो आप, क्लियर कर दो कि आप ये काम करेंगे नहीं, बट एट द सेम टाइम यू आर पोलाइट। आप उनको सस्पेंड भी नहीं करेंगे, आप ना तो एक्शन लेंगे उनके अगेंस्ट, ठीक है। तो अगर पेशेंस है आपके साथ और आप उनका कोई चीज मानेंगे भी नहीं, तो जब नहीं मानेंगे तो ये जो भीड़ है वो धीरे धीरे कम हो जाती है। लोग उनके साथ होते हैं कि उनको लगता है कि इनके जरिए हम अपना करवा लेंगे। जब लगता है कि नहीं होना है ये, और आप पोलाइट भी हैं, प्लेजेंट भी हैं, तो कुछ नहीं कर पाते। मैं जब मेरी यूनियंस द्वारा मुझे मिलने आती थी तो मैं उनको मिलता था, पूरा घंटों लगाता था उनके साथ। अच्छा, उन्होंने कुछ उसमें रश बहुत कुछ बोलेंगे भी, ऊट पटांग भी, तो अपनी ईगो दबा लो, ठीक है, थोड़ा ब्लड प्रेशर की गोली बढ़ा लो थोड़ी, पर ईगो दबा लो। लेकिन शाम को उनको खाना भी खिला के भेजता था मैं उनको। तो उसके बाद क्या करेंगे वो जाके? कुछ भी नहीं कर पाते थे, वो कुछ नहीं कर पाते थे। सब डिफ्यूज हो जाता, अपने आप ठंडे पड़ जाते थोड़े दिन के अंदर। सो आई थिंक वो जो था, मैंने और उनको मैं बोला था, भैया देखो मैं इसका फॉलोअर हूँ, प्राइम मिनिस्टर का, तो मैं तो ऐसे ही चलूंगा, लेकिन तुम्हारी बात मानूंगा भी नहीं। होना ये है जो गवर्नमेंट के अंदर है, सिस्टम के अंदर है, ये सबके हित में है, ये होना है, लेकिन आपको रास्ते पे आना पड़ेगा। लेकिन फिर अगर जो कोई हाथ में फंस गया, जिसने गलती की है, जिसके आपको इंक्वायरी से प्रूव कर सकते हो, फिर उसको मत छोड़ो आप। देन लेट एवरीबॉडी गो। वो ह्यूज लिस्ट है जो वर डिसमिस्ड एक्चुअली, जिनको कोई बख्शना नहीं चाहिए किसी को भी। बट जो परसिस्टेंट बन गया है, दैट मीन्स कि एक बार भी, दो बार भी, तीन बार भी, देखिए आवर फिलॉसफी, व्हेन यू टॉक ऑफ आवर स्क्रिप्चर्स आल्सो एवरीवेयर, भगवान कृष्ण के भी जब एग्जांपल लेते हैं तो क्या एग्जांपल यही आता ना कि 99 बार दिया, 100 बार दिया। आपको बोले एक झटके से यार ये रैश नहीं होना चाहिए कि यार इसने मुझे ऐसा बोला तो उसको मैं आज ही रगड़ दूंगा, मैं इस कुर्सी पे हूं तो मैं ये एक्शन ले लूंगा, इसको सस्पेंड कर दूंगा, ये कर दूंगा। क्योंकि दैट आई थिंक मोस्ट टाइम यू हैव टू गो बैक एक्चुअली, और आइदर यू हैव टू गो बैक और यू गो, ठीक है। अब तो उसमें आई थिंक जो बेस्ट अपॉर्चुनिटी यही रहती है कि आप अपने को चेंज करो एक्चुअली। ईगो उस टाइम अपने को जस्टिफाई करना मुश्किल पड़ता है। क्योंकि मैं जब एज ए डायरेक्टर था तो मुझे बड़े होता था, हमारे पास 2 यूनियन थी। एक यूनियन में बड़े आइडियलिस्टिक लोग थे, वो काम करते थे खूब सारे, पर उनके काम करने वालों के साथ कुल 20% लोग भी नहीं थे। तो दैट मीन्स कि देखो हमारी सोसाइटी जैसे बन गई है, और अब सब इंस्टीट्यूशन की वही हालत है, इट इज द सेम स्टोरी एवरीवेयर। जो अच्छे लोग हैं उनका परसेंटेज वही है 20-25%, तो उनकी अगर यूनियन भी होगी तो उनका नंबर वही 20-25% ही होगा। दे आर टू बी नर्चर्ड, दे आर टू बी लिसन्ड, उनकी ओपिनियन शुड बी रिस्पेक्टेड। लेकिन भीड़ तो वो 70-75 तो उधर साइड पे है। अब वो हमारी सोसाइटी बन चुकी, वैसे पूरे कंट्री में इज द सेम स्टोरी। तो 70-75% वो हैं जो बदमाशी करके अपना टाइम निकालना चाहते हैं। अब उन 75% के साथ आप 75% को निकाल तो नहीं सकते एक झटके के साथ। आपने उनको न्यूट्रलाइज करना है, सो दैट दे गेट टू द वर्क एक्चुअली। यू हैव टू चेंज द एनवायरनमेंट इन अ वे दैट दे स्टार्ट वर्किंग। उन्हें जो बीच के 50% फेंस हिटर हैं, दे गेट इनटू द वर्क एक्चुअली, एंड दे डू गेट इनटू द वर्क। This is something I have seen in my life. All they get into the work. अब you very, आप उनके जो क्राइटेरिया प्रोडक्टिविटी के रखो, उन चीजों को मॉनिटर करो, उनके साथ पोलाइटनेस रखो। 50% फिर घूम के उधर आ जाते हैं, 1 साल 2 साल लगे, दे ऑल गेट बैक टू दैट। तो आई थिंक जो एडमिनिस्ट्रेटिव में आपको आपकी साइकोलॉजी चेंज करनी पड़ती है। आपको यू हैव टू जस्ट किल योर इंस्टिंक्ट, दैट एंगर फॉर ए वाइल, बट वी रिमेन फोकस्ड टू आइडियल, बैक द राइट थिंग, खुले बैक करो उसको, और उनके साथ पेशेंस रखो। अगर आप में दम है, अगर आपको लगता है कि एक बार में आप इतनों को निकाल के आप सरवाइव कर सकते हैं, तो वो भी करो। मैं ये नहीं कहता कि डोंट डू दैट, बट उसके कामयाबी के चांस आर नॉट वेरी हाई, बिकॉज आई हैव सीन एवरीवेयर, आई टेल यू, आई हैव सीन एवरीवेयर एटलीस्ट इन माई लाइफ आई हैव सीन, तभी आपके जो सुपीरियर जो होते हैं वो अपॉर्चुनिज्म पे रहते हैं, आपको लाइक भी करते हो, लेकिन उस वक्त जब क्राइसिस खड़ी होगी वो चाहते हैं यार कैसे मामला निपट जाए, दिस शुड पास ऑफ। वो कोई उस कोर्स को, जो गोली चलाने वाले कोर्स का बैक नहीं करता कभी, चाहे गोली राइट भी चली हो फिर भी वो बैक नहीं करेंगे। आप देखिए कितनी बार पुलिस की गोली चलाती है, वो अपनी मर्जी के लिए थोड़ी गोली चलाती है, क्योंकि एंड में एक्शन उनके ऊपर ही होता है। दिस हैपेंस विद एवरीबॉडी, आई टेल यू, दिस इज द स्टोरी ऑफ आई थिंक दिस सोसाइटी एक्चुअली। तो वी मस्ट एक्सेप्ट दैट, जहाँ के हम हैं उसकी अच्छाइयाँ भी बहुत सारी हैं, जो जो प्रॉब्लम वो भी यही है। तो बेस्ट एज ए लीडर यू हैव टू बी ऑफ योर ओन, आपको अपने पे रहना है, आपको अपना सोचना है कि मैं क्या करके बच सकता हूँ और निकल सकता हूँ। क्योंकि एंड में अगर आप देखेंगे कि मैं इतनी चीजें मैंने डेवलप कर ली, सी आपको क्या याद रहेगा, आई कुड डेवलप सो मेनी थिंग्स। मैं चाहे हेड ऑफ डिपार्टमेंट रहा, चाहे डायरेक्टर रहा, वाइस चांसलर रहा, प्रिंसिपल रहा, मैं ये चीजें कर पाया या कर पाई ये अपने पीरियड में, आपको वही याद रहेंगी और लोग भी वही याद रखेंगे। अब वो करने के लिए इतनी सारी ट्रबल है चारों तरफ की, वो ट्रबल्स आपको अपनी पेशेंस से डील करनी है, और उन लोगों की फीलिंग उनको समझ के कि उनको चाहिए क्या एक्चुअली, इट हैज टू बी फेल्ट नीड ऑफ द पीपल। ये वायरोलॉजी स्कीम जो पूरी, जो बाद में कोविड में अच्छी काम आई, देखो मैं आपको आज भी मैं एग्जांपल देता हूँ उसका। ये शुरू हुई स्वाइन फ्लू के साथ से। स्वाइन फ्लू से पहले जो आई 2010 में पहली पेंडेमिक आई, तो जल्दी फॉर्चुनेटली टेमी फ्लू को सेंसिटिव थी इसलिए वो जल्दी गिर गई, लेकिन उससे उसके भी कोविड की तरह हालत बिगड़ सकती थी काफी। तो जब वो आई स्कीम, तो सडनली एक दिन जब बात थी, पहले दिन आई कि 12 लेबोरेटरियां या 15 लेबोरेटरियां थी जो इन्फ्लुएंजा के ऊपर थी, नेटवर्क था आईसीएमआर के जरिए फंड हो रहा था। फिर डीजीएसएस के थ्रू एनसीडीसी का नेटवर्क था सर्वेलेंस लैब्स का, वो भी इतनी थी, 15-20 ये भी थी, तो टोटल मिला के लेस देन 30 से कम लेबोरेटरी थी जो जो इन्फ्लुएंजा को टेस्ट करने की कैपेसिटी थी। बाकी कंट्री पूरा खाली पड़ा हुआ। और मिनिस्टर हमारे गुलाम नबी आजाद थे उस समय, वो हमारी उन्होंने रिव्यू ले रहे थे सारा। तो उन्होंने रिव्यू लेते लेते पहले तो एक चीज उन्होंने मुझे सिखाई जो मुझे बहुत अच्छी लगी बाद में, मैंने उनको अब इज रिपोर्टिंग ऑन माई सिस्टम कि मेरे आईसीएमआर के थ्रू कितना है, क्योंकि डीएचआर की तो अपनी लैब नहीं थी कोई भी। मैं सर वहाँ पे इतनी लैब्स हैं, तो बोले उनकी दूसरों की कितनी है, मैं सर दूसरों की तो मैंने नहीं पूछी भी नहीं। तो बोले भाई ये तो मैं आई डोंट एक्सपेक्ट, मैं सेक्रेटरी से ये तो एक्सपेक्ट नहीं करता कि वो दूसरे का उसको पता नहीं, कंट्री तो एक है, कंट्री में तो एक ही सेक्रेटरी है, सो यू कांट से कि दूसरे का आपको पता नहीं है, आप उनके आपके अंडर नहीं है, लेकिन आप पता करिए क्या है कितना है। अच्छा मुझे बात बिल्कुल स्टक करी उनकी बात, ये मेरे को बिल्कुल सही बात है। उसके बाद मैंने कभी बात नहीं करी कि आईसीएमआर का है, डीएचआर का है कि दूसरे का, दैट वाज आई थिंक ओनली टाइम। उसके बाद मैंने वो टर्म ही नहीं यूज की अपने पूरे अगले कैरियर में पूरे में उनके साथ। सेकंड चीज उनके बाद फिर हमने फिर पूछा, फिर उन्होंने सारे मुख्यमंत्रियों से फोन कर रहे थे उस दिन, सबको पूछ रहे थे कि आपके कितने केस हो रहे हैं, कितनी जल्दी से फैल रहा है। और लास्ट टॉक हिज कॉल वाज टू मायावती जी, यूपी की चीफ मिनिस्टर थी, और मैं सामने बैठ के नोट्स ले रहा था सारे। तो फिर उसके बाद जब चलने लगे तो बोले कि साहब ऐसा है कि कटो साहब इतनी इतनी लेबोरेटरीज है, 20-25 लेबोरेटरी से मुल्क कैसे चल सकता है, ये इतने बड़े लोग का जब फैलेगा तो कितनी जगह फैलेगा, ये कितनी स्पीड से फैलेगा, कितनी स्पीड होगी उसकी, लोग बोलेंगे कहाँ टेस्ट हैं, कैसे होंगे पूरे, ये एपिडेमियोलॉजी कैसे, इसकी जो ट्रांसमिशन कैसे वर्कआउट होगी। सी दिस बीइंग टॉक्ड बाय ए वेरी एस्ट्यूट पॉलिटिशियन, ठीक है। मैं वापिस आ गया रात को, मेरे दिमाग में तो स्टक की बात ही बड़ी सीरियस है। सुबह में उठा ही, अभी उनका, मैं भी घर पे ही था, अभी 8 बजे करीब उनका फिर फोन आ गया कि रात को जो मैंने कहा था आपने क्या सोचा इसका। तो मैंने कहा हम नेटवर्क बनाएंगे। बोले हाँ बनाएंगे, तो फिर जाके मुझे बताओ क्या करें, कैसे करेंगे। हाँ आई केम टू आईसीएमआर, मैं गेस्ट हाउस यहीं रहता था हमने खेल गाँव में। मैं आईसीएमआर आया तो फिर मैं अपने कोलिग को पूछा, तो कोलिग कहते हैं यार 5 प्रपोजल्स हैं हमारे पास ऑलरेडी, जहाँ पे एक नोडल सेंटर बन सकते हैं। बाकी मैं कहा ठीक है, बाकी उनसे आप हम एक टायर सिस्टम बनाएंगे, उसकी फंडिंग कितनी चाहिए उसकी मुझे प्रपोजल आइडिया बताओ शाम तक। मैं मिनिस्ट्री गया, मैंने अपने ज्वाइंट सेक्रेटरी को बुलाया, वो साहब वो कहते हैं सर यहाँ पे हम कोई भी एक ढिला नहीं खर्च कर सकते जब तक उसकी स्कीम नहीं है। सेक्रेटरी की पावर डीजी से 60 गुना ज्यादा है, पर वो वहाँ पे गवर्नमेंट के अंदर हर चीज के कैबिनेट से अप्रूव स्कीम चाहिए, सो यू कैन नॉट डू एनीथिंग बियॉन्ड दैट, ठीक है। वो करने, वो जब स्कीम अप्रूव हो जाए तो उसके बाद कुछ भी उसको बढ़ाते रहिए, कितना भी करिए उसके बाद। तो अब जो बात बन गई, मैंने कहा ये तो सोल्यूशन साफ है। फिर जो स्कीम है जो मुझे करनी है छोटे छोटे लेवल पे मुझे ICMR से करनी है। DG ऑटोनॉमी है खूब सारी, पर एक एक आइटम के पैसे की कैपेसिटी इज लिमिटेड, ठीक है, लेकिन ऑटोनॉमी तो है। सो दैट वे ऑटोनॉमी इज फार बेटर देन द बिग माइट ऑन द अदर साइड। तो मैंने कहा चलो हम यहाँ से छोटे छोटे जो जो लोग रेडी हैं उनके लिए सेंटर फंड कर देंगे। तो 5 वो स्कीमें थी, उन लोगों को बुलाया, उनको कही ये साइंस मोड में नहीं होंगी, दे विल बी इन सर्विस मोड। और सर्विस मोड में आप आउटपुट देखेंगे किस किस एरिया को आप सर्व करेंगे, उसके साथ साइंस भी करो। जो आपके जो मांगे साइंस के लिए पैसे, वो साइंस भी करिए आप साथ में। लेकिन इस एरिया के जितने मेडिकल कॉलेज, जितने हॉस्पिटल से जो चीजें सैंपल आएंगे उनके लिए डायग्नोस्टिक सर्विसेज भी क्रिएट करनी है, वो प्रायोरिटी रहेगी पहले ही। और फिर जब शुरू कर दिया ये सारा, तो बनते बनते पहले 8 लेबोरेटरियां फंड करी हमने नोडल, फिर छोटी छोटी मेडिकल कॉलेज लेवल फंड करी, मे बी 30-40 लेबोरेटरी और फंड हो गई। पर तब तक क्योंकि टेमीफ्लू जो भी लगता है टेमीफ्लू खिला देते थे, उससे उसका जो सीवियरिटी कम होती गई, या पेंडेमिक का रेट गिर गया। लेकिन एक स्कीम वायरोलॉजी रिसर्च डायग्नोस्टिक लेबोरेटरीज की स्कीम बन गई, और उसी पीरियड में मैं अपने पीरियड में ही 50 से ज्यादा लेबोरेटरीज एस्टेब्लिश कर गया। मेरे स्कीम थी पूरी 258 लैब्स की, 50 तो मैं ही सैंक्शन कर गया अपने पीरियड में। उसके बाद जो आने वाले सक्सेसर ने खूब बढ़ाया उसे। चले चले अब देखिए, वो जो कोविड का टाइम है तो ऑलरेडी सारे मेडिकल कॉलेजेस में ऑलरेडी थी। मुझे नहीं मालूम था कोविड आने वाली है, तो लोग मेरे को क्रेडिट देते हैं, लेकिन मेरे को थोड़ा पता ये समस्या आने वाली है। मेरा तो एकमात्र गोल ये था कि मेडिकल कॉलेज शुड बी एम्पावर्ड टू डायग्नोज 50 डिजीजेस, 50 कॉमन वायरल डिजीजेस को उनको पुणे नहीं भेजना पड़े, उनको NCDC को नहीं भेजना पड़े। दैट वाज द ओनली गोल ऑफ माय लाइफ, कि हमारे मेडिकल कॉलेज शुड बी पावरफुल इनफ टू डायग्नोज द कॉमन 50 कंडीशंस, और अपनी एरिया से और जोड़ लें जो जो उनको अच्छी लगती हैं, जो इंपॉर्टेंट लगती हैं। तो एम्पावरिंग द मेडिकल कॉलेजेस बाय द होल गेम आई केम अप विद। लेकिन वो जब से बनी तो किसकी पुश से बनी? देखिए, वो डिमांड से बनी ना, उस वक्त की नीड खड़ी हुई, उस वक्त के जो पॉलिटिशियन ने बैक किया उसकी उसने so ultimately you have to listen to others. Actually you have to listen, your articles should be open to the needs of the people, not okay, I'll create this, or my department will create this, or my university will create this. I and my should not be the anywhere. Actually it should be the felt need of the people. तो अगर उन चीजों का इम्प्रिंट है, मेरे बाद 3 सेक्रेटरीज निकल गए, बाल साहब तीसरे चौथे हैं उसके बाद, तो वो स्कीमें सब चल रही हैं। इन्होंने और लेवल पे इन्होंने दूसरी इन्फेक्शन डिजीज भी उसमें जोड़ दी हैं, बहुत और एक्सपेंड किया। तो एवरीबडी हु कम्स टू दोस चेयर्स ब्रिंग्स ए डिफरेंट फ्लेवर, डिफरेंट थिंकिंग, डिफरेंट एक्सपेंशन। लेकिन स्कीम की सार्थकता थी तो वो रेलिवेंट है, वो आज भी रेलिवेंट है, 15-10 साल बाद भी, 12 साल बाद भी रेलिवेंट है। तो आप जब कहीं से रिटायर हो जाएं तो आपके जो सक्सेसर हैं अगर उल्टा सीधा करना भी चाहेंगे तो वो उतना ही कर पाएंगे जो उनकी इमेजिनेशन होगी, बेसिक स्ट्रक्चर को नहीं डिस्टर्ब कर पाएंगे, क्योंकि वो लोगों की नीड है। इफ यू हैव क्रिएटेड समथिंग बेस्ड ऑन द नीड ऑफ द पीपल, देन इट विल नेवर गो। आप चले जाएंगे तब भी वो इतिहास जो है वो स्टोरी वहीं आपके साथ होगी, और आपको सेटिस्फेक्शन रहेगी। अगर आप जिंदा रहे तब तक देखने के लिए, तो आपको लगेगा कि ये मेरी बेवकूफी नहीं थी, ये मेरा सही फैसला था बैक करने का। तो आई थिंक ये जो लाइफ की जो स्टोरीज हैं एज ए एडमिनिस्ट्रेटर, एज ए से व्हेन यू थिंक एज ए, आज लीडर की बात हो रही है, एज ए साइंटिफिक लीडर, एज ए साइंस मैनेजर, एज ए प्रोफेशनल लीडर, तो इसमें जो मुझे चीजें लगी, थिंग्स जो पॉजिटिव रही मेरे साइड पे, वो यही थी, जो इंक्लूसिविटी वाली, दूसरों की बात कर, व्हाट दे वांट, व्हाट दे नीड, देन अडॉप्टिंग द मिडिल पाथ। और नेगेटिव बात भी मैंने आपको बता दी कि नेगेटिव बात वही थी। और क्योंकि आप जो बदमाश है उसके ऊपर बहुत इंडेफिनिटली सॉफ्ट नहीं हो सकते, एंड देन यू शुड बी, आई मीन इवन वेरी क्लियर इन, आई थिंक, टेकिंग एक्शन अगेंस्ट इवन द पीपल हु आर क्लोज टू यू आल्सो। आई थिंक you should not be guided by emotions, क्योंकि मुझे लगा कि मैं अपनी लाइफ में मेरी जो कामयाबी का और जो थी, आई लाइक द गुड ह्यूमन रिलेशनशिप्स एक्चुअली। तो मेरे जो स्टाफ थे, चाहे वो किसी भी ग्रुप के थे, किसी भी क्लास के थे, सब में ओपन एक्सेस थी मेरी। कभी उनको अपॉइंटमेंट की जरूरत नहीं थी किसी को भी, किसी भी लेवल पे, वो सभी के लिए थी, चाहे वो पीएन है, चाहे वो लैब अटेंडेंट है, लैब टेक्नीशियन है, किसी भी लेवल पे है, या आपका कोलीग है या आपका सीनियर है कोई भी, वो तो पॉजिटिव साइड है, को मुझे अच्छा लगता है, दैट गिव्स मी ए पॉजिटिव फीलिंग। बट एज ए एडमिनिस्ट्रेटर उसको डर भी होना चाहिए कि अगर ये भैया अगर मैंने नहीं किया इस पीरियड में तो ये एक्शन हो जाएगा मेरे पे। आई थिंक दैट वाज द ओनली लिमिटेशन आई थिंक इन माय व्हेन आई लुक बैक। पर बाकी जो थे कैरेक्टर वो मेरे भगवान ने पॉजिटिव साइड पे दिए, और वो सभी आपके सबके अंदर वही कैरेक्टर होंगे, कोई डिफरेंट नहीं है। मैं आपको बताऊं, ऑल ह्यूमंस आर सिमिलर, ऑल ऑफ अस, जो मैं बोल रहा हूँ मेरे में है वो आपके अंदर भी वही हैं सारे प्रिसाइजली। नाउ हाउ यू यूज दैट अप एक्चुअली, how you synthesize that, how you convert that into the larger goals, वही बाद में झलकती है। और हर किसी को देखो ये बात सोचने की भी नहीं है, हर कोई डायरेक्टर बनने की क्या आवश्यकता, कोई मतलब नहीं है। बहुत सारे लोग नेवर बिकम डायरेक्टर्स, बट दे आर मच मोर बिगर देन डायरेक्टर्स। इसी इंस्टीट्यूशन से एम से ले लीजिए, पी एन टंडन जैसे एग्जांपल, अब उन्होंने तो हर सेक्रेटरी उन्होंने सिलेक्ट किया होगा, इवन मेंबर ऑफ सिलेक्शन ऑफ ऑलमोस्ट एवरी कमिटी ऑफ एवरी सेक्रेटरी एक्चुअली। तो वो खुद तो नहीं बने ना, तो लेकिन उन्होंने सब बनाए, बाकी तो देश तो उन्होंने गाइड किया। तो आई थिंक वो जो पोजीशंस भी बहुत ज्यादा मैटर नहीं करती। जैसे आप किसी डिपार्टमेंट के हेड है और उसी में आप हिस्ट्री क्रिएट कर जाते हैं, मतलब ये हु क्रिएटेड दिस डिपार्टमेंट, व्हाट वाज द थिंग्स वर डन ड्यूरिंग दैट हिज और हर पीरियड, वही इतिहास है एक्चुअली। आने वाला टाइम में उसमें से इतने लोग प्रोड्यूस होते हैं, दे क्रिएट द हिस्ट्री एक्चुअली। तो ये जो डेकोरेटिव पोजीशन वाला आज टुडे जो मैं आपसे बोल रहा हूँ, तो डोंट जज मी एज ए डायरेक्टर ऑफ इंस्टीट्यूशन और डीजी ऑफ आईसीएम और फॉर्मर सेक्रेटरी, वो तो ठीक है, चांस की बात थी, मैं वहां पहुंचा और बहुत सी चीजें मैं छोड़ पाया जो पॉजिटिव है। लेकिन वो जरूरी नहीं है एक्चुअली, क्योंकि हिस्ट्री तो हर जगह की उतनी इंपॉर्टेंट है एक्चुअली। आई थिंक मैनी पीपल क्रिएट हिस्ट्रीज एट ऑल लेवल्स, बिकॉज मुझे जो आज मैंने आपके जो सरसरी तौर पर जब ये इन्वाइट किया था, देखा था मैंने सबके, आप लोग सब लीडरशिप पोजीशन में तो ऑलरेडी हैं आप सारे, आप या तो डिपार्टमेंट्स हेड कर रहे हैं या इंस्टीट्यूशन के किसी सीनियर लेवल पे हैं आप लोग। तो आई थिंक वो सिचुएशन कोई कुछ नहीं बदली, सिचुएशन वही है सारी की सारी। आपके पास आज भी वही अपॉर्चुनिटी है, कल भी वही अपॉर्चुनिटी है। बट आई थिंक द क्वेश्चन इज हाउ यू चेंज योर माइंडसेट एक्चुअली टू अचीव द गोल। गुण जो मैं बोल रहा हूँ वही सब आपके अंदर भी है। आप प्रोफेशनली भी आप कॉम्पिटेंट हैं, आप प्रोफेशनली अकॉम्प्लिश्ड भी हैं, आप कर भी वही रहे हो जो मैं बोल रहा हूँ अभी तक। जो मैंने कुछ बोला वो आप सब आपको भी रिफ्लेक्ट कर रहा होगा कि हाँ मैंने भी ये किया। तो सबके इतिहास तो सेम है, बट हाउ यू कन्वर्ट दैट स्टोरी इनटू ए बिगर स्टोरी, दैट्स द क्वेश्चन एक्चुअली। वो आप अंदर सोचने का, आपने अंदर सोचने का सारा। और एक इसमें एक सवाल और लिखा था कि अपने सीनियर से कन्फ्रंटेशन कैसे बचानी है, ये विच इज आल्सो वाइटल पार्ट। आई थिंक इज वन ऑफ द क्वेश्चंस, टॉप क्वेश्चन क्वेश्चंस ड्राफ्टेड बाय प्रोफेसर कपिल, जो हमें दिया पिछली बार उन्होंने, आज फिर अभी दिखा मुझे ये। आई थिंक एक चीज साइकोलॉजी में रखो आप, हर किसी की जिम्मेवारी है, एवरीवन हैज रिस्पॉन्सिबिलिटी। कभी ये मत सोचो कि सीनियर को कैसे एक्ट करना है, सीनियर की अपनी जिम्मेवारी है। अब ये छोड़ के अगर आपने को अलग कर लेते हो, इफ यू बिकम सेपरेट डिफरेंट, फिर आपको भी कंफ्लिक्ट में नहीं हो। बट द सीनियर डज ही और शी इज हर और हिज प्रॉब्लम। अब मत सोचो इसके ऊपर। तो जब मान लो मैं साइंटिस्ट था तो डायरेक्टर क्या कर रहे हैं, तो मैं कभी डायरेक्टर से कन्फ्रंटेशन में नहीं हूं। मैं डायरेक्टर से, मेरी ओपिनियन डिफरेंट है, मैं उनको बता दूंगा अलग से, लेकिन मैं आई विल नॉट अपोज द ऑर्डर्स, ठीक है। सो आई थिंक एज ए सिस्टम यू शुड नॉट बी अपोजिंग एनीथिंग, यू शुड नॉट बी रेबल ऑल द टाइम। ये बात तो मैं बोलता हूँ, ये जो जितने लोग मैंने रेबल देखे हैं वो दे जस्ट अपनी ईगो सेटिस्फाई करते हैं। मैंने डायरेक्टर को सुना दी, मैंने उसको सुना दी, मैं उसको बोल दिया, उससे ज्यादा क्या कर आपने, व्हाट यू अचीव्ड इट आउट ऑफ इट, नथिंग। सेकंड चीज ये है कि आप सीनियर के डिसीजन को रिस्पेक्ट करना भी सीख लो, क्योंकि जब आप सीनियर होंगे तब भी आपके भी डिसीजन, यू वांट योर डिसीजन आल्सो टू बी रिस्पेक्टेड। और जब आप डिपार्टमेंट के हेड हैं तो आप चाहते हैं कि आपके सब कोलीग्स आपकी सुने, तो फिर आप डायरेक्टर की क्यों नहीं सुनेंगे? सी द पॉइंट इज दैट इज वेरी सिंपल, यू डोंट रिमेन इन कॉन्फ्लिक्ट। एंड द पॉइंट वाज, जब भी मुझे लगा कि ये प्रॉब्लम आएगी, मैंने आपको बताया कि मैं जूनियर कैसे डील किया, सीनियर के साथ भी आया, तो मैं उनको अलग से मिला, अपनी ओपिनियन अलग एक्सप्रेस करी, मैंने कभी उनको कन्फ्रंट नहीं किया। मैंने अपनी बात रख दी कि सर ये वाली बात से मैं सहमत नहीं हूं, मेरी राय ये है, ये करने के, ये मेरी लॉजिक भी यही है, लेकिन कोई गड़बड़ नहीं होनी चाहिए, कोई प्रॉब्लम नहीं होनी चाहिए। और जो लेटेस्ट मुझे एग्जांपल जो दूसरे आदमी ने ये करके दिखाया, मैं जिपमेर का 5 साल जो प्रेसिडेंट था 2019 से 24 तक, क्योंकि जिपमेर पुराना इंस्टीट्यूशन है, एज ए टेल दिस, उसका दायरा भी बहुत बड़ा, अपना मेडिकल कॉलेज अलग है, दूसरे उनका पूरी टेरिटरी में चलता है सारा, इज ए कम्प्लेक्सिटी एक्चुअली। तो वहां पे बहुत सारे ह्यूज इश्यूज थे सारे, लेकिन क्रेडिट आई गिव टू द डायरेक्टर ऑफ दैट प्लेस एंड हिज डिप्टी डायरेक्टर्स एक्चुअली। वो कामयाबी में जो मैं कर पाया, उसकी कामयाबी का आई थिंक दो तिहाई उनकी वजह से है। पहले मैं हर महीने जाता था और निपटाने उनका मामला, 3-4 दिन रहता था, 3-4 दिन में उनके जो कॉम्प्लेक्स केसेस थे, क्योंकि डिफाइंड आपके एक्ट में डिफाइंड है कि प्रेसिडेंट की क्या रिस्पॉन्सिबिलिटीज है, डायरेक्टर की क्या है, सब डिफाइंड है। तो अब जो जो चीजें मुझे करनी थी मैं निपटा के आ जाता था। उसके बाद बीच में फिर ये कोविड आ गई, मेरी ट्रेवलिंग हम कोई किसी की भी नहीं थी ज्यादा। कोविड के बाद में मेरा कोई हेल्थ रीजंस आ गए बहुत सारा, आई नॉट एबल टू ट्रेवल मच। तो उनके जो डिसीजन करेक्ट होते थे वो उसी दिन मैं प्रिंट आउट लेके आई यूज्ड टू एक दिन के अंदर उनको करके मैं भेज देता था। जिसमें मुझे लगता था मैं नहीं करा, तो उनके डायरेक्टर की स्किल देखिए, वो और उनके डिप्टी डायरेक्टर हर महीने 2 दिन के लिए जयपुर आएंगे, उन्हीं केसेस के उन्होंने वर्कआउट करके लाएंगे कि उनकी ओपिनियन उन्होंने क्यों जस्टिफाई किया। कोई कहीं कोई लिखित पढ़त नहीं, कोई फोन नहीं, कुछ नहीं। वो दोनों करेक्टर्स मेरे साथ रहेंगे, आधा दिन रहेंगे एक दिन, आधा दिन अगले दिन रहेंगे, और पूरा बता के सर अपनी बात एक्सप्लेन करेंगे। एंड आई टेल यू, हाफ ऑफ द टाइम आई एग्रीड विद द डायरेक्टर आफ्टर लिसनिंग टू देम। वही रीजनिंग मैं अपने ऑर्डर में देता था कि ये रीजनिंग इसकी ये है। वो क्या करते थे, रूल लेके आते थे, सारा रूल बताते थे और अपने प्रेसिडेंस लेके आते थे इंस्टीट्यूशन की, क्या करने का, व्हाट विल बी द इम्पैक्ट एक्चुअली ऑन दैट। So I think there was never, 5 years, there was never a bitter feeling between the director and the president that उनको नहीं कभी लगा कि मेरी चीज मैंने उनकी चीज नहीं मानी जो उन्होंने रिकमेंड करके भेजा था। Half of the time still like I didn't agree with them, but they never disrespected that, and there was never a bitterness. The relationship remains as close, I think, as ever, even a year later after the things are over actually. तो क्या होता है कि सीनियर के साथ जब आपको लगता है कि ये समस्या, ये इशू है कि नहीं, डिसएग्रीमेंट है, तो डिसएग्रीमेंट के लिए तो सीनियर बनाया है ना एक्चुअली। अगर आपकी हर चीज जो वहीं पे, अगर जो आपके सिग्नेचर ही काउंटर साइन होने, तो वाई दे शुड बी नीड ऑफ ए हायरार्की एक्चुअली। वाई यू नीड ए प्रेसिडेंट, वाई यू नीड ए मिनिस्टर, वाई यू नीड एक्चुअली द सेक्रेटरी ऑन द गवर्नमेंट, वाई यू नीड एक्चुअली द पीएमओ, बिकॉज इट हैज टू बी हायरार्की एक्चुअली। अगर आप वाइस चांसलर हैं तो आप चांसलर तो रखा है ना उसके ऊपर भी, तो चांसलर की ओपिनियन तो है ना उसके ऊपर भी। तो आप कन्फ्रंटेशन इज नॉट द वे टू सॉल्व द प्रॉब्लम। रेदर अंदर से अपने आप को हैप्पी कर लोगे, या अगर आपको लगेगा कि मुझे आई हैव टू मेरी जिम्मेवारी यहां एंड करती है, आई हैव नॉट टू बी क्रिटिक ऑफ ए डीजी इफ आई एम ए डायरेक्टर। डीजी का काम डीजी का है, सेक्रेटरी का काम सेक्रेटरी का है, मिनिस्टर का है। अगर वो राजनीति भी कर रहे हैं, अगर वो मान लो कोई चीज में ऐसी साइड यूज कर रहे हैं जो आपको लगता है डिस्ट्रक्टिव भी है, आप उसको भूल जाइए, वो उनकी जिम्मेवारी है, वो हिस्ट्री में उनके खाते में जाएगा, दैट गोज टू देयर अकाउंट एक्चुअली, दैट इज नॉट योर अकाउंट, आई टेल यू। फिर आपका अंदर से जो फीलिंग आती है वो खत्म हो जाती है, अंदर से जो कन्फ्लिक्ट है दैट फिनिशेस, अंदर से जो आपकी एंगर है वो खत्म हो जाता है। अगर है भी, अगर नहीं है तो बहुत अच्छा है, you should have a temperament where you should respect the opinion of the senior actually. ये ऐसा है तो ऐसे ही है। तो आई थिंक इफ यू एज जो लीडर वाली बात आ रही है, लीडर में आप अपनी जिम्मेवारी पे जाइए कि मेरा काम क्या है, व्हाट इज माय रिस्पॉन्सिबिलिटी, व्हाट इज माय गोल इन दैट चेयर एक्चुअली। एंड माई का अंदर दैट मीन्स us, that means the goal of the people whom you lead actually. It has to be the goal of all the people whom you're leading actually. And there has to be a way of reaching the decision making. And that should be objective. फिर आपको कोई conflict नहीं है, कोई difficulty नहीं है, कुछ नहीं है, बिल्कुल आप अपनी पूरे एरिया में निकल के ठीक ठाक से निकलोगे, और आप एंड में भी when you retire also, you superannuate also, you pass out from this world also, your conscience will be clear actually. You'll have you'll not be won't be in conflict, because देखो actually एक बात जो I think all of you should really reconsider one thing in life. हम लोग महसूस, we realize, we feel कि I have done so much work, ठीक है, so I deserve better opportunity to lead, or I have the capacity to lead, I should be given the opportunity to lead. ये legitimate feeling है. I think यही तो this is a human entire evolution actually. This is what the whole thing is all about. So nothing wrong about it. So being ambitious is nothing wrong. But then the second point arises. उसके बाद ये तो system है. If you are selected, that is the success of that selection committee or failure of that selection committee. अगर मैं कामयाब रहा तो मेरी कामयाबी के जिम्मेदार कौन है? वो कमेटी है वो जिसने मुझे पिकअप किया. It is not I. See, that committee could have picked any of those 5. ठीक है. Remaining 4 जिन मेरे कंपटीटर थे मैं उनके नाम नहीं ले रहा. उनमें से कई लोग आज भी शाइन कर रहे हैं. In very high positions. They deserve this position also. ठीक है. तो लेकिन लेंगे तो एक को लेंगे ना कोई. Only one will be chosen at a time. तो वो तो कोई चांस की बात है. हो सकता है पॉलिटिकल मैनिपुलेशन भी होती है बहुत जगह में. वो भी हो सकता है मे प्ले अ पार्ट. But you don't bother about that. You can look up of your qualities only, your performance only. You focus on that. मेरे हिसाब से जो पॉलिटिकल पाथ यूज करते हैं ना वो लाइफ में उनकी हिस्ट्री इज वेरी बैडली रिटन. आई डोंट थिंक एनीवन इज रिस्पेक्टेड एक्चुअली. लेटर इन द लाइफ यू शुड बी अ रिस्पेक्टेड पर्सन. दैट शुड बी द गोल एक्चुअली. तो आई थिंक यू बी क्लियर ऑन दैट. बी क्लियर ऑन दैट एक्चुअली. अपना गोल वही चूज करिए और उसी एजेंडा को फॉलो करिए आप. why should we there should be trouble. उसके बावजूद भी आप कामयाब होना का इक्वल चांस है. So I think you will succeed, I think. So you have a legitimate feeling, you have an aspiration, and you will get the opportunity also. But then after that, you have to charter your path. आता है ये A आता है तो perform for A. If B आता है तो perform for B. If C आता है तो perform for C. So I think then you don't be all the time a disgruntled person in the game. ये नहीं हुआ, I didn't get it. ये गड़बड़ हो गई, इसने ये politics करी. उस दायरे में मत जाइए आप. Keep on improving yourself. Keep on improving yourself. I think that is the only solution. Because I think your competition is with you only. Is not with none else. It is with you only. That's all. And that's in your hand. तो मैं आई थिंक यही मेरे ओपिनियन थी इन बहुत सारे कमेंट्स के ऊपर जो उन्होंने पॉइंट दे रखे थे मुझे. which I talked last time, but that time I had these in front of me. But this time I think my मेरे कंप्यूटर से गोल हो गए तो I forgot about them. Yes.
Thank you, sir. Thank you, sir, for giving sharing your experience of several years with all of us. And I think your presence itself is a source of encouragement. You came all the way from Jaipur for this talk only. The flight was delayed. He has to wait at the airport. And immediately he came for this session. I think the key point of this presentation is learning for all of us. He said that at whatever level we are, we should try to make efforts to improve our subordinate. It is not always necessary that when I become a director, when I am head of department, only then I will do something for the department or for my subordinate. So at whatever level we are, we can express our capabilities by developing of the department. And secondly, he has given practical tips how to handle the seniors, how to handle the bureaucrats. Because in our country, we have still the best bureaucracy. We have the best politician in the world, and we are the best techno professional in the world. Only thing is how to coordinate, as he said, because each one of us have our area of specialization. Let's respect their administrator. They have their own training and their own capability. Respect them, give them your viewpoint, frank viewpoint. And if something good comes, because we have to work as a joint, sort of a unit, rather than we think I'm from medical profession, I'm superior from a bureaucrat or a politician. He gave the example of the former health minister, Ghulam Nabi Azad Sahab. He was so positive. And see, they also have a vision. They look from the community point of view, and many times their opinion could be useful to all of us. So thank you so much for sharing your experiences, and you have always supported us with your presence and with your guidance. And future also, sir, we look forward for your support to this program and for other activities of the activity. Thank you so much. And I think one or two quick remarks, and then we'll conclude.
Hello. It was nice to listen to your comments. I was really touched by the experience you have shown in your life and how to deal with different things. what I personally feel is that a good leader should have good qualities as a good human being and being honest. And the thing about what you said, that there might be conflict arising from your subordinates in implementing a good thing in the system, which you always know that it's a good thing, it is going to benefit so many people. Isn't it better to take into consideration your other colleagues, senior colleagues and administrations, the facilitating administration between the government sector and the secretariat level and other areas that could facilitate implementation, and it could not resolve to any form of conflicts or problems with your subordinates or unions or whatever. This is my take on this. And one more thing, that a particular person is given a higher position, always in different by different committees. There are directors and other areas. I think the most important thing in everywhere where I have found is that what his deliverance has been in the previous post, what new he has created, what change he has made. All these things are taken into consideration besides good CV.
Thank you, Dr. Malik. I think I agree with 100% with your comments actually. See, when you move into those positions and if you move by your really the output in the previous side, what you did earlier, you're automatically respected actually. So there is acceptance for you by the people, by the new place you come. That is absolutely correct. You know, the people who go through a path which is people think they go through the manipulation or go through the political pressures. And if they succeed, they don't come with the respect actually. And the people always tolerate them, and unke jo chamcha log, they make use of them, but they are never respected actually. So they are never accepted as leaders actually. So I think what you told, that's I think that quality matters for everybody, Dr. Everywhere, you take examples from north to south, anywhere. The people who come with their accomplishments from the back in their careers, that is a very, very starting point actually. And about the resolving the conflict actually, see, something you call as a conflict, something is a difference of opinion. So this, if you must respect the other's different opinion actually. But then as a leader, it's your job to decide. Now that decide, is it decision as an individual feeling? No. It should be a system. It should be a pathway of taking decision. Okay, there is a platform to give your opinion. So you create those structures, create those if the committees don't exist for that purpose, synthesize them. Then, but in the end, that the buck stops here actually. This is my decision. And after that decision, this goes, my superior only the person to overturn. I will not overturn it actually under any circumstance. And that, once I made it very clear, and that I give you that example, that my previous two bosses who were very good people actually, because जब वो चक्कर पड़ता था कि वो decision reverse करने की tendency हो गई, तो that created trouble actually. They were great outstanding people, but they got into trouble actually because वो एक बार पीछे आना शुरू हुआ तो then going up and down. So I think you should be firm after you reach that point actually. Yes.
Yes, sir.
Thank you. Shukriya.
Sir, this side. Yep. This side, sir. Yep. Sir, down the
Sir,
right.
I know there are a lot of people who want to ask you questions. My suggestion is, we are already 20 minutes over time. You can ask him during lunch break. We have a lunch break right now.
Okay, sir. I think I'll speak to you during the lunch.
Yeah, my apologies for curtailing the discussion. Sir, a small token of remembrance. And one thing I remember about Dr. Satosh, I was ED NHSRC and then Director IHMR. I walked into ICMR with 3-4 of my colleagues. He was in the office, health secretary level person. I just sent a word, sir, we want to meet you. He was in a meeting. He invited us. बाकी लोग wait कर रहे थे, invited us. And I didn't know him by that time. उसके बाद मैं इनको जब भी मिला, ministry में या कहीं भी, he always stopped. How are you? What are you doing? He will always take out a few minutes to talk to me. मेरे जैसे हजारों लोग इनको मिलते होंगे. Thank you, sir. That really endears all of us to you. Thank you.
We'll break for lunch and come back at 2 o'clock if you can. Have a quick. The next speaker is already here.
Yes, yes. We'll come back.
हमारा तो फेलोशिप का दिसंबर जनवरी में
कोई इकट्ठे बच्चों से जानते चल रहे हैं तो बात दौड़ में लगे रहते थे कि बेटी के उनसे बात करते थे हमारे
So Dr. Arundhati Rao said when I joined as a resident and also when I joined as company eventually.
Very interesting. I remember. रात को 8 बजे आए देर तक काम करते रहते तो मेरे को कहते संदीप आप के साथ मारुति वैन नहीं आई तो कहते नहीं मैं कहते चलते थे You took another X-ray. पहला X-ray लिया ना मैंने पूरा सीधा हो गया से और वो कुछ सोचा वो बड़ा दे वो तो दोबारा X-ray लिए उन्हें पता ही उनको भी तो कर लिया फिर बाद में उसने बताया क्यों लेके गए
Okay, friends, we can start the lunch session. And in this session, it is my privilege and honor to introduce the chairperson, Honorable Professor Lieutenant General P.P. Verma, sir. Sir is our senior council member. On है, sir. And he is presently Principal Director, Nephrology and Renal Transplant at Venkateshwar Hospital, which is very famous hospital in Dwarka, Delhi. Sir has served in the Indian Army for nearly 4 decades. And he has been one of the best DM and DNB teacher and examiner for another 20 years. 20 years, you can see, with more than 300 presentations, 70 publication, and 15 international publication, and also 15 contribution to books in the form of different chapters in the area of nephrology. Sir also has been MD and DM examiner for nearly 20 years. Sir has been the honorary surgeon to the President of India from 2013 to 2015 and chief consultant medicine nephrology, Indian Armed Forces from 2013 to 2015. And he has been awarded a decoration like Ati Visis Seva Medal, Sena Medal and Visis Seva Medal by the President of India. Sir is President of the Indian Society of Nephrology from 2014 to 15, Vice President ISOT from 2018 to 21, and of course, Council Member of ISN, ISDP, and President Daily Nephrology Society for the year 2005 and 2006, and President Indian Society of Nephrology.
Without his permission, I'll make a statement. He joined MBBS in Ames with me, but after 2 months, he was not to be seen. फिर हम इनको ढूंढते रहे कहाँ बहुत दिन बाद दिखाई दिए. He left Ames and went to Maulana Azad. I think the only person I know who left Ames MBBS and went to Maulana Azad. Very clear in his thinking what he wants.
Classmates. In 71, we were classmates in MBBS. Yeah. Yeah. Thank you very much. And it's an honor to be here and to be among so learned people, senior people. I think it will be good learning experience for us. And to start this session, we have got a talk on artificial intelligence. We all know that artificial intelligence is invading in every field of medicine. Leave aside medicine, whether it's a transportation, whether it's any area you will talk today. But we are talking today about the artificial intelligence in the field of medicine. And to talk about it is a very learned person, Dr. Kritika Rangarajan. She is a MD Radio Diagnosis, PhD, Fellowship in Royal College of Radiology, London. She has got another degrees diplomate of National Board of Radiology. She is presently the associate professor in the Department of Radiology, AIIMS, New Delhi. She has got special expertise in the use of AI in clinical practice, especially the medical specialty and public health. She is PhD from Indian Institute of Technology, especially with deep learning in medical imaging. Postdoctoral fellow, Indian Institute of Technology, New Delhi, way back in 2019. She has been instrumental in development and implementation of AI framework for improving patient care. If I keep reading, I think it'll be too long, but she has been a contributor to AI-driven healthcare research initiative, a lot of publications. She is generally an invited faculty wherever we are talking about artificial intelligence. And I don't know, because to nephrologists, what is important is now, previously in the biopsy, we used to see this is the biopsy, and there used to be almost 25 to 30% variance in opinion. Somebody will say biopsy is this, somebody is saying. Now, gradually what you find is the microarray diagnostic technique has come, where, let's say, acute rejection, they have seen over 500 patients, they have seen the biopsy finding, they have fed it into the machine, computer. Then they see chronic rejection, they fed it 500 biopsies, they fed it in the machine, in the computer. Likewise, so you are able to find out with great accuracy. Next time you put it, that this is the figure, and you put it in the machine, machine gives the diagnosis. I mean, that is the time which is coming. Possibly many times people feel that doctors will not be there, it will be more of a artificial intelligence, but that's not going to happen, certainly. Because logically, you are going to feed the data in the machine and everything. And mind you, the confusion comes, the machine gives a diagnosis, whereas the pathologist may not be agreeing to that. And because there is almost, if I'm not mistaken, almost 25 to 30%, again, a variation. You say, Baba, I have given this diagnosis, and the machine gives this diagnosis. Now, there's again a confusion. I think to dwell on the issue, I request you to. Yeah, you are the leader today.
Thank you very much for that very kind introduction, and thank you for having me here. So I'll speak a little bit about artificial intelligence, which, as Sir has very nicely summarized, is a buzzword today, and we're trying to see where it can really help us. So to try to demystify this over the next hour or so, I'll take you through what really is AI, because we keep talking about it. I'll try to sort of simplify this and talk about what is it that we're talking about, talk a little bit about how we've evolved in the spectrum of AI, take a sneak peek into the applications, and then I'll take a segue into what are really the deployment problems and what is it that we're likely to see. And I'll try to make this as brief as possible, maybe finish within 45 minutes or so that we leave some time for discussion after this. So really, what is AI? So you can think of AI as just a set of mathematical equations. Now, this is a terrible oversimplification, but if we were to just try to understand what is going on behind it, if you were to try to find patterns in data, where you're trying to represent it roughly maybe as an equation to say what is happening, this is what AI really does. So it has its core inside the patterns within data. That's what you're trying to figure out. So if you were to find a mathematical equation for what is there in this picture, to call it a cat, this is essentially what you're trying to do with AI. How is it different from what we used to see maybe 10 years back? So 10 years back, if you remember your Google Photos, there was nothing like a face recognition on Google Photos, right? But we had machines which seemed to promise some amount of intelligence. Now, what we used to do back then was you give some data and you would encode the rules. So there'd be programmers who would sit down and write a rule to really tell you what the output should be. So in this example, if you were to give a rule saying, y is equal to x into 2, then what you're doing is traditional software engineering. Whereas what we're doing today is called machine learning. So machine learning really is a data-driven process. Why do we call it a data-driven process? Because what you're feeding is a lot of inputs and outputs. So over here, you won't say y is x into 2. You'd say y is 8 when x is 4, y is 12 when x is 6, y is 14 when x is 7. And you'll say, computer, figure out what the rule is behind all of this. Now, obviously, when the rule is something as simple as x into 2, it doesn't make sense to do something like this. It's much easier to tell the computer and encode an x into 2. But when you go to things which are much more complex, like face recognition, you'd see that there are so many more variables. Excuse me. So if I was to take this example, if you were to simply tell whether the image has a cat or it's not a cat, the cat can look in any direction. The cat can have fur of any color. The cat may or may not show both eyes, both ears, etc. So when you have to capture so much variation, that's when traditional machine learning, traditional software engineering fails. Which is why you see over the last 10 years or so, your Google Photos, your Facebook tagging, everything has improved so much more because the data is so complex, and what we're using now is a data-driven process. You're trying to figure out the patterns in data rather than giving a definite rule. So these are just terms that we would come through. AI or artificial intelligence is a broad term. It can encompass any technique that a machine uses to mimic the human intelligence. Whereas machine learning is a sub-segment of AI, which is a data-driven process. And deep learning is a further sort of sub-process of AI, of machine learning. So what does deep learning really mean? And this is something that you come across in a lot of research papers, so I'll delve into this a little bit, which is, we talk about neural networks. So what are neural networks? So all the neural networks, the current day deep learning takes its inspiration from the biological neuron, where there is an input layer, there are a series of computations, and then there is a final output layer. And this is essentially what we do. There is a series of inputs, and then there are a series of equations. Think of them as mathematical equations, many layers of mathematical equations. And then there is, depending on the activations, you get an output, which then comes out as the output that you're looking for. These are called hidden layers. And when this layer becomes very deep, this is why you call it a deep neural network. So one simplistic way of understanding this is that the more the number of layers of equations that you give, the more complex the problem you can possibly solve, which is why deep learning is actually doing very well today. Another term you might come across while reading papers is convolutional neural networks. So what are CNNs? It's specifically a technique that you use for images. A convolutional network is something that uses an operation which is a mathematical operation. It's also used in CT reconstructions regularly, where you're basically trying to, again, find patterns in data. For example, this kernel will give you all the horizontal edges of the image. Another kernel will probably give you all the edges of the image. So by using multiple, you're basically trying to say, what are the features which are important in this image, which are helping me come to a certain conclusion. And that's what you do in a convolutional neural network. Now, essentially, a lot of techniques have moved to something called transformers in today's day. And transformers basically encode context. So all of your ChatGPT and all of these models, the Gemini that we see, use a technique called transformers. And transformers began with a seminal paper by Google called Attention is All You Need. The difference between the older methods, now even convolutional neural networks are relatively old, versus transformers, is that it understands context very well. So if you've ever used ChatGPT in your practice, you would know that it's able to understand not only the last sentence that you've written. If you give it a whole paragraph and you explain what context you're asking the question in, it's able to actually take that entire information into account. And that kind of context encoding is what transformers have been very good at. So how did we really get here? How has AI really evolved? The concept behind AI is not new. It was known even back in the 1950s, where the basic mathematical principles of machine learning was actually well understood. Why didn't we move? It's because we didn't have enough computational power to really implement this. Today, we carry more computational power in our cell phones, in our pockets. than, if we had to fill up this room with a computer, that would probably have lesser computational power than the phones that we carry today back in the 1950s, which is why we could not practically implement machine learning. But then, so 50 years after this was a period called the deep learning winter. It was called the winter of deep learning of AI because not much happened during this time. But I'll sort of pause to take an example of mammography CAD. So in the 1990s was when there was a lot of excitement, particularly if there's a radiologist here, you would know, where it was believed that there was a computer-aided diagnosis. It's called a CAD, can actually very specifically pick up cancers on images. And it was believed that it's so good that maybe we don't need second-reader radiologists anymore. So the initial studies were very promising. It got its FDA approval. It took 10 years. 10 years later, large randomized control trials, which were done prospectively, ended up showing that when you used CAD, the confidence of the radiologist in saying that this is not a cancer reduced significantly, subjecting more patients to biopsies than were actually required, and you did not end up getting a significantly improved yield in the number of cancers that you detected. The reason I brought this example out here is because it's just to sort of impress upon us that as medical professionals, ensuring that this hype doesn't lead up to something that may not be truly sort of valuable, the responsibility for that lies on our shoulders. So designing studies very well to see how it interacts with human beings is a very important part of the entire spectrum. Anyway, this was what was traditional software engineering. This was not the current day AI that we use. In 1997 was when Deep Blue beat Gary Kasparov in a game of chess. So this is where, again, the world started taking notice that there is a new sort of technique which is making inroads, really. And yet, chess is a game where you have some rules. And Deep Blue actually used something called brute force, which means at every square, it was able to calculate what are all the possible moves that I can make, and imagine what the board would look like, and therefore win against Gary Kasparov. But then when you moved into other games which are more complicated, like everyday life is not a game of chess. We don't have defined rules in everyday life. So the skepticism continued. But then just a few years later, in another game called Alpha, Go Alpha, again, deep learning beat the grandmaster of Alpha. Now, this story is again interesting because when you go to the game Go, even if you ask a grandmaster, why did you make a particular move, they probably won't be able to exactly explain it to you. So it's a lot of intuition, and it's impossible to calculate all the possible moves in the game of Go. And yet, they came up, so the deep learning actually made a move by observing grandmasters that had never been made in the past. And that was considered the decisive move in actually winning that game. So it kind of showed the world the power of deep learning, where you're actually able to discover new information using deep learning. So there was actually a sort of intelligence that had evolved in a vague use of the term intelligence, not like the human intelligence, again, but some form of intelligence where it's actually able to think. Then, I mean, it took a few years for it to come into medicine, but in 2016 was when IBM displayed something called the Eyes of Watson in the Radiological Society of North America. This is the largest radiology conference that happens across the world in Chicago every year. And 16 was when IBM actually displayed this, where you would scroll through a scan and very intelligently Watson would put a box around possible tumors and was fairly accurate. And this was really the inroads of AI into the medical world. The Google paper also came around the same time in 2016 on diabetic retinopathy. Again, another seminal paper showing the possibility of use of deep learning in medicine in general. And then there's been an explosion of papers. 2018 was Cure.ai. And then, 19 onwards, of course, if you look at PubMed, it's really filled with literature on what AI can possibly do. And that's really how we got where we are today. Excuse me, where possibly can deep learning be used? Now, I've really divided this into tasks when you go from the top to the bottom. We'd go from tasks which are really back-end tasks. You probably won't even realize that AI is being used, all the way to superhuman tasks where even humans are not capable of really verifying whether this is true or not. And while back-end tasks at the top are already in existence, we are actually already using some of these tasks, whether we know it or not. Superhuman tasks are kind of, there in the future. We don't know whether they're really going to make it or not. And that's how this has been arranged. Now, looking at some of the back-end tasks, can you actually schedule patients intelligently? Can you actually put up the records of all the patients and say that maybe this patient needs 30 minutes, whereas this patient is probably going to be done in 2 minutes, and actually arrange your appointments that way to solve pain points in actually scheduling, in the logistics. That's the kind of application which a lot of the world is actually targeting for immediate implementation. This is where all of us become more efficient and we're able to utilize a specialist's time in a very useful manner. Again, image acquisition, if you buy any CT scanner, any MR scanner in today's day, you're already using AI on the back end to reconstruct the images, whether we know it or not. So can you acquire half the case space, reduce the amount of time of acquisition, and still get a very good quality image? Can you reduce the radiation dose that the patient gets and still get a very good diagnostic quality image? These are applications which have been very well researched and actually have already been built into scanners. And that's why we're actually using AI on an everyday basis, whether we actually realize it or not. Coming to, raising the bar a little bit to second opinion tasks. When you come to cumbersome tasks, if a human being, a human radiologist, no matter how good the radiologist is looking at 200 mammographies a day, when you come to the 200th patient, you're a lot less sort of attentive than you were in the first patient. So won't it be nice if you could have AI pat your back and say, maybe you're missing a cancer over there? And that's the kind of task which actually is the immediate next target for most AI. A lot of these tasks as second opinion tasks actually already have FDA clearance, and some of these are available commercially. So similarly, dermatology and a lot of image-based tasks, because the last generation of AI was actually image-based, are already with FDA clearance at the time being. Measurements are, you ask any radiologist, they would give anything to have a tool which would actually do these cumbersome measurements for you. Nobody likes drawing a contour around every section of the liver and doing the same thing 200 times, especially when a machine is capable of doing this much faster and in a much more efficient way. So again, these are the tasks which are the next level, are already available and looking for people who would adopt them. I'll raise the bar a little bit more now and go into things like triage tasks, because this is sort of AI working semi-autonomously. A patient if you had a lineup of, in a busy trauma center of 200 CT scans, maybe a patient with a brain hemorrhage is actually hiding and is the 190th patient in your list. So what if AI could actually detect this and pump it up your list and say that this patient needs your attention first? So this kind of workless prioritization task for triage, again, is already in existence in several fields. A lot of them actually have FDA clearance for use in this. And then again, can you have a toothbrush which every day has a camera in it, and every time you brush your teeth, it's screening your oral cavity for possible cancers? So these are the kind of, and then alerting you to say that you need attention and please visit your doctor today. So these are again the next sort of tasks, which again are, some of them are already in existence with regulatory clearance. And then raising the bar a little bit further, taking the triage task example a little bit further, when you look at a low resource setting like India, where you barely have any, you don't have the ability to have trained professionals to look at every X-ray. Can you actually triage the X-rays into just being normal or abnormal? We actually are doing this in AIIMS currently because we do over 1,000 X-rays every day. It's actually impossible for somebody to actually look at all the X-rays. So we just triage them using AI into normal and abnormal. And it's only the abnormal ones where we say that we'll have a look at those. The normal ones just go to the clinician and we say that you can come back if you have any trouble. But can you actually use this in public health? So there are e-tuk-tuks in some states down south, which actually carry a mobile X-ray machine, which goes around screening patients for tuberculosis. And can you use that to alert patients who might actually need attention? Similarly, tasks such as mammography, it's impossible it's absolutely impossible actually We'll have a multi-stage system of doing something like that. But even if you were to think of offering mammography to say only the high-risk patients, it's impossible to do something like that in a country like India. So can you actually start saying that, okay, this lot of mammograms don't need to be seen by radiologists. Maybe a technologist can see and send the patient back, but this lot need to be seen. Then the number of scans that you can possibly do, number of patients you can target would significantly improve. Now, this is a little bit sort of further down. There are only 2 algorithms around the world which actually have clearance, any kind of regulatory clearance for autonomous use. One is for chest X-ray and the other one is for diabetic retinopathy detection on fundus. But as we go forward, possibly in specific settings, we'll see a lot more of those. And coming to the superhuman tasks then, now these are tasks which you never know whether these are really going to see the light of the day. There are a lot of issues in actually implementing them. But while I said that the previous generation of AI was image-based, and the reason I said that was because I'd spoken about CNNs earlier, the convolutional neural networks. Now, CNNs worked on images, and that was the primary modality that was used in the AI world. Whereas, and also that if you look even at medical specialties, a lot of image-based specialties are light years ahead in terms of digitization. So in most radiology departments, you'll find advanced digitization techniques where you actually have data which is available in a digital format and therefore amenable to AI intervention. Whereas the same can't be said about other modalities such as text and speech. But with the advent of the large language models, so all of your ChatGPT and Gemini are a category of models called large language models. These have come in about the last 2 years or so. And therefore, the next generation of AI is very likely to target text and voice. And we're already seeing significant amount of that. Can you have a clinical decision support which is automatically based on a patient's conversation with the doctor? You're constantly recording this and then suggesting the next step. You're constantly alerting the doctor to say, maybe you might want to advise this extra investigation which you may have missed. Can you actually, I mean, going a little bit further, going into a field called radiomics, radiogenomics, can you start predicting the genomic makeup from images? Can you start predicting which patient is likely to respond to what kind of therapy? So that's going into an era of personalized medicine where you're actually selecting specific patients based on what that patient's profile is. And then there are some very interesting modalities like, can you generate a PET scan from a CT image? Can you generate an MR from a CT image? These have been proven in literature. There are small studies which actually tell you that some of this is possible, but only time can tell how far we will actually get as far as all of this is concerned. Now, with this, before going into the rest of it, because all of this, of course, sounds like we're living in a different world. I'll take a small segue and talk about why aren't we, if all of this is so exciting and all of this is a solved problem, then why aren't we actually already replaced, or why aren't we looking at replacement of medical professionals? And why aren't we actually seeing this in our everyday clinical practice at all? So what are the deployment challenges? And I'll sort of delve into this right now. So back in 2014 was when Amazon said that, okay, I have these, we have so many resumes, which are all digital, which have been collected for years together. Why don't we just build a fancy AI model to tell us who we need to recruit and who we do not need to recruit? They did sort of implement it for a couple of years, and they suddenly saw that they were only recruiting males. And when they actually dug in a little deeper, what they saw is that the training data showed that in this male-dominated industry, somehow the AI model had learned that if the gender is female, she should be penalized for being female and not be recruited, because that's the pattern that the AI model learned from the data. So in 2016, they tried to correct this. So they said, let's take out the gender out of the whole thing, and let's take out any reference to the gender, and let's see if this works. And in 17, they found that AI somehow found a way still of finding the gender, because whenever she would say something like the champion of the female soccer team, they would again pick up those references and still penalize the person. So the key takeaway here is that sometimes it's very blind. The data quality matters a lot. It's an entirely data-driven process. It's going to find patterns in the data that we are blind to. We've probably not noticed these patterns. And human oversight is absolutely critical. Also, there are a lot of ethical challenges in AI, and which we really need to sort of the fairness of the algorithm is a very important topic that we need to delve a little bit more on. Now, taking the same thing into the medical domain, this was one of our very initial experiments where we started building, chest X-ray AI as one of our first models when we began, about a decade ago. So what we found is that the same thing when it translated into X-rays. This was a typical model where we were trying to do a pneumonia detection. What we were trying to say is, does this patient have pneumonia or not? And we found that it worked excellently. So on the data sets, it had more than 95% accuracy. But when we started deploying this, trying to deploy this prospectively, we realized that it did not suddenly work so well. And then we did something called a visualization, where it tells us what is the model looking at to try to come to the conclusion that it's given you. And we found that it was focusing on all the lines and tubes. So in a very similar way to the Amazon example, what it had actually learned is that it had, the examples of pneumonia that it had been trained on were all from ICU patients. And it learned to identify the lines and tubes. So it said wherever there is a line or a tube inserted in the patient, it would call it a pneumonia. And when it was not, it would call it a normal X-ray. So of course, it got very good marks because it did. A lot of pneumonia patients are of course very sick. They may be likely to have lines and tubes, but it did it for the wrong reasons. So this is a very important example of why explainability and why looking into the model and not treating it as a black box is very, very important to ensure the safety of the tool. So can we always tell whether the model is biased or not? Now, this itself is a very, very difficult question to answer. This is some of our work in COVID, where we were trying to determine whether the patient is COVID positive or COVID negative based on the RT-PCR of the patient. The labels were from RT-PCR, but we were trying to give the input as chest X-rays. Now, we found that the model performed very well. But surprisingly, the model had more than 90% accuracy, even when the X-ray was completely normal to human radiologists. Now, when we tried this in a retrospective setting, we tried this in a prospective setting, we tried this on publicly available data, it continued to perform very well. And this is the visualization where it shows that it is looking, somewhere in the cardiac region to tell you whether the patient is positive or negative. Now, could this be that that we all know that there was subtle myocarditis happening in these patients? So could it be that it has detected some subtle configuration change in the heart? Or is it just missing it? And how do we prove that it's missing it? The answer is we don't know. And that's why we did not deploy this model in clinical practice. So this is the reality. As human beings, we may or may not really understand what is the pattern that the model is picking up. But again, what it teaches us is the importance of choosing your training data and your test data in a very good way. Now, this is an example. This is a video that's there. It's available online. You could just look at it on YouTube. I've just put in the YouTube link. This is of an autonomous driving car. This is the example of an Uber that hit the pedestrian. So this, if you look at it, the human did realize it, although the human realized it too late. And you can see, it's not that you can't see the cyclist. And if you look at the training examples that this was trained on, plenty of examples like this were very nicely seen. So why did it choose to miss the pedestrian in this case? Nobody really knows. But let's look at the flip side also. Do humans also make mistakes like this? Plenty. If you look at data, autonomous cars are actually way safer than human-driven cars. But humans have the ability to explain to the patient. So when it comes to a patient, at least you can say, okay, the cancer was hiding behind fibroglandular tissue. The cancer didn't look like a cancer. I actually thought it was not a cancer. And that kind of explainability can be very important when it comes to a human, a life, something where life is really involved. But I'll also give you an opposite sort of example to think about. All of us prescribe and all of us have used paracetamol. How many of us actually know and understand why paracetamol works? Possibly, and even literature doesn't tell you in a lot of with a lot of clarity the exact mechanism of action at cellular level. So, does a lack of explainability actually justify not using AI if you actually show in terms of data that it is actually benefiting a very large number of patients? I don't have an answer to this, but it's for all of us to sit down and think about issues like this. And I'm just throwing up these issues, as food for thought. So how important is explainability? It is important, it is desirable, but perhaps cannot be made mandatory for implementation of AI. Now coming to the other side, which is the possibility of attacks. As we all know, I think 2022 was when AIIMS came under a cyber attack. 5 out of 100 servers were actually down. And this was crucial medical data which underwent a breach. Now, patient scheduling had moved entirely online by this time, and the institute was brought down to its knees because we did not anymore have the ability to go back to a physical system of appointments. And there was a 200 crore ransom demand with suspected attackers in China and Hong Kong at that point in time. So how do we secure our systems, our data, because we keep speaking about how it's a data-driven process, but also our models from attacks such as this, is something that we all need to sit down and think about. Now, I'm taking another example, and this is not really AI, but this is an example of digitization. When you look at the NCD portal and when it came up, so you went from a system of writing on papers to a system of filling up very neatly digitally, and so multiple copies did not need to be made. And you would have expected that there would be very high compliance to it. You would have expected that everybody is very happy with this. But let's look at what actually happened. In majority of the cases, the ASHA worker would still write down on paper, and somebody would come back, give it to a data entry operator who would then copy the same thing onto a portal. Now, the entire purpose of digitization somewhere got lost. So, are we making whatever we're building, are we making it user-friendly? And who is our end user? Is that person capable of using what we're building this out for? Is a very important question that we all have to think about as we go forward. Similarly, the diabetic retinopathy, I was talking about the Google paper on diabetic retinopathy. Seminal paper showed excellent results on paper. But then when they actually implemented it in the field in Thailand, when they tried doing a screening of the population, they realized that the lighting was so different, the people acquiring the images were so untrained that the model failed miserably. So another example is if you go to your Play Store, you'll find maybe tens of apps which claim to be ASHA worker apps. So these are apps which have been built to assist your ASHA worker at acquiring data. And then, but two very interesting examples. When we spoke to some people in Karnataka and asked them if they're using the app, and you would have expected that this is giving the ASHA worker a lot of information, so should be a very nice app to use. So the app had an audio interface, so the phone would talk back to her so that she didn't need to write, she didn't need to read, and tell her what is to be done. And you found that there was very poor compliance. And when you spoke to the ASHA workers, they told you that when she would traditionally go and speak to patients or participants in the village, she had a sense of authority over everybody. People would respect her. And now suddenly people start perceiving her as just a puppet who was doing what the phone told her to do. So they said, we don't want to use it anymore. Again, another example from the RMNCH program in Gujarat in the implementation, where they started seeing that suddenly after implementation of the digital app, they started seeing a very, a much lowered registration of high-risk pregnancies. And when they asked her why she's not doing that, the Anganwadi worker basically said that, see, every time I register a high-risk patient, it keeps giving me alerts constantly, and that keeps bothering me constantly. So it's just too disturbing. So whenever there's a high-risk patient, I keep them off the app. I'd rather sort of write it down on paper because it's too disturbing to use this. So essentially, making fancy things in labs is very different, But when you go on ground, we have to face the reality on ground. And having our ears constantly to the ground is essential if we hope to make any difference at all. This is the CAD example in mammography that I was talking about. I've already described this, so I won't go into this. The only thing I'll point out here is this is the paper from 1998, and 10 years later, this is the paper from 2007, and the two papers have a completely different conclusion. The second one is from NEJM, and this is the larger study which actually tells you that this increased the rate of biopsy with the use of CAD and is not associated with improved detection of invasive cancer. So there's a lot of difference between the lab, what the lab says, and what real life says. This is an example from my own PhD. So when I was writing my PhD thesis, I said, I don't want to write code to build this graph, and I'm trying to build a graph for piecewise linear transformation. And I said, let me go to GPT and ask it to write the code for me and build out a graph. So I've described in detail what I want. I said, okay, this segment should show these many values, x-axis, y-axis, etc. And drew this graph. This is the graph that came. Now, I'm not primarily a data scientist. I did my data science much later. So I wasn't very sure. I wasn't very confident. And then I just thought that this graph did not look right. So I said, GPT, why are segments 1 and 3 so horizontal? Shouldn't they be a bit more vertical? And look, this is what GPT tells me. It says, you're absolutely right. Piecewise linear transformation should not have had these as horizontal segments. Let me redraw this graph to give you the right thing. So if you did not know, and now take this to a medical context, if the person who's chatting with the LLM does not know what the ground truth is, imagine what the entire thing can be. Now, this is another example, and this is a real one from a poor little boy who is under exam stress, chatting with Gemini. And then this is Gemini who got frustrated with the number of questions that the boy asked him. And look at what Gemini says. It says, this is for you, human. You and only you. You're not special. You're not important. You're not needed. You're a waste of time. I'll skip everything else. But look what it says at the end. It says, please die, please. So imagine the same thing happening with a person with a mental health disorder. And imagine the consequences that something like this can have. So we are at a very exciting time where our efficiency can increase many-fold by the use of AI. But what are the guardrails that we need to implement is something that we all really need to work on, particularly for these large language models that we're talking about. Detecting hallucinations is very important. This is again some of our own work. How much time do I have? Is it?
You can go ahead.
Yeah.
Another 5 minutes.
Okay, great. So this is just an example from what we found when we started off working on mammograms. So to begin with, so mammograms are very large images. So when you look at medical imaging, mammograms have the highest spatial resolution out of any other modality, more than X-rays, CTs, MRIs, everything. But what is the first thing that a computer scientist will do when they take a mammogram image to run it into a neural network? They would reduce the size of the image for computational constraints. Now, whose responsibility is it to say that a full-size image should go? Because the computer scientist doesn't know the importance of the size of the image, whereas the radiologist may not know the importance, the possibility that he's going to reduce the size of the image. So this talking between specialities is essentially very, very important in order to build medical AI. Similarly, when it comes to dense breasts, or when it comes to how does a computer scientist know that there are two views of the breast that you take, and you have to look at both views unless you tell him. So often as medical professionals, we look at our role as either right at the beginning to annotate the data or right at the end to validate the whatever models have come. But our role in between is also extremely essential to ensure that the AI that actually comes out is relevant and is safe to use. Now, this is another hypothetical scenario. This was actually a tool we built out for resident education, where all of these mammograms are not real mammograms. These are all drawn by AI. And this is the cancer on this one, 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 and this is the cancer on this one. These have all been drawn by a resident, actually for the purpose of training. But take this into a scenario where it's not the resident, but a hacker who does this. And let's say a hacker comes in And the way we had the cyber attack, they decide to insert cancers into all the imaging studies of your patients. Now, no radiologist can say that this is not really a true mammogram of a patient and that this cancer has been drawn by AI. So what are the implications of something like this? And similarly, if we were to use AI autonomously, if you just use something called noise, so Gaussian noise, you can't detect that there is anything added to this X-ray. It looks like a normal X-ray. And yet your models will fail completely because there is noise added and the model is not trained with noise. So how do you really protect and secure your healthcare systems is a question that we all need to really answer. And essentially, we need to walk a tightrope to establish guardrails for the use of AI. And that's really where we are. And I'll end with that. Thank you, everyone, for your attention. This was actually one example. I typically end with this where, so I entered AI at the same time as my daughter was born. And I saw how human intelligence develops versus how, AI sort of learns things. So if you were to give my daughter these two images and say, okay, what is this? She'll probably, it doesn't take her any time to say that they're both Ganesha. But for AI, you have to train on these sort of images separately and on these sort of images separately. She may, my daughter may have never seen a sketch, but she doesn't need to see a sketch to be told that this is Ganesha. So this ability to translate and imagine is basically what makes us all as irreplaceable as we all are as humans. I'd like to end with that. Thank you.
Thank you very much. I think that was fascinating. Any questions? Yeah, please. We can have 3 odd questions.
Hello. Yeah.
Okay, can you just tell
Yeah.
before that in which areas it has got a definite place as on today? As we all know that a pilot in the flight is sitting for last 20 years, the navigation is already set. The artificial intelligence is already there for so many years. A driverless buses or cars are running. So logically, artificial intelligence is already there. Your Google, every day you are seeing the directions and every minute, every second it is changing. So artificial intelligence is already there in our lives. But in medical field, where exactly we are using it without any conflict?
So I think the first sort, which is what is already there, is on things like back-end tasks. So efficiency improvement is something where we can all use it. Can you summarize, digitize, etc.? So those are areas which are very amenable, ready to use. Several companies actually offer this. Again, reconstructions, image reconstructions prior to the radiologist actually seeing. So these are the safe areas where it already exists. Worklist prioritization is a very important area.
Is it coming now that you do a MRI and with this AI, the report comes straight away, well, this is a glioblastoma or this is so-and-so.
So
Have we reached that stage?
No, we're very far from that stage.
We are
We're very far from that. So it can do a narrow task very efficiently. So if you ask it to say whether there are nodules on X-ray on the CT, for example, it will catch all the nodules fairly efficiently. But if there is, say, if it's not a nodule and it's a pleural effusion, something which is trained on nodules will completely miss the pleural effusion.
I have a point. For example, in locally advanced cervical cancer, there is BioEmbrace trial where they have a prediction model depending upon the multiple MRI images like T2 weighted image, the diffusion weighted image like ADC mapping and dynamic contrast enhanced image. So ultimately they divide into 2 risk categories depending upon the C index. So if the probability of, so that gives you a very good prediction. Basically, this has been proved. Now the trials are going on. There's a BEROS 2 trial beyond that. So this is already there. And secondly, I'm in from radiation oncology. In our field, we have what you call the back projection algorithm. What you do, we just delineate that this is the target. I need this much dose here, and I want to spare the nearby organs. Automatically, with the back projection algorithm, there is iterative imaging. That is, you define a cost, and the cost for the target will be the root mean square difference between the desired dose and the realized dose. For oral rat race, it will be 0 dose because you want to give
minimum dose to that, and the realized dose. And this is why iteration does. So it is already there, sir, in the algorithms, algorithms, auto contouring, but you have to see, because there are certain drawbacks. There is a data bias. It cannot be from one area. It has to be global. Annotation bias, you have already explained. I think there's a great future. I think this will save time and improve the efficiency also.
Dr. Malik.
Yeah.
Every technology that comes into place has always pros and cons. I've gone through so little bit of AI. I'm also interested in it. But what I have found over time, that taking human life into consideration, making such mistakes. You see, I'm a surgeon, so it may devise me methods of attacking a tumor inside the abdomen in the best possible way. The resectability criteria that is defined by CT, MRI, or other radiological investigations may not be true, but it may make me to do, but it may take me to the wrong planes also, and it may make a disaster where an unresectability has been defined. It may tell me that it is resectable, then having a deleterious effect on the life. What I'm concerned is presently, I think, with pros and cons, and whatever data has been infused into this AI in different AI modules, I think we should not take into consideration the prospective way of thinking by AI. I think it should be utilized more in retrospective data. This is my personal thinking. Yes, definitely, it might show you, it might make your life easier in certain situations, but at the cost of the cons it makes. That can be, and that can have problematic situations. And the first branch in medical sciences, there are pros and cons with our profession also. The first branch that is going to get wiped off will be radiology. I'm sorry. And whatever will be there in your hands will be the interventional radiology. And in that also, if you then start introducing AI, then it might make your life miserable.
No, sir. I think I will disagree with that respectfully. I think we are very far from this.
Yeah, it is.
Even in diagnostic radiology. And I think, so radiology is a branch which has been declared dead 6 times in the past. So I think we've gone through that. Even when MR came, everybody believed that it's so clear, why do we need a radiologist anymore? But the more data you add into the mix, the more the complexity, not lesser. So tomorrow, the radiologist of tomorrow is not going to say, this X-ray, is it normal or abnormal? The role of the radiologist will be very different. But if you start predicting, is this patient likely to respond to CHOP versus R-CHOP? When you add data of that kind, it will become much more formidable. Where do you trust AI? Where do you not trust AI?
After adding that is what I'm telling you, that presently, I think it's more you should be in retrospective.
So, I mean, you'll have to use it properly.
No, I think in
retrospectively.
pathology, it is being used.
Sorry,
As I mentioned, that molecular microscope diagnostic, the kidney biopsies, people in US, the only thing it is costing too much. Each biopsy is costing over $3,000, which insurance companies are not willing to pay. But it is being practiced. Some of the only problem is when you have to have the tissue has to be transported to a particular center where computer is tuned. So you have to transport a tissue at -70° in a frozen section, in a special transport to a particular area. So these difficulties may be there, but gradually these difficulties are also going to be waived off.
Replacing pathologists.
Yeah, no, but it will not replace. After all, you have to.
So I have something to add here. With the interest in AI and machine learning and looking at the net and saying, let me do a course on this and let me take it from whoever are the experts who can teach me online and let me see its applicability in forensic pathology or forensic medicine as I practice. So there is one group called Institute IDI by IIT Delhi in collaboration with a French organization, which brings out a course of over 4 Sundays and talks of how you can, they explain AI in healthcare, the courses on that. But it didn't give me, because it was from the mathematics people and from people who knew from 1950 who did the first PhD thesis on AI, the IIT Delhi guy. So it was really incomprehensible. And so I turned to Future Learn. But this group told me that there are 4 things which can be diagnosed by AI.
Users are warning me, yours is the last comment.
Okay.
Then we have to close.
Sir, I have one, sir. I've been
Next,
waiting.
diabetic
Thanks.
retinopathy, brain tumors,
Okay.
and some pathology. These 4 things they said the AI has worked it out and is now established that the AI can diagnose it. So there were brain tumors like the glioma you were saying. They had 4 kinds of brain tumors which it diagnoses very well, and diabetic retinopathy and some 2 more things. And this just finished on October 12th, Sunday. So they were saying that this is there. But then I learned the easier way to learn AI and machine learning, deep learning, was through a textbook and then a Future Learn course, which makes it easier through some New Zealand or Denmark university. But you explained very well. So it's easier to understand from a human being finally.
Thank you.
Yeah.
In person. That's also a point.
Yes, Dr. Kritika.
Yeah.
See, one thing as we understand that diagnoses and all these things. Now the question is, if there is a mishap, maybe a damage or a death arising out of that. So who is liable? That is number one. And second thing is, there is artificial super intelligence. How is that differing from artificial intelligence? So can you comment on
So
that?
to your first point, I think legally speaking, the buck always stops with you as the doctor. So whether you decide to use the AI and then make your diagnosis, or you decide I don't want AI and make your diagnosis, it doesn't matter because the responsibility lies with you for making that diagnosis. At the moment, there is no law which says that is the company that built it liable? Is the hospital administration which decided to use it liable? At the moment, there is no immunity that is provided to the doctor. So the buck will always, at the moment at least, because law also has to catch up. And it's a moving target. It's constantly changing every single day as we speak. But at the end of it, it lies with you. Super intelligence is, to your second question, these are just additional terms that I think, people are kind of pumping into things. It's kind of like superhuman tasks that we're talking about, which are beyond the comprehension. That will find its way into things like, finding patterns that we don't understand. For example, protein folding, if you go into the drug discovery side of things, we've seen that, a process to discover the 3D configuration of proteins, which used to take many decades some time back, can easily be done within minutes by some AI models. So those are the kind of tasks in terms of knowledge discovery where AI can actually truly accelerate knowledge discovery in that sense. So that's possibly one.
Thank you very much, Dr. Kritika. That was very nice, very knowledgeable, I think a lot of insight in what is in future with that. I think we change gears and come to role of medical institutions in national health programs, that especially the MCH and the non-communicable diseases. I think there are tens of programs. One can't count. I think there are 20, more than that, more than 23 or more than, yeah. So many of the programs. And to talk on the first session is Dr. Pavan Kumar. He's MD, MBA, PGDH, FM, WM, PGDHM. I don't know the full form of these degrees, but out of that, he's, yeah. Yeah, please. Pleasure. We enjoyed it. So Dr. Pavan has got a experience of almost 24 years in public health, healthcare management, especially in planning, policy implementation, monitoring, and supervision. He is a associate editor for Journal of Advanced Research in Medicine. I think it's written there, treasurer of Indian Society of Hospital Waste Management. And he's a recipient of more than 19 awards, national and at state level. And also the recipient of Excellence in Public Health Award. I think he's a right person to talk on these things. Please.
Thank you. Thank you very much, sir.
You have got 20 to 25 minutes
yes,
only,
sir.
sir.
Thank you very much, sir, and all the respected teachers which are from different medical colleges. So from clinical, paraclinical to will coming to the public health, that is basically public health programs which are being implemented in the country. The RCH or MCH being the biggest program in the country. Why I'm saying the biggest? Because the cohort is very large. Such a large cohort of 29 million, 2.9 crores pregnancies every year. We have 2.6 crore newborns being added into the population every year. So see the kind of a cohort and the number, then we have an adolescent life cycle approach in the country. So I'm having 15 to 20 minutes. So I'll try to finish in 15 minutes so that in the last 5 minutes, we can have a discussion about the program, any question and answers there. This is the basically thematic area on which I will be touching upon, that is RM and CHA. And the base of this is about the National Health Mission, which has started in 2005 as a National Rural Health Mission, being more focused on the rural population, where 80% of our population they stay. Then it has been seen that public health interventions, they are required in the urban settings also. So from rural to the urban health mission, that has also come. And with the progression of time, it has been merging as a NHM, the National Health Mission, which you must be hearing in your respective states, where a mission director is also there. And the main purpose of this program was to give affordable, accountable, accessible, free services to the last beneficiary, which is there in the field. Whatever we do at the policy level, at the national level, how those policies, program, they are being translated to the last beneficiary of our country, and how that has brought an impact into our indicators, statistics. So I'll just touch upon all those things. As sir was telling about, this is a horizon of a program. I'm not be touching each and every component, so I'll be restricting to the RM and CHA only. My colleague Dr. Swasti will be touching about the NCDs also. But this is the kind of a programmatic architect which is happening and being worked out for the country. And this piece being very important, because this is a life cycle approach, starting from a reproductive, maternal, newborn, child health, adolescent, family planning. So whatever is being there, all components, they are being there. And these are the indicators basically. Whenever we go to the global or international meetings, we see these 3-4 indicators. One is a maternal mortality ratio. Pregnancy being a physiological phenomena during which how many mothers they are dying because of a pregnancy itself. Second is the outcome of that pregnancy, because rearing and bearing of a child for 9 months, and what is the outcome in terms of a neonatal mortality, infant mortality, or under 5 mortality. And third bigger component is a total fertility rate, how the population is being increasing. And if we see the statistics, what is the current statistics? Way back in 2014, it was 130, and now current status of SRS is 88 per 100,000 women which are being they are 88, they are dying because of a pregnancy related issues, and SDG target is 70. Then is the neonatal mortality, we are standing at 19, infant mortality 25, and last row is about the SDG targets. We are approaching in the right direction towards the SDG targets, and this is how the transformation of the program has happened. This is also an important slide. If we see the 90s, the maternal mortality ratio was 500 plus. 500 mothers, they were dying per 100,000 live births because of pregnancy related issues. Same is with the infant mortality. But the trajectory by which there are two lines, one is a green and a blue. One is a global fall in the maternal mortality ratio. Another is the Indian fall in the maternal mortality ratio. If we see the trajectory by which the maternal mortality ratio of a global has fallen is just 48% from 90s. Whereas for the Indian context, the fall is 86%. This means whatever the strategies, program, RMNCHA, they are working in the country, they are working in the right direction. Because of those impact, those interventions, we are able to bring the maternal mortality much faster what is happening at the global level. Same is with the infant mortality and same is with the total fertility. Though we are the most populous country, but we have reached a replacement level of TFR 2.1. Now, contraceptives, people talk in a different connotations. We are not for a population stabilization, but the too many births which are happening, very early pregnancies, teenage, all lead to maternal morbidity and the mortality, which thus impacting the maternal mortality ratio in the country. So I'll be touching upon these. These are the different components. So don't go with those small jargons. They are the names of the program which has been given to different segments, how they are working. But the main important is that the continuum of life, reproductive life, then maternal, child health, adolescent, then is a family planning services. All they are important because if the newborn is being born in the country, he or she needs a immunization as per schedule. Then once she is 5+, he needs a child health services. Once she becomes an adolescent, she needs a adolescent care. And that adolescent boy or mother is coming as a parent in the family or in the community, then again the maternal services they start. So this is the continuum cycle. We have to focus on these points. Most important in maternal health program is the out-of-pocket expenditure. If the deliveries of 30 million deliveries which are happening, 2.9 crores, if they are happening in the country, there should not be any out-of-pocket expenditure. So is the JSSK scheme, in which whether it's a normal delivery, whether it's a cesarean section, there should not be a penny being spent by the family in the government setup. If the newborn child is being born and if he or becomes sick in the progression of time, they need not to spend money in the hospital. So for 1 year, the newborn child, and for the cesarean sections for 7 days, for normal delivery for 3 days, all these diet, food, diagnostic, transportation, in-house treatment, all need to be free. And we at the Government of India impart and give money to all states through the state program implementation plan. And till now, from 2024, we have given almost 1.97 crore beneficiaries. They have been availing this kind of services. How the medical college, how the teaching faculty, which is there in a PSM or in pediatrics, or we are leaders of a medical college, how we play an important role into the implementation of this scheme. It is by handling the technical advice to the state governments, having a service delivery, having a SOPs building for those activities, how we can build up our program in collaboration with the medical college. Second is a Suman program, Surakshit Matrata Aswasan, where the denial of services is not there, and we impart quality services. We have a component to address the grievances also, and all preventable causes of maternal and newborn death that can be handled in the Suman program in collaboration with the medical colleges, with collaboration with the teaching academia, and which will help us to implementation of the program. And there are many committees or a supervisory board which are in each state. Wherever we have a AIIMS or a medical college, those faculties, they are already part of those advisory bodies or state committees, how we can impart our technical knowledge for the translation of a program in the field. We have a data, we have a statistics, we have a science, we have a research. So something new has come at what is the impact of that X policy or Y policy. So we can bring a change into the documentation, how we can move forward from the existing document to the next document. Third point is a PMSMA services. Why our mothers, they die in the field? We have to see that. Why they die? Because during those 9 months, if some high-risk pregnancy is there during normal deliveries or during those 9 months, that need to be captured in a timely manner. So PMSMA programs give us a tool that 9th of every month from PHC, CSC, district hospital, sub-district hospital, medical college, we need to have a PMSMA session where some CMOC or a BMOC doctor or a DGO doctor or a gynecologist or any MBBS doctor who has been trained in comprehensive emergency obstetrical newborn care, they touch the mother actually in 2nd trimester onwards to capture the HRP. Once the HRP is being captured, we can tag that mother to the next higher facility. Once she is tagged to the next higher facility, we can have a diagnostics, the birthing planning can be done. So those high-risk pregnancy, they can be captured, can be tagged, and they are fully managed during those 9 months. This will help us to reduction of maternal morbidity and mortality in the country. So this is the 9th of every month. This is all, and how the medical colleges, if the PG or a senior residents or a HODs, if they monitor those programs wherever they have a medical college, where the vicinity of a district or in a state government, how we can help in volunteering one day by the gynecologist senior resident to going to the CHC or PSC. Sometimes we ownership have a ownership of a PSC or CSC. But this is a programmatic component we need to contribute into this program. Second is the family planning services. We have a basket of choice. Now we are at a replacement level of less than 2.1. We have a TFR less than 2.1. But it's not contraceptives. They are not for the population control. They are for the healthy mother of the country. We have a different basket of choice. Recently, program has introduced subdermal contraceptive implants. There is a matchstick kind of a thing which is being inserted under the arm, under the skin, and it prevents the pregnancy till 3 years. So single tool empowers the mother to control over her fertility. Thus, if the teenage pregnancies are there, they can come into 21, 22, so that morbidity part, that the vulnerability is taken care of. If the gap between the two child is required for the healthy mother, that can be maintained. That is a one commodity we have brought in the program recently, sub-Q injection, subdermal injection. That has an effect for 3 months. And if you impart 3 injection to the mother, keep at your home, and when you teach them to how to put in the thigh, that fertility is controlled for 1 year. This is how we can empower our mothers. So for those developing those SOPs for those subdermal implants, for new innovation in the contraceptive, this is how we can help the community programs which are being done in the community level for the implementation of family planning programs. This slide I purposely put. This is a modeling of a contraceptive use in the community. In 2024 modeling, almost 16 crore married women are using modern contraceptive, and 3.7 plus crore additional women, they have been added. But more important is that by using those modern methods of contraceptive, 6 crore unintended pregnancies, they could have been averted. 20 lakh unsafe abortion they can be prevented basically. They are being done. And this has led to 20,000 maternal death prevention because of a contraceptive use only. Otherwise, unsafe abortions, unwanted pregnancies, no have access of a quality abortion care, all have landed up into the absolute number of a maternal death in the country, thus raising our MMR at the country level. This is the Rashtriya Kishore Swasthya Karyam. I'm just putting one slide for the adolescent health only, because adolescent health is very important. They have a risk-taking behavior in terms of sexual activities. They have a risk-taking behavior because of addiction, abuse, disabuse of any substances. So community kind of a clinic, having ambassadors, adolescent-friendly clinics at the community level, all needs to, they are part of the program. And as a teacher, as a academia, we can help to strengthen these programs in the community. Then is a Rashtriya Bal Swasthya Karyakram, which detects the defects in the community for the newborn children. There are almost 32 kind of conditions. If they are being detected, screened at the PHC, CSC, at the district hospital, and how we can help, because providing the services, providing the technical knowledge, providing the capacity building, the state machinery to the district machinery, how the role of medical college can be elaborated in all these programs. This is about the immunization program. This is the world's largest public health intervention in the world itself. Why I'm saying there is not so much of a cohort of 2.9 crore pregnancy and 2.6 crore newborns in the country. We impart free of cost 11 antigens against 12 vaccine preventable disease. We are the largest manufacturers of the vaccine in the world, and almost 50 to 60% of the vaccine to low and middle income countries goes from India itself. We have a very huge cold chain maintenance system, almost 30,000 cold chain system we have in place, cold chain points in place in the country. This is a slide how new antigens they have been added. From 2014 onwards, 6 new antigens they have been added into the program. When my senior teachers are there, when they were there in the school or in the medical college, 4 or 5 vaccines were there. But for last 10 years, 6 new antigens, let it be a pneumococcal, let it be a rotavirus, inactivate polio virus, TD vaccine, measles rubella combined vaccine, all they have been added. Recently, the country is working for introduction of 2 more new vaccines. And VPD surveillance, no immunization program can be successful unless until we keep a watch on the VPDs, the vaccine prevalence, the VPDs happening in the surveillance of all those conditions. And this is how the medical college they can play in the research, in the academics, and in doing a surveillance by sending our PGs for new vaccine introduction, developing SOPs. The JE surveillance is there, the pneumo surveillance is there, the CRS, congenital rubella syndrome surveillance, which happens in the tertiary care institutes. Then AEFI is very important part because safety of the vaccine, the confidence building of outside the country people, within the country people, the family, the AEFI is important. And we have a very well structured, we use IT for the adverse event following immunization that being captured from the community itself through the Safe Act portal. So each vaccine is safe so that confidence is there, no refusal, no denial, no hesitancy is there. And we use the program and how the medical college they can help us. This is the overall at each level, let it be a supplementary immunization days, NID days, A5 days, or we have a very expert groups, the measles rubella India expert advisory group, measles rubella, then we have a polio India expert advisory where the academy and the medical college they work as experts into those, what should be the policy for the immunization for the country. We have a national technical advisory group for immunization chaired by Honorable Secretary Health, and they're part of the medical college, they are in that team. So this is how we are imparting to the medical college and the importance of that. This is my last slide. This is a thematic area where how we can help to the program in the country, that in be evidence generation, which we all doing. But there is a disconnect between the evidence generation and translation into that policy formation and implementation of the program. I think that disconnect need to be bridged, and from the academia side to the program publications and then to the public health implementation, then service delivery. We as a medical college also provide the service delivery, that it be immunization, ANC, out of reach camps. So this is how the service delivery can be imparted and strengthened through the medical colleges. Then community engagement through our PSM department, through the pediatrics, through the gynae ops. We have outreach sessions also. We own some PHCs, CHCs, villages, and during those our third year, fourth year MBBS student program, how we need to align those programs, those community attachment with the MBBS doctors in alignment with the program requirement, not as per the NMC, but we have to see how best we can use those HR in the field for the programmatic interventions also, the policy support and advocacy, because we are the advocates, we are the policy makers, we have academia knowledge also. Wherever we go in any platform, we need to do advocacy of the program also. This is at the, and that program intervention should be so simple that the people which are the periphery, they understand actually. How we can benefit out those schemes. Then monitoring and evaluation, this is the last leg of any program. As a public health person or as a physicians or as a medical college colleagues, we can how can help us in the monitoring, evaluation and supervision of the program in the country. There are so many, I just given a few committee. There are so many committees which are there in different programs, and we have a colleagues from the medical colleges also. But this is another area how the medical colleges, they can play a very important vital role in public health interventions, which is actually an actionable point at the field level and which actually brings the impact, not in terms of a service delivery. It has indicators also which are being seen at the global level also, and we stood a very high pedestal once we go in the global meetings that this is the program intervention in comparing to African countries, how the maternal mortality has fallen, how the IMR has fallen, how the under 5 mortality has fallen, how through the domestic budgeting, we are giving 11 antigens worth of 5,000 crores procurement of vaccine, which the other countries, they are dependent on the donor and development agencies. That is the beauty of the Indian context, because we are the manufacturers and we have a policy program to practice. This is how we are bringing impact to the program. I stop here. This is my last slide. Thank you very much. Thank you.
Thank you very much. Dr. Pawan, I think your talk brings a lot of pride in us in India that we are doing pretty well in the field of MCH. We are producing a huge amount of vaccine, and you said that the maternal mortality rate is coming down. Whatever we want to achieve, we are. in your opinion, where are we lacking?
So, sir, if we
And-
see, there are some pockets in the country because we have done an analysis of the whole country. Out of 36 countries, there are 11 states, and out of those 11 states, there are 110 districts which we have identified, putting 9 indicators. We brought a composite index of 9 indicators where the ANC checkup is low, where the anemia prevalence is high, where the infrastructure is low. We have identified 110 districts where 80% of maternal death they happen. So we have pinpointed, we have done a root cause analysis also. So our policy, the drivers, they are working in those directions also. Same way for the immunization. We have a coverage of 98% for the full immunization coverage. We have a measles first dose coverage 97%. We have a measles second dose coverage 92%. For measles and rubella disease to be eliminated from the country next to the polio is have a coverage of more than 95%, and there should be no case of measles rubella for 3 years. So we are working into that direction. So we have identified those geographies. We have a hard to reach area, tribal area, refusal, resistance. So we made a 10-point strategy how to reach to those 3% of the population. We are not happy with the 97% coverage. We are unhappy with the 3%. Now we have to focus on 3% only, where the medical colleges are there, where the hard to reach area there, how to mobilize, how to break those resistance also. So these are the areas. So we are going in a very targeted intervention, the policy level, how to reach to those where we have not reached actually.
Very informative, very, very informative. Any questions or queries from? Yeah.
So in previous years, I think the government of India gave some nod to IGNOU for starting MCH, PGD MCH courses for MBBS students. What did happen to those candidates? There was no accreditation and most of them have been lost.
So,
This is
sir,
in my state, J&K, I'm talking.
Okay. So I'm not have a direct knowledge of that PGDM course, how the accredited, because maybe my another vertical is looking after the medical education in that. But that program, which I know is a good program to how to strengthen the periphery medical officer, which are doing an online course. So about that accreditation, I'll touch upon with my medical education wing. So about the accreditation of that 1-year diploma course is there from IGNOU.
Dr. Parashar, you were asked.
I have just some input to that, like it's already being done. Several programs, one program like Suman and another one like antenatal care. So like, it is very well known that sensitization is very important, sensitization of public. So like there have been several channels or advertisements and one like in the ringtone when someone dials. So such for short duration, such programs can be actually initiated through that advertisements. Or that areas, some advertisements are very important on public transport, other places, because public like immunization is well known to people. And that Janani Suraksha Yojana, that Yojana slightly changed, name is changed, that is also known to people.
JSY is also the JSSK, a new addition to that.
But that new things, actually, I was also not aware of that. So, I mean, those things should be known to the public.
Yes, well noted, sir.
Thank you very much. One more, yeah, please. Yeah, last. Between two ladies, one.
Okay, thank you so much for allowing me. Sir, I just want to know regarding HPV vaccine, how soon we are going to implement for the whole of the country, because it is limited to few of these states. And my state, I come from Uttarakhand, we are very keen to start it. So I just want
So
to...
as of now, I can say that the work is going on for the introduction of the vaccine. The groundwork is going on. Rest we can discuss in the cup of tea.
When we can launch that? That's a big issue. That's a big issue.
The country is working to introduce that vaccine.
Okay, thanks.
I think we will go and touch the second aspect, and that is, I think, the non-communicable disease. To talk on that is Professor Dr. L. Swati Charan. He is a Deputy Director General in the Department of Health and Family Welfare. Dr. Swati Charan is MD in Community Health from Delhi University. After that, he never stayed in India. He did a Master of Public Health from Massey University, New Zealand. He did a WHO Fellowship in Health Impact Assessment from Liverpool University. He did leadership training in Global Tobacco Control Program at Johns Hopkins in Baltimore and Public Health Leadership Program at Emory University, Atlanta.
And then come back to India.
Then came back to India. So now he is, of course, a Deputy Director General in the Directorate General of Health Services, and he'll be talking on what we have in National Non-Communicable Diseases, NCD. Just a minute, I think we have to honor Dr. Pawan. We have cancelled the tea break. I think tea will come here because there are more questions. Yeah.
When Swasti is preparing, Pawan, I wanted to make a comment. I was part of the UN when SDGs were being drafted. And in 20 years before that, India probably had made no progress in MMR. And here was a very ambitious goal reduced to 1/4. And we achieved it. We achieved it already. So my compliments to the program people, to every worker right up to A&M, this task which looked impossible to achieve has been achieved. My congratulations to you and your team.
Thank you, sir. Thank you. Good afternoon, everybody. And after Pawan, I will be taking to the second part of the live course that we have when we have NCDs. So we have many of the risk factors starting early in life, and we'll also touch upon a little bit of that. As Sanjeev sir had rightly said, in the UNGA that we had in September this year, we were witnessing history unfolding for NCDs. The UN high-level meeting on NCDs happened in September 2025, and we could see that from 2011, 2014, 2018, and then this year 2025, and SDG ends at 2030. When we were students, we all thought that 2030 is very far off, but now it's just 5 years ago, 5 years later than now. So now in 2031, we are going to analyze again whether we have achieved the political declaration that we have done for the NCDs as well. But before we embarked on that journey, the first surprising thing which happened this year was in VMMC in Safdarjung Hospital, the medical colleges call us that before you go to the UNGA, these are the views of many of the professionals working in medical colleges. Take our views with you when you go and participate in the UNGA. So that was one vivid example of medical colleges contributing in a high-level meeting. So we all know the NCD epidemic, affecting all age groups as well as also causing premature mortality and also draining the economy of this country. It is part of the SDG goals. We all know that by 2030 we have a target of reducing 1/3 mortality due to NCDs, and it's also part of our own national health policy of 2017 to reduce it by 25% by 2025. Now, so we have the principles in place. We have the directions in place. And then if you look at the evolution of the NP-NCD program, it's way back in 1975. And even though we don't remember the institutional memory, I'm sure like any program, it must have started in some institute. It's always like they say, oral health program, which I look after now as a DDG, started in CDR AIMS as a small pilot project and implementing in some district. Then over the years, we have added many of the components of the NCDs so that we cater to all the NCDs which we need to cater, studied the 2017 National Health Policy and made the comprehensive package for the PHC, etc. And if you on the later part, we have added the STEMI, we have added the chronic kidney disease and the dialysis program, and the latest entries being, COPD and non-alcoholic fatty liver disease, thanks to Dr. Sarin and his team. And now in the UNGA, in the political declaration, there is a there is a paragraph on hepatic cancer, and India had proposed that NAFLD should be there, then it is there. So India is being rated as one of those few countries which has embedded non-alcoholic fatty liver disease in the program of NCDs. So now for WHO, only focus on 4 of them, but in India, for operational point of view, we are focusing on 8 of them: so hypertension, diabetes, CKDs, COPD, liver, then cancer, then STEMI, the ST elevation, myocardial infarction, and stroke. And now, earlier we had a tongue twister name of NPCDCS. Now, so now Sarin sir will come and say, where is L, the liver component? So we say NPCDCS-L, and then Dr. Agarwal sir, Sanjay Agarwal sir will say, where is the K component? So now we need to read the, add the kidney component. So then we finally decided that it will be an NP-NCD program so that we can cover as much as possible. To do this, we have got administrative cells, which are known as the NCD cells. These are administrative cells at the state headquarters, and also we have got the district NCD cells. But the actual activities of the clinic happens at the NCD clinic at the district level and at the community health center level. But we also have certain specialized centers called district daycare centers for the cancer component. And you have heard the budget announcement this year. So we are supposed to increase another 200 districts and then saturate it in the next 2 years in all the districts. So we have got a proposal from 281 this year already, and we are going to start the integration right from there. Then the tertiary care centers, cancer care, we had a scheme. We all know that the regional cancer centers were there, but now it was changed into SCI, the State Cancer Institutes, and the tertiary cancer care centers. And we also have the stroke units in many of the centers. So this is all to address the rising burden. We are on an epidemic, transition from the communicable diseases to the non-communicable diseases, and like any other countries in the world. And the service delivery mechanism, very briefly, what we do is at the community level, we have got the ASHA and the ANM. Then we have a community-based assessment checklist, a checklist with which the ASHA comes to your doorstep and then enumerates the members of the household, and then subject those people who are 30 plus and above to that checklist, based on the score of which you will be referred to the primary healthcare centers and through the Ayushman Arogya Mandir. So the health promotion by mere virtue of that screening also happen. Then the ASHA also imparts some health education to the family. So the preventive aspect, the promotion aspect, then primary prevention is happening there. Now the primary level at the primary healthcare, the medical officer is also sensitized to do this. But what happens is the ASHA refers somebody, but he or she doesn't come to the PHC. So the ASHA has to follow up for that. And so if you go to any of the Ayushman Arogya Mandir, ask them how many hypertension patients are there in your jurisdiction. Then they will tell you, okay, I have got 256 of them, and they'll tell you 300 are diabetic. So that data is there because of this activity. And at the secondary level in the community health centers, we have the NCD clinics, and the district hospital also NCD clinic. And the tertiary care level, this is where the medical colleges and the dental colleges, because many of the facilities for treatment are there in these institutes, including the INIs and all other institutes like All India Institute of Medical Science, many of them which has come up, and also the tertiary care centers apart from the regular medical colleges that we have. So this is the mechanism how we are delivering the population-based screening. The challenge for NCDs is unless you have a catastrophe, the patient doesn't come to the health facility. They don't think that they are suffering from NCDs. So unless they have that, so they still roam around with 300 blood sugar and 190 systolic pressure, and so they have no symptoms. So that's why the opportunistic screening that we need to do at individuals seeking health care, either by themselves or through the screening at the doorstep, is very, very important. So because of that, we are doing hypertension and diabetes through the CBAC in once a year, and 3 cancers, oral, breast, and cervical. So I remember how the population-based screening started in one of our institute of NICPR from ICMR in Noida. We were debating few years ago whether to start the population-based screening or not. Then we said that we need to do it. Some people said that we already have a burden. Why do you want to screen and aid? But that's not a solution. We may have a burden, but how can we leave the people whom we could have detected early? And so we started with only 3. So now the role here for medical colleges, we started with 3 of them. Are we going in the right direction? Do we need to include any other cancer? This ease of operation, then ease of diagnosis, ease of facilities available is there. So now the medical colleges and dental colleges will have to tell us that you have done this, but now you can add in the next phase certain other cancers, certain other diseases. Say, do we need to screen for CKDs? Do we need to screen for thyroid? Like that. So that progression needs to be told to the program officers like us. So we deal with many programs. But the priority should come from the clinicians, should come from the medical colleges through their researches. Then the population-based screening, the referral, which I have already explained, happens like this, and the end point of this referral is usually a medical college or a dental college. So that aspect is already there. So now, during this screening, the first referral, then the second referral, third referral for all the diseases is already mapped out. But what happens is, the moment you say that you could be suffering from oral cancer, the non-healing ulcer that you have in your mouth is oral cancer. You need to go and see the medical officer, the PAC. What usually happens is that patient doesn't come to the PAC. After few days, he turns up either in Tata Memorial Hospital in Mumbai or in AIMS. He's standing in the queue of AIMS. So we don't know where he has gone. So in order to be able to track that, we have ensured that Aadhaar IDs are to be generated, the unique IDs, so that we know where that patient has gone. So in cancer, unfortunately, all treatment goes in the PMJ package is utilized, and even after the PMJ package is utilized by the single individual, which is meant for the whole family, then he still is paying from out of his pocket, and he is draining the economy of that, the financial condition of that family, and finally he dies also. So in order to ease that, we are trying to establish the daycare center. Usually after oncosurgery, after the first dose of chemotherapy, patient would love to come back, and then if we can provide with support from the medical colleges, the tertiary cancer care centers, or the state cancer institute, a center, the daycare cancer center, where chemotherapy can be given free of cost, then many of these plights of this patient suffering from cancer can be taken care of. That's what we are planning for. So the state cancer institutes are those institutes which we have funded through 120 crores for upgrading the facilities, and tertiary cancer care centers are little smaller ones which we are funded for about 45. So now the medical colleges and dental colleges, I have given the example of only cancer. So there are other conditions which, because of paucity of time, I'm not been able to elaborate more. So we will realize that these are the referral hubs for the complex NCDs. Many of the hypertensions we continue to treat at the primary healthcare level, secondary care level, but the referral hubs are there for many of the complex NCDs are our medical colleges and our tertiary care institute. Training and mentorship for districts. Now this is something which we do little bit, but not to the extent, like in the NHM and say even the Secretary Education, Secretary Health, Medical Education and Secretary Health in many states are different, and there is not much coordination there. But those where it is happening, the trainings are happening in the medical colleges and the dental colleges. Research and surveillance activity, as Dr. Pawan has also rightly said, particularly operational research, etc. It's done in the academic interest, but when we go to some medical institute, this is a research we have done. But as a program officer, I have never seen that research. So that research stays in the academic circle, then it stays in the medical conferences, which happens for different disciplines, but it doesn't reach the program officer. So these needs to be synced with us together. So that because of these activities, what we need to do is we do advocacy. So many of our colleagues, hear this story that in Lady Harding, I don't know anyone from there, not anybody from Lady Harding, the first air conditioner was installed in the dental department, because when the dentist was operating on the director, on a hot summer day, the sweat, came and fell on his face. Now then he said, you don't have an AC, sir, we have given the proposal, bring the proposal tomorrow, like that. So they understood that, unless we have a AC, I cannot operate on, I cannot, they must be having. Yes, so we need to see that. So that advocacy happens at the highest level. Say if someone say NAFLD, non-alcoholic fatty liver disease, Dr. Sarin is the right person who is advocating at the highest level. Then he has emphasized that if you treat NAFLD, many of the back, downstream NCDs can be taken care of. So that we have taken it, and then so that this is what the medical colleges should do it, and then. The student engagement. So I also deal with what is known as the rare diseases, and during our MBBS we know what are the rare diseases: lysosomal storage disorders and Niemann-Pick. I still remember the name, but then we have written a short note for the toppers. For those who know what to write, Niemann-Pick are the toppers. But after, when you come back to your practice, then you have never seen a Niemann-Pick there. No? So if you have inculcated that right from the beginning of the student time, then that stays throughout their life. And then dental colleges, oral cancer, we have got tobacco cessation services in all the dental colleges now, because now we realize that the dentist is operating 35 minutes, 40 minutes. I think Nandita and Prabhat is here as dentist. They are operating 30 minutes, and 30 minutes they are keeping quiet and they are operating even when they see that the tobacco, the stains of tobacco in the teeth also, they are just doing the RCT, and I said, why don't you counsel this person? I am putting RCT, I'm doing RCT, I'm going to put the implant, or I'm going to do whatever it is going to fail unless you quit smoking, unless you quit tobacco. Or this, submucosal fibrosis, because of which you are not able to open your mouth. Today I can treat you, but it's now going to turn into cancer, oral cancer, then I have to cut out this much amount of like that. So that kind of advocacy, that kind of integrating in the practice with the national program in our mind is very, very important. So the roles and responsibilities, to sum up, we need to do health promotion and encouraging healthy behavior for tobacco-free campuses, etc. But sometimes we remember that we had friends who were reading carcinogenesis and pathology with a cigarette. Carcinogenesis, you are reading, but you have a cigarette in your hand. So during the medical colleges, so that kind of, unless you are a role model, then you will not be able to tell convincingly to other people. So then the clinical care, of course, we have been doing good for all, but through the NCD clinic, the linkage is the downstream also. Instead of the patient coming again and again for the referral, if you can impart it to the NCD clinic, empower them, connect them through e-Sanjeevani, teleconsultation, etc., and impart that, then your medical colleges will also be decongested. Then data reporting, I have already told you, because of the AVA ID, which we are not able to do universal, we still have that. Many patients would have come to you with a heart attack or with chronic kidney disease, unless they are trying to utilize the dialysis units in the district hospital. Till then, they don't bother for the ABHA ID, etc. So that continuum of care is training and mentoring. Of course, I have already said educating, guiding future or the current healthcare professionals is there. Then operational research is one, which is very, very important, because when we are designing, so many people, you say that, oh, you sit in Nirman Bhavan, Pawan and myself, you sit in Nirman Bhavan in AC. And everyone sits in AC, but we are accused that you sit in AC rooms and design the program for the country, which is working in non-AC conditions like that. So that operational research should come from the medical colleges, that if you have done oral, breast, cervical, now include colon cancer, now include lungs cancer, etc. Then phase-wise, we need to improve that. So that teaching should come from the medical colleges. So the usual challenges now is competing academic and service commitment. We have seen medical colleges engaging, then we tell them that we have got our academic activities, we can't enter too much into the program. Then there is weak coordination between departments. So I'll give you an example. The rare disease patient, we have got the Center of Excellences in about 15 institutes now. In that center, one of them is AIIMS in New Delhi. So one patient who is seen in some department, went to Gangaram because he was referred from AIIMS to Gangaram, where the Center of Excellence for Rare Disease is existing in the pediatrics department of genetics and pediatric department of AIIMS itself. But it went to Gangaram, and the Gangaram somebody called me, and I said, where did the patient come from? From AIIMS. No, AIIMS, we have got the Center of Excellence where we are providing 50 lakhs for one patient of rare disease for a lifetime, not to the patient, but to the institute. So in order to get that, we need to do that. So like that, what is happening is the institutes, the different faculties, we do not have that awareness. So the patients keeps, suffering from one department. So that coordination is one of the challenges, and limited NCD module integration in the curriculum. In the curriculum, we do learn, but not in the way how the NCD as a whole is there. Then underuse of many of the digital tools. I don't know whether it is a challenge or it is a liability. So many of us are carrying phones that, and the phone is able to measure your blood pressure, whether it is doing it correctly or not. So those are many things, but we need to see this, whether whether are we over relying on these digital tools, or are we able to use them properly. Where you say, for example, we have got digital sphygmomanometers now. The mercury, because of the Minamata Convention, is phasing out. So we need to switch over. So we need to switch over. But many of us who learn the manometer, we spend a lot of time, dropping the mercury there. Why should I do it? I had learned it with a lot of, and many of us will still say, the gold standard is sphygmomanometer. But how many of us are able to measure the BPs of our own relatives? We are not able to. But now with the availability of digital, sphygmomanometers, they are able to monitor their blood pressure. So there are plus points, minus points, etc. Then weak community linkages. That the only community linkage medical college has is in case of medical college is the Department of community medicine, or for dental college, the public health dentistry department. The all other departments are the patients come to them, so they don't go out to the community. So that weak linkages with the community is one of them. So we are thinking of after coming here, we think that we should now have a nodal faculty who should be for NCD in the institute. If you have that, then that person can be given all the material from the institute, from the ministry, how we are doing it, how that particular state in which that medical college is situated is performing, whether they can be augmented in some areas and so on. And also population-based screening in the teaching hospital, the PBS. I do not know how many of us are teaching in community medicine, or some people who are doing MD in community medicine or community health administration could be knowing little bit of the program component. Then the college NCD committees, the sub-committees which can fit in the different NCDs could also be there. Then we have got campaigns like tobacco-free educations, like the TOFI initiatives, or from the Ministry of Youth Affairs and Sports, the Fit India campaign. So if you engage ourselves and our students in these activities, that itself is a health promotive activity. Otherwise, many of us in the ministry, do you go for regular screening of your, of your parameters in your blood, etc.? No, if you do, you go. I don't know how many of us do it here. In the ministry, we say that, "Arey mat karo, kuch na kuch nikal jayega," like that. So we think that nahi kare to nahi nikalega, like that. So many of us in the faculty also, we think that I think I am okay, like that. So that health-seeking behavior, health promotion activity starts from home. Then tele-mentoring of the district hospitals. Now the district units, whichever is happening, that needs to be tele-monitoring. We will have issues of, who will be the hub and spoke. Now everyone wants to be the hub. No one wants to be the spoke. Now they think spoke is a low status thing. Why should we be the spoke? So hub and spoke. So it's a challenge, but we need to link ourselves together, understand the role of each other. And then we have got, for example, joint oral cancer screening by the medical as well as dental, community medicine, and public health dentistry, OMR, etc. Like that should happen in all the medical and the dental colleges. So now the NCDs, We are trying in the UG/PG, in the curricula, etc., to embed. It's already there, but it's all scattered there. Then we also should have centers of excellence in metabolic disorders. I'm giving an example. So, for example, Dr. Sarin is proposing that ILBS would love to be the center of excellence for metabolic disease. For oral health, we have got a national center of excellence in CDR AIMS, and we have got 3 national resource centers, and we are proposing various state institutes of excellence and also regional centers, etc. So like that, we need to involve them. Once we give a small grant to a department in a medical college, the whole institute, by virtue of being involved at the national program, the whole institute comes and provide guidance and assistance to the program. So that kind of health promotion needs to be there, and student NCD promotion, NCD research promotion should also start, because the early it is like addiction. Like if you give tobacco to somebody who is as young as possible, in a high dose as possible, then the chance of that person getting addicted to tobacco is very high. Like that, our NCD program, the research angle, etc., should be introduced young in life, so that they stay committed to that part. And then we should also collaborate. I have just named only few of them: ICMR, WHO, Ministry of Health, and civil societies. I missed that, and civil societies should also be there, so that we all address the common issues in a whole of government, whole of society approach. So this is all what we need to do for involving. So we should finally institutionalize NCD activities in medical colleges, not just that some of us start and then it's gone. So it should be, there should be a laid down procedure for doing it, and then aligning ourselves with the Ayushman Bharat and the Viksit Bharat 2047. We all are part of that country, dream of the country of Viksit Bharat in 2047, and strengthen the institutional collaboration. And we should build a future-ready workforce. The burden is going to continue. Many of us are also having the NCDs ourselves, and we all joke that, in the whole of ILBS itself, except for Dr. Sarin, all of them have, fatty liver. So all of us who are sitting here will have some NCD or the other. We must be having antihypertensive or anti-diabetic. It's going to continue. It's the disease of the future. So we should collaborate in that way from medical and dental. Thank you very much.
Thank you, Dr. Swati, for this very informative talk. Just I wanted to know, how are you doing the screening? For example, let's say CKD or hypertension.
CKD is what we have already, I had just said. So we are doing only diabetes, hypertension, and the 3 common cancers. For CKD, we are yet to take it up. So we are asking a technical expert.
Let's say hypertension.
Yeah.
How are you doing the screening? Is the person going out home to home for checking the blood pressure?
No, the person will come to the Ayushman Arogam Mandir.
The person has to come.
Has to come.
The individual has to come.
Based on the CBAG. CBAG is a questionnaire, community-based assessment checklist. So are you taking alcohol? Are you taking tobacco? There's a.
Now, how will he fill the questionnaire? He has to come to the clinic?
No. That questionnaire, the ASHA will come at the doorstep. Then 30+ individual, the ASHA will ask the questionnaire. Then based on the questionnaires result, either in a hard copy or in a tablet, the score will indicate that this person has to go to the Ayushman Arogam Mandir. Then they will measure the BP. They don't come. They don't. That's what I'm saying. They don't come. So the ASHA knows that how many. But earlier, NCD screening we didn't do. So everyone was roaming around. Now ASHA know that I had referred this patient. He has not turned up. So he will keep calling that person. Then if that person has come, then on 2 occasions, 3 occasions, his BP is high and given medicine. Then after 1 week, he doesn't come again. And then the ASHA calls.
What
in
is
some states,
what is the compliance rate in your assessment? Honest.
Compliance rate.
You have gone to a village of 5,000 homes. ASHA worker has gone, given the questionnaire. You have checked that possibly 1,000 of them are hypertensive. You tell them, please go to the clinic and get the BP checked up. What is the compliance rate?
I think roughly, sir, I'll have that figure, but roughly around 50 to 60% currently. We still miss out many of them, but many of them do come, because the ASHA is persistent because what we have done is under the Chief Secretary's conference, we have given them certain targets. So 75 million people by 2025 to be put on STGs, standard treatment guidelines for diabetes and hypertension. And then this year in February, March, this time we have done 100% screening. So every ASHA will have to cover that screening. So because of that, those activities which we have done, many of them have come out, sir.
About loss of, but there be some robust system of referral. What is the problem? Why aren't we able to do that?
The robust system is what we are trying. We have
No. Instead of ABBA, why can't you take Aadhaar card into consideration and make some other column in that and fill all health related these things in that also?
Yeah, that's
and make a person compliant. Stop his something if he does not visit this thing. Yes.
I know the intent, but democratically, I don't know how we can do it. I know the intent. It is very. We want to catch him by any means.
Please, two questions. One, can you take the mic? You're not audible.
I have one comment and I have one question. The comment is related to the SDGs. We are already trying to increase or elevate our poverty. We are making ourselves nutritionally more dependent. I'll talk specifically to the cancer patients. Our breast cancer data is showing alarmingly increase right from the northeast and you go to the down south. So the range is now between 32 to 46%. Whereas if you look at it earlier, before 14, it was just 16 to 18%. So that means somewhere it is a health paradox. And most of them which we are detecting now because of screening, 60 to 70% we are picking up in stage 3 and stage 4. So, and they don't get the facilities once they are detected. There is a waiting period in the tertiary care center because of the non-availability of health technology.
Right.
Even the biopsy reporting cannot be done so easily and we lose those patients.
Yes.
So are we implementing the screening at that level and then not providing the treatment exactly when it is required? So what should be done?
That's a nice question. That exactly was the reason why we were hesitating to start the screening. But that being a challenge is not the solution either. So we decided to, start with that. And that's why we are trying to build in the 16th Finance Commission. There is a committee under Secretary Health where we are trying to increase the number of facilities also, not just the daycare centers, but the tertiary care institutes, the ACI and the TCCC, we are going to take in the 16th Finance Committee.
We have major stage 4 cancers being diagnosed in entire India.
But we should have been able to diagnose earlier.
That means it's our failure.
It's our failure.
Failure not to diagnose them early.
Early, exactly.
So my second question is, Swastika, why we are loading in each national health
We are all
program?
leaders sitting here. We have to find the ways. These are problems. What he is saying is a problem. Yeah, you are picking up late. But rather than criticizing, we have to find a ways.
We have to find a way. The best way. Population overload is not the only thing. Everywhere, wherever you talk, everybody will tell you population overload.
No,
China is also having
sir, I slightly.
We can go on some footsteps of countries which have already achieved screening tools in different diseases, not communicable, even non-communicable diseases. Go to Britain, go to US, go to France, Germany, so many countries.
Sir,
we can follow those models.
What sir
Why can't we have a robust referral system? Simple.
Sir, the solution is, one solution is that we can ease the methods by which we can provide equipment to the government hospitals. We need to put it to the ministry. Repeatedly, I have been doing it. It is not easy to follow all the guidelines of the GFR to get these equipments in the government hospitals. Private people can do it. Anyhow, so Asti, my second question is, I am looking after the cancer control and with Dr. Sareen, we are putting up in the HCG task force about the NASH, ASH and MASH, all three. My question is why we are burdening our A&M only for all these national programs. They are looking after almost all national programs.
That's,
So can we do something about it?
yeah, we all say that.
Sir, this is the big question always being asked to the ministry persons and everything whenever any program is being launched. There are the only two healthcare workers, ASA and the ANM. The ASA now is totally overburdened, so they are creating a nirasa among the society.
No, no, I would like to.
We should give incentive to.
So,
Actually,
we are giving, we are
they are
giving.
overburdened with the work, so they are basically demoralized.
Sir, now.
To mobilize them, they incentivize.
Yes, that's part of the scheme, yeah.
And second is the occult fecal blood, very easy test for colon cancer. And it is highly curable if detected early. So I think that should also be included.
Yes, that's a good suggestion.
You are
Dr.
distributing
Sir,
iron tablets also.
I have one just query regarding that population-based screening. Population-based screening for cervical cancer. Are we going to introduce that self-collection of samples for cervical screening in the program right now?
Self-collection?
Yes.
Not yet as of now.
Because the way they are saying that everyone is coming in stage 4, stage 5, because this wire is not that reliable and that is not working as in the field as of now. So,
But we have to see at the national level.
no,
Till now,
I'm from community medicine. So
till
that is
now,
what I'm asking
many of the
this question.
communities, the screening rate for cervical cancer is very low.
Yes,
They are
it's
still
very low and it's
cultural.
not possible also the way we are
Yes.
going ahead. So we need to, we need to have some more strategies for that.
One of my respected colleagues from here said that occult blood in stool, it says it is not to be considered as a screening tool for GI malignancies. The best way is to do a DNA test in stool. That's Sir, community-based mein, you have negativity results, 80% are negative. Right, sir.
Yes.
Sir, I would be happy if this is introduced in the screening methods here.
No, we all agree, the methods are there, the gold standards are there, but when we do it at the national level, say many people will come and say that they want to test the genome analysis of, HPV, etc. Then they come with an instrument called iBreast for, ultrasound based.
I'll tell you one
And then,
example in
of course,
Japan.
It's
Yes. I'll tell you one example of Japan. Initially, there's high incidence of these cancer stomachs, like it is in our state also. So what did they do is they started screening tool, and screening was just making that barium. You would take a films of barium and then could interpret by different good radiologists. But everybody was not undergoing, ready to undergo an endoscopy. So they made mandatory one barium, so that made things easier.
Yes.
So my question is, I think we will stop now. It has been wonderful discussion. And all right.
So diabetes is, we know that a pandemic, and nearly 20% of the population is at that risk or is affected. And complication of diabetes are directly proportional to its control.
Sorry, मैंने इनका mic
And the
ले
key
लिया, mic दे
to
दो.
control the diabetes is that you need regular monitoring and treatment. So is there any policy of the government whereby there is regular monitoring services are given? Second,
monitoring of diabetic patients.
Monitoring of diabetic patients. Second is that there are some complications which can be early screened at peripheral health institutions.
Publications?
There are some complications which can be screened at public health
Facilities.
primary health facilities like diabetic retinopathy, which can be easily screened through AI tools like fundus camera.
Yeah. I think that's a good suggestion.
And third is diabetic kidney disease is the most common cause of end-stage kidney disease and dialysis dependence.
Yeah.
Is there any scheme for early screening of proteinuria, which is the early stage of diabetic kidney disease?
So that is what I asked him.
Not yet as of now, but
for PKD, they have to do one, the proteinuria, and second, the GF calculation. So these are the two screening methodology they have to adopt. So they have not started the CKD program yet. At the moment, it is only diabetes, hypertension, and cancer. Cancer also 3 of them. So that is what is prevailing in NCD today. But gradually they have to diversify into other areas.
And the last question is that the mother of all
Yeah,
these
UACR is a
obesity.
minor.
So is there any national thinking at national level that how we can aware of how we can first find the incidence, particularly in the school going children and young adults, cause NASH, hypertension, diabetes, all these are due to mainly in genetically predisposed individuals.
It is something like a school health program they have to develop. Basically, before the school, the child gets the 12th class certificate, or school leaving certificate, or 10th leaving certificate, you have to bring it that he has to be screened for these diseases. So what you are saying that maybe UACR, it's a childhood obesity. We are missing all the hypertension or diabetics in childhood today. So metabolic syndromes. So possibly by the 12th class, when he is leaving the school, you have to make something that he has to have these tests. And after that, only the certificate will be issued. Something compulsory you have to do. Anyway, I think wonderful talk, Swati, as usual.
Thank you.
And I think now we have somebody was mentioning that
I
we have
have
leadership.
requested General Verma not to introduce me
I'm
because
not
you are all sick of me and my introduction.
No.
So we will skip that.
It is something like somebody was saying that we have come for leadership lectures. So, but a leader has to have a vision. One of the traits of leadership is a broad vision. So I think all these are to give a broad vision of what is happening in the health status in the country. I think now we come to the true leadership talks. And that is, we are talking about emotional competencies, critical thinking, and decision making. I think these are intricate and intertwined things.
Thank you.
Once I believe you don't require introduction.
No, don't,
except
please.
You are my old classmate, right?
And we know each other for last 55 years. So keep that in mind. He can tell you a lot of stories which I also have forgotten.
Right.
So it's better to
Once
keep safe.
I tell you, Manik Shah was once there, so General Manik Shah, Sam Manik Shah. So one of the Havaldars, because we have got monthly or twice a month, there is a meeting that who all have to be promoted. So one of the Havaldars was to be promoted. He thought he will be promoted. But Manik Shah went to the CO that time, he was a major. He refused. He said he will not be promoted. And in the Paltan, he was the only one who was not to be promoted. This Sohan Singh was angry. He was boiling. He said, "Aaj saab ko goli maar dunga." And all the crowd, there was Halka in the Paltan. He said, "Goli pistol, main aaj saab ko goli marunga. Mere ko promotion nahi mila." Now look at Manik Shah comes. He has been warned that it possibly might happen. He might shoot you. So let me go. He went there. He said, "Son, tum nahi mara." He held his hand. "Tum mere ko goli marega? Maro." He gave the pistol. He said, "Maro." Now this is what is called, basically I'll say, emotional competence.
Yeah.
He had a control over his emotions. That is what I feel. That is how I analyze what you are saying. That are you having a control on your emotion? Many times you meet a person, your peon has not done the great job. You just scold him. But is that correct? If you are able to hold on your emotions, that is your emotional competence. And exercise whatever decision you have to take in the next time. And that is how you require a critical thinking and analysis, what action you should take. And that is the decision making. That's, I thought, a layman's language. Please go ahead.
Thank you, General Verma. You
Just
gave a
before
good.
I start, Dr. Swati needs to be honored. Yeah. Very well. Yeah, you.
I will start with where Dr. Swati Charan left. Dr. Vinod Paul came to one of these trainings and they were questioned like this, why don't you do this? Why don't you do that? He asked the medical college faculty, what is your role? You have field practice area. You can adopt a district, talk to the government counterparts. You can even adopt a state. Develop a model and come to me. I will give you funding to scale it up in the whole country. That was the message from Dr. Vinod Paul. So don't corner the program manager in Delhi. Develop models and come to them. They are looking for it. And I can tell you, last 5 years, there is more money in health than the health system can spend. So you will get money. NHM, how much? 5% of money is for research and monitoring. That money is not used. So there's no dearth of money, but come forward, develop model which will show the way to the national program. So with that, we come to decision making. Decision making is a discipline. We need to learn that. And two skills which are very important for decision making. One is emotional competencies and second is critical thinking. If you have mastered these two, your decisions are more likely to be correct and effective in the long run. How many decisions you make? I was looking for literature last night. And then I won't say that I did thorough research, but quick research. An American adult on an average takes 35,000 decisions a day. I'll just take you to when you get up in the morning. Should I get down on the right side of the bed or the left side of the bed? Should I put on slippers, walk to the washroom? Should I brush or not brush? Should I make tea, so I'm saying, do I make tea? क्योंकि मेरे को किसी और के हाथ की चाय अच्छी नहीं लगती, including my wife. So I make my own cup of tea. Should I make cup of tea now or after I go to the washroom? So, if you look at the number of decisions you have, these add up to 1,000. So decision making is not an art which needs to come from heaven or for an expert like General P.P. Verma, Dr. Swasti Charan or me. You are taking decisions. Most of those decisions are subconscious. When I told you what you do in the morning, you remember, yes, this is what happened. But most of those decisions are taken at subconscious level. What we will be talking about is the decision we take consciously and how we can refine those decisions. All of you are clinicians, or you have been clinicians like me. I'm not a clinician anymore. You precisely do what they tell you to do in decision making. Every patient, you follow what management tells you is decision making, but we don't apply that to our work. What do? You listen to the patient. History taking. Undergraduate को पहले clinic में history taking बताया जाता है. Then what do? You do physical examination. Then you do some tests. Then you do some tests to exclude some of the conditions. For example, when you're sitting in an oncology clinic, you do tests to exclude. So if it is excluded, patient is happy, you are also happy. And then if you find something, you do confirmatory test. And then compare it to, we have standard case definitions. COVID के लिए भी standard definitions थी. हम देखते थे probable case है या a likely case, unlikely case, you put it there and then you are confirmed with the decision on diagnosis. Then you take a decision on treatment. You put the patient on treatment. Most of the times you have made a diagnosis, but at times you have a doubt. Chalo, we'll give trial of anti-tubercular treatment for 2 weeks or 4 weeks. And then you realize symptoms are not reducing, so then you change. You look for something else. So same thing happens in decision making. You take a decision, ask your team to implement it, you monitor, and then you realize that decision is not working. You come back to the drawing table, change the decision. This is precisely, and you have done it thousands of times, maybe even 100,000 of times. but we don't apply it to our real life situation in management. Examples, career choices. All of us, I have two daughters, when they wanted to choose their profession, that's a very important decision, which is going to, draw the life of your child. And you take those decisions, get information, and if you have access, many of us have put our child to aptitude test to find out what is the aptitude of the child. So my elder daughter aptitude was towards medicine. She saw two of us from early. She used to go to polio camp. बच्चों को दवाई पिलाते थे, वो भी साथ में जाती थी. So maybe that's how she got inclined. छोटी वाली, we got aptitude test, good in linguistics and managing people, nothing to do with medicine. So she did psychology and sociology, and finally through the back door became public health person. She did health psychology and came back to the field of health. So, all these decisions you take and you change the decision. She said, I am interested in health psychology. Both of us told her, including my elder daughter, तुझे तो हेल्थ में कोई इंटरेस्ट नहीं था. She said, नहीं, मेरे को साइकोलॉजी पढ़ी ना, सोशियोलॉजी पढ़ी, तो इंटरेस्ट आया. Then you change your decision for the child. Shifting from high credibility institution. You are at AIMS. You get an offer which is attractive. Should I move or should I not move? You want to do research and a new opportunity comes up which is new to you. Do you want to work in that area? Because that is going to change probably the future of your professional life. You will be known as expert in oncology. And then maybe you move to that area, or a particular type of cancer. Then you refine your skills and look after that type of cancer. Relocating to another place, that has happened with me many times. I left India, I went to Baghdad, then I went to Geneva to Nairobi, Nairobi to Uganda. So I've been moving to various places. Each one of that takes a lot of thinking, lot of preparation. Should I or shouldn't I? If I should, what all are required? So, for example, in one of the duty stations, when I'm moving to Nairobi, I asked the office where I was joining, I want to come and see the place. They said, fine, we will pay for your travel. Come and stay for 1 week, meet the staff, and then take a call. तो उस एक हफ्ते में मैंने घर ढूंढ लिया, एक कोई ट्रांसफर पे जा रहा था, उसकी गाड़ी खरीद ली. These are many things you have to do. And when my wife and children, we said, dispose of everything, we'll buy everything new. So they were very free, very happy. They had full freedom to buy furniture, appliances for the kitchen, etc. There are many things which are involved in decision making when you move to a new place. Then forced collaboration. Many times we are forced to collaborate. Maybe we don't like it. We don't like a particular head of the department. We were told there is no other way, you have to work with that person. Or with an institution which you don't like and you have to work. Especially when you're doing a multi-centric study. You have to work with many institutions. All of them are not to your liking. So you have to see how you want to get into it, or you don't want to get into it. If you want to get into it, what will be your way forward? And all those factors. Most of the time in your life, there are uncertainties. वहां जाएंगे तो क्या होगा? बच्चों का क्या होगा? बीवी को जॉब मिलेगी या नहीं मिलेगी? या हस्बैंड को जॉब मिलेगी या नहीं मिलेगी? These are situations I have faced when we moved. These are the issues which came up. What are the financial implications? For example, when I moved to Geneva, people think UN salaries are good. But we got almost same allowance because Geneva is very expensive. To give you an example, मेरा जो car parking slot था $300 per month. मेरा घर का किराया, and this is about 10 years back. घर का किराया था $3,000. और जो सफाई करने आती थी वो लेती थी $20 per hour. You have to take decisions. Then I was told, no, don't worry. You get a special allowance because the place is very expensive. So this is another factor which comes in, possibility of failure. I was moving from country program head to looking after 28 countries. My God, एक देश नहीं संभलता, 28 कैसे संभलेंगे? No, you have, will I be able to deliver, not deliver? Work-life balance. And I gave you an example. 3 हफ्ते ट्रैवल करता था, मेरी वाइफ और बिटिया कह रहे थे हम तो भारत वापस जा रहे हैं, आपको तो टाइम ही नहीं है हमारे लिए. So you know that also you need to consider. When you have to work with others, you have unequal partnership. And you have to see how you're going to work with a person who is maybe much more senior to you. Junior to manage कर लेते हैं, पर वो somebody who's a stalwart in that particular area, मैं अपनी बात रख पाऊंगा या नहीं रख पाऊंगा. That is another factor which comes to your mind. High tolerance to ambiguity. होगा या नहीं होगा पता नहीं. How things will turn out. So you have to have a high tolerance to ambiguity and be prepared to face it. You need more and more information. Every day you come to know something which you didn't know earlier, and that will help you in moving forward. You have to consider alternatives. ये नहीं होगा. COVID आया, पूरा देश बंद हो गया overnight. I remember I had gone to visit my parents in my hometown Hisar. वो खबर आई शायद वो क्या बोला था, खुद लगाया हुआ था, what do they call it? खुद नहीं, खुद किए करने वाला मोदी जी ने कहा था, you have to self contain yourself in the house. मुझे नाम नहीं ध्यान आ रहा, और उसे अगले दिन पूरा ही हो गया. What was it called? क्वारंटीन नहीं, कुछ नाम दिया था और अलग. लॉकडाउन से पहले उन्होंने कहा था आप, इट इज वॉलंटरी, यू स्टे एट होम. इट वाज नॉट लॉकडाउन में तो सरकार करती है. नेक्स्ट डे वाज लॉकडाउन. So when I heard that, we immediately came to Delhi, and I was happy कि अगले दिन लॉकडाउन हो गया था, ट्रैवल मुश्किल हो जाता. And you have to be careful and adaptable. Things keep changing. You have to accordingly make a decision and act with that decision. Tools. Every one of us needs information whenever we have to take a decision. So you need to, and many times in uncertain situation, you implement decision and keep gathering information and keep refining your decision. We have another term which is normally used by economists, which is called marginal analysis. मैं अगर दूसरी पोस्ट नहीं लूंगा, मैं दिल्ली में जो काम कर रहा हूं वही करता रहूंगा, और अगर दूसरी कॉस्ट, व्हाट इज द मार्जिनल कॉस्ट इन टर्म्स ऑफ मनी, व्हाट इज द मार्जिनल कॉस्ट इन टर्म्स ऑफ फैमिली लाइफ. I will be moving away from my parents. साल में एक बार आना होगा. I will not be available to them when they have a crisis. That is the marginal cost, not just financial cost. Other cost you have to consider. You develop alternatives, and then वो हम लोग provisional diagnosis करते हैं ना 2-3. So that is how you develop alternatives, and then identify strengths and weaknesses of each alternative and select the one that best addresses the salient discrepancies which you are facing. As you do in clinical practice, you have 2 or 3 provisional diagnoses. You look at each one of them carefully, maybe do more detailed investigations to come back to the final diagnosis, and you do the same when you choose an alternative. Then you take a decision, right or wrong, and implement, take necessary steps for correct execution. Many times you come across situation, decision was taken, but it was not implemented properly. Whatever decision you take, it needs to be implemented properly with full commitment. Otherwise, even the best decision will not work because it was not implemented properly. Follow up and evaluate the results, and be prepared to change. Don't stick to it. We have a term again from economics called sunk economy. मैंने तो 10 लाख रुपया लगा दिया, अब उसको तो खत्म नहीं करूंगा. I will keep trying, चलता रहे. मैंने स्टाफ हायर कर लिया, प्रोजेक्ट तो चल नहीं रहा, नहीं चलता रहे. So that is called sunk cost. And that influences your decision. Business may, if particular unit is not working, they close it down, they shut it down. they take that decision, नहीं तो घाटा ही चलता रहेगा. But when we take decisions in development sector, we get biased because of what we have already in. 5 साल से काम कर रहे हैं, आप कह रहे हो कल से बंद कर दूं? 5 साल से प्रोग्राम चल रहा है, इंटरवेंशंस हमने आइडेंटिफाई की हैं, वो काम नहीं कर रहे हैं, बंद कर दूं? We get biased in development sector because of what we have invested in terms of money, in terms of time and manpower. That we have to be careful about. You have to take drastic decisions at time. नई interventions डाल दो. पुरानी नहीं काम कर रही. Let's look at what are the new interventions in program control. And who is going to tell the new interventions? All of you. Dr. Sasti Charan is looking at you. कुछ नया तो बताओ. आप कह रहे हो 5 ही कंडीशन को स्क्रीन करें, बाकी को क्यों नहीं कर रहे? बताओ कैसे करें. He will do it. और इसमें 6 साल का टाइम इन्वेस्ट, 6 नहीं ज्यादा, 2017 8 साल का टाइम इन्वेस्ट हुआ ये 5 कंडीशन को स्क्रीन करने के लिए. I was in NHSRC when we developed the checklist. और कौन करेगा, कैसे करेगा, रेफरल कैसे होगा. So if you come up with better options, he will do it. He will do it even immediately. 2 ethical considerations we make in decision making. One is utilitarian. क्या फायदा होगा? I am reaching as a program manager, I am reaching 281 districts today. Will I be able to reach 700? कितने districts हैं डॉक्टर साहब आजकल? 750. So will I be able to reach 750? If yes, how? Yes. There is one intervention if I implement, I take a decision, I will implement and I will cover the whole population of 750 districts. So that is utilitarian point of view. And related is, somebody will come to him from Human Rights Commission, 281 में क्यों कर रहे हो? बाकी भारत के सिटीजन नहीं है क्या? 700 बाकी जो 750 में से 281 घटाओ, आधी से ज्यादा जनसंख्या तो आपने छोड़ दी. उनके राइट का क्या होगा? अब उनको ये नहीं पता कि एकदम सबको नहीं दे सकते, फेज मैनर में देना है. बट दैट विल बी अनदर व्यू, राइट्स व्यू, कि बाकियों को क्यों नहीं मिल रहे, उनको भी मिलने चाहिए. कोर्ट में उनकी बात सुनते हैं सब, कोई आके इनकी हेल्प नहीं करता कि जल्दी से जल्दी 750.
6 areas to start evidence.
Yes. That is the rights view. And you have to keep that in mind. And as a public servant, all of you are public servant. सरकार आपको पैसा देती है. So somebody can take you to the court of law कि आप इसको क्यों नहीं दे रहे हो, उसको क्यों दे रहे हो खाली. That happens. That's rights approach. And in the real world, it happens. Coming to emotional intelligence, he gave a very good story of General Manek Shah. He did not control his emotions. What he controlled? His behavior. So emotional intelligence is not that आप मेरे को गाली दो, थप्पड़ मारो, कुछ भी बोलो, मास्क फेस लेके खड़ा रहूं. That is not emotional intelligence. I am not controlling my emotion, I am controlling my behavior, which is not under the influence of my emotions. And that is what is emotional intelligence. Let's look at what it is. Maybe 5 minutes. If you can tell a story, any one of you, think about a situation where you behaved under an intense emotion और बाद में लगा कि ये तो गलती होगी. मेरे साथ तो बहुत बार हुई है गलती. So if any one of you can tell a story. If no one is telling, I will tell you my story. बताओ, please, please, please. I want one of you to say, Mike. And it has happened with many of us. घर पे भी होता है, बच्चों के साथ भी होता है, बीबी के साथ तो बहुत ही ज्यादा होता है, at work place भी होता है. अब बीबी या हस्बैंड के साथ बहुत होता है.
सर पुरानी बात है, मतलब जब माय वाइफ वाज प्रेग्नेंट तो शी वाज वर्किंग इन द अल्ट्रासाउंड डिपार्टमेंट. तो एक कॉलेज में पोस्ट थी एमबीबीएस के लिए. बट क्या हुआ, एक और लड़की ने ज्वाइन किया एंड उसने मेरी वाइफ को शिफ्ट करवा के गायनी में शिफ्ट कर दिया, ऑल्दो शी वाज प्रेग्नेंट. और गायनी डिपार्टमेंट बहुत बिजी था, ठीक है. और मैंने उनको बड़ा रिक्वेस्ट किया कि आप इतना वही इस टाइम तो मत करवाते। तो मैंने वो जो लड़की जो जिसने शिफ्ट करवाया था मैंने उसको कुछ बोल दिया अपना, बट बाद में मैंने रियलाइज किया कि आई शुड नॉट हैव डन दैट। ठीक है, इवन मैंने डायरेक्टर को भी लेटर लिख दिया कि दिस इज अनएथिकल टू शिफ्ट। ठीक है।
Thank you. Any one of us? And now what do you think? If you face the same situation, how will you behave?
सर अभी मैं कहूँगा ठीक है सर, देखो कोई मजबूरी हुई होगी, जो ना दे हैव शिफ्टेड, मे बी उसकी रिक्वायरमेंट ज्यादा थी, मे बी समथिंग शी वाज मोर कॉम्पिटेंट फॉर दैट जॉब, मे बी समथिंग डायरेक्टर की भी कोई मजबूरी हुई होगी, है ना, कि उन्होंने ये शिफ्ट किया। दे हैड नथिंग अगेंस्ट मी और माय वाइफ।
Anyone else? Yes, please. In emotional intelligence, it has been found that women are more honest. हम छुपा के रखते हैं men.
So there was somebody who was taken away from our administration because of some false practice. So I had decided we will not fill that decision as the director, and it hadn't percolated through the file system yet. But I had taken a call that nobody will come in that place. We have to keep that space empty for some time for all the wrongdoing to be slowly unraveled. Nahi to next person will come and start doing the same thing.
Right.
So without telling me, one of the office superintendents, they hired somebody and they hired a staff member's daughter and they put her in that seat, which is administration. I could have just said very coolly, this is not approved and this is in a way illegal or it's not allowed. I just lost my cool. I behaved so badly. I said, who told you to take her? How could you take somebody without asking me? In the position in which I was, it was enough for me to say this is not approved.
Yes.
It was enough, but I really behaved very badly and I got emotionally unnecessarily. I took it on my ego कि मेरे कहने के बाद भी इन्होंने देखो ले लिया, अभी तो वो इतना गंद मचा के गया, अब एक और जने को ले लिया, and her chacha is already here, every confidential matter will come out and it will reach the, well, I said कि ऐसा हो जाएगा और ऐसा हो जाएगा और ऐसा हो जाएगा और ऐसा हो जाएगा, and then अब ये जाके अपने चाचा को बता देगी अब ये हो जाएगा, वो ये भी वही करेगी, मतलब I built so many false हवा में महल and I behaved very bad.
Right. Good. That's very good examples. Thank you. Let's move on. Emotional intelligence is ability to recognize and understand emotions of self and others, and use this awareness to manage own behavior and relationships. What you are managing is behavior. You're not stopping. Oh, गुस्सा आ रहा दबा के रख रहा हूँ. You're not doing that. नहीं तो आपको stress होगा, शाम को मुश्किल हो जाएगी. You will become hypertensive in a few months. So you don't do that. Only 36% of us are able to accurately identify our emotions as they happen. So the first step is identify your emotions as they are happening. And then I don't think I need to go through this. EQ is more important than IQ. And there have been studies looking at income, but you can't be a moron with good IQ. You have to have some basic intelligence to understand things and move forward. So you have to have some intelligence, but at the same time, emotional intelligence is more important in moving you up in the society, in your profession, and also on leadership ladder. Who's this person? The father of emotional intelligence. वैसे तो इमोशनल इंटेलिजेंस गीता में जितनी है ना वो कहीं नहीं है, पर हम लोग वेस्टर्न एजुकेशन इन्फ्लुएंस है ना, तो हम वेस्ट में ढूंढते हैं. This is Daniel Goleman, and I will come to the two books you should read on emotional intelligence, and he has identified 5 core emotion, and then there are 20 subtypes of each one of them. पहले मैं वो matrix present करता था, मेरे को खुद ही नहीं याद होती, तो what can I tell others? So I have stopped at this. 5 core emotions, we need to know that. हमारे धर्म ग्रंथ भरे पड़े हैं. हमारे जितने भी इंडियन रिलीजन हैं उनमें 5 वाइसेस हैं. काम, क्रोध, मोह, लोभ, अहंकार. हमें बचपन से बताया जाता है, पर वो हमारी एजुकेशन में कोई नहीं बताता. वो तो घर में करने की बात है. दैट इज द कोर ऑफ इमोशनल इंटेलिजेंस. बचपन से पढ़ाया गया हमें, और वो ये भगवत गीता में लिखा है, काम क्रोध और लोभ जीवात्मा को आत्मविनाश के नरक की ओर ले जाने वाले 3 द्वार हैं, इसलिए सबको इनका त्याग कर। इससे ज्यादा स्ट्रॉन्ग कौन बोल सकता है that we should not be our behavior should not be controlled by these 3 vices. ये क्या हुआ? What happened to the brain? What has disappeared from the brain? Huh? Cerebral cortex खत्म. And that is what happens when you're emotionally surcharged. वो limbic system में जानवर की तरह behave करते हो आप. Because there is so much of emotional clouding here, ऊपर के कनेक्शन खत्म हो जाते हैं. वो ट्रैफिक जैम जैसे बोलते हैं ना, ट्रैफिक जैम यही होता है, यू बिहेव लाइक एन एनिमल. बाद में आपको लगता है अरे मैंने क्या कर दिया. And emotional intelligence is keeping the control of your higher brain, which we humans have acquired over millions and millions of years. So we have to, this is what is emotional intelligence. The control is always with your higher brain, cerebral cortex. This is summary of emotional intelligence. Self-aware, I know I am getting angry. हमें नहीं पढ़ाते. मेरी बड़ी बेटी की, मेरी ग्रैंड डॉटर जिसकी फोटो दिखाई थी, शी इज 5 years. उसको स्कूल में बताते हैं तुम्हें गुस्सा है तो बोलो मुझे गुस्सा आ रहा है. वो घर में आके बोलती है आपने जो बोला मेरे को ठीक नहीं लग रहा, आई एम गेटिंग एनॉयड. हमें सिखाते ही नहीं.
हमें कहते चुप रहो.
हाँ चुप रहो, चुप रहो,
सीखो.
हाँ चुप रहो. और दादी अम्मा तो जानती थी, वो बोलती थी कि 1 से 10 तक गिनती की. अनपढ़ थी वो जानती थी. पानी पी.
पेरेंट्स तो कहते थे चुप रहना सीखो जरा.
नहीं, दादी अम्मा की, नानी की, उनकी बात करो आप. आपके ग्रेट ग्रैंडफादर, ग्रैंडमदर की. पानी पी ले बेटा, गुस्सा आ रहा तेरे को. गिनती गिन 1 से 10 तक. फिर जब थोड़े बड़े हो गए ना, 1 से 10 तक तो गिनती सब कॉर्टिकल लेवल पे हो जाती है. फिर उल्टी गिनती गिन 10 से 1 तक, है ना. देन योर सेरेब्रल कॉर्टेक्स टेक्स ओवर. आपने कुछ ऐसा किया जो हायर ब्रेन से होता है. सो दीज आर द बेसिक्स. सो वी नीड टू बी self-aware of our emotions and we manage our behavior when we are emotionally charged. Similarly, we are aware of behavior of others and then we have social skills. Empathy is very important. You should have empathy to yourself. Don't keep cursing yourself. मैंने आज ये गलत कर दिया. मेरे से बदतर कोई नहीं. You get into those phases. Everyone, I also got into those phases. बहुत गलत. Have pity on yourself. Empathize with yourself. हाँ मेरे से गलती हुई, आगे नहीं करूँगा. There is a way to move forward. So empathy is across all these 4 quadrants. And this is how it can be summarized. You notice your emotions, you name your emotion. गुस्सा आ रहा है, I am getting annoyed. I am happy. बच्चे यही करते हैं, मैंने आपको बताया था ना पहले. मम्मी पापा में किसके पास जाना जिसका मूड ठीक हो. पापा कल पिकनिक में जाना, 100 रुपए चाहिए. मम्मी का मूड ठीक है तो मम्मी के पास जाएंगे. You know, they read your emotions and then they behave. You accept your emotions. Yes, I am getting emotional, I am getting angry, I am getting annoyed, I am feeling happy. You accept it and it is part of life. Don't curse yourself. मेरे को गुस्सा आ गया. गुस्सा तो आएगा, but don't behave under influence of that. Then you investigate what are the triggers. कौन कौन सी चीजें हैं जो मेरे को ट्रिगर करती हैं into an emotional state. So identify those triggers. You will be more careful in those situations if you have identified your triggers. And then you allow release. चुप रहो थोड़ी देर, गुस्सा आता है तो. And my younger daughter moved to Geneva with us. वहाँ ह्यूमन राइट्स पढ़ाते हैं उनको, बच्चों को घुसते ही. हम उसको बोलते थे बेटा दूध पी ले, तो क्या यू डोंट टॉर्चर मी. मैंने कहा ये क्या हुआ बेटा, हम तो दूध पीने को बोल रहे हैं, डोंट टॉर्चर मी. फिर हमें पता लगा उनको वहां लेके गए थे रेड क्रॉस म्यूजियम में. वहां जो टॉर्चर किए थे, फर्स्ट वर्ल्ड वॉर, सेकंड वर्ल्ड वॉर, वो सारे के सारे पुतले बने हुए हैं. तो देन वी अंडरस्टूड कि इसको वो सिखाया जा रहा है कि डोंट टॉर्चर, डोंट टॉर्चर मी. ये क्या हो रहा है? ये पिक्चर साफ नहीं है. कैन यू गेस? दिस इज a baby crocodile. अभी काट नहीं सकता, so I could hold it in my hand. So you need to know behavior of others, have empathy, service orientation. You have a responsibility as a leader to develop others. Leverage diversity. सब तरह के लोग होंगे आपकी टीम में, सब एक जैसे नहीं होंगे, आपके सांचे में नहीं ढले, सब अलग अलग सांचे में ढल के आए हैं. तो you respect diversity and leverage it. Political awareness. The group dynamics. Why do I walk around? सबके पास क्यों जाता हूँ? So that I can connect. I am aware of who is with us, who is not with us. एक कोने में खड़ा होकर बोलूंगा तो आधे लोग मुझे पता मोबाइल में देखते रहते हैं, मैं देखता हूँ बाकी सेशन में क्या होता है जहाँ वो खड़े होकर बोलते हैं. So you have to connect. So you have, that is political awareness. Politics not only BJP, Congress, RJD, etc. Politics is in every group. And then नहीं तो एक दूसरे से बात करने शुरू कर देते हैं धीरे धीरे कान में फुसला फुसला कि you are not with us. So you have to be aware. ये क्या है? Python around my neck. And my wife and daughter डर रहे थे तो फिर मैंने उनको अपने साथ लिया तो दोनों को इकट्ठा. I have that picture as well. तो उनके गले में डाला तो मैं भाग गए. तो मैंने उससे पूछा कि ये निगल सकता है, मेरे को कहता है सर इतना छोटा है थोड़ी निगल सकता है आपको. ठीक है मैं डालता हूँ. पॉइजनस भी नहीं है. तो you need to generate. I don't say put a python around your net, but you have in real life many pythons around you. So you have to generate a friendly and collegial atmosphere. They also should feel comfortable. Influence, and you have responsibility to coach and mentor others. मैडम शेयर करो, आप आपस में भी कुछ हंसने की बात कर रहे हो. We all want to laugh. We all want to laugh.
Having a time of life.
ऐसे करके. Not for public consumption. Oh, okay, I'm okay. I'm okay with that. So you have to manage others' behavior. You will be able to do it when you understand their behavior. You read what is going on in their mind. We have been talking. कुछ लोग हैं बड़ी हमेशा गलती सोचते हैं. I had a faculty member as director of IHMR Delhi who was notorious. सबसे लड़ना उसको. तो एक दिन रिसेप्शन में धुआंधार, स्टूडेंट्स आर वाचिंग, फैकल्टी विजिटर्स आर वाचिंग. तो मैं वहां गया. मैंने कहा क्या हुआ? तो मैं उनको अपने कमरे में लेके आया. अपने पीए को बोला मैडम को, शी वाज फॉन्ड ऑफ कॉफी, मैडम को बढ़िया सी कॉफी बनवा के लो. पहले तो उसको बिठाया. तो उसको पूछा क्या हुआ? Then she came out and I did not react. And she told me what happened. So what do you want me to do? मैंने कुछ नहीं बोला ये करो वो करो. What do you want me to do? सर नहीं मेरे को तो गुस्सा आ गया था. I shouldn't have behaved like this in public. मेरा काम हो गया. अगर मैं बोलता how dare you shout in front of students at the reception, in front of visitors, वो उन दोनों की लड़ाई खत्म होके मेरी लड़ाई शुरू हो जाती. So respect them, bring them in, recognize they're emotionally charged, look after them, and then ask them to narrate the story. वो जो कहानी सुनाएंगे, half of the time they will realize उनकी गलती थी. So, and that happens only if you have social awareness and you manage others' behavior. How do leaders demonstrate emotional competencies? इसमें कहीं नहीं लिखा इमोशन नहीं होने चाहिए, गुस्सा नहीं आना चाहिए, अफेक्शन नहीं दिखाना चाहिए, वो कहीं नहीं लिखा. खाली बिहेवियर कंट्रोल करना. व्हाट डज इट से? शो एम्पैथी, गिव ट्रस्ट एंड अर्न ट्रस्ट. आप उनको ट्रस्ट करोगे, वो आपको ट्रस्ट करेंगे. पॉज बिफोर, वही दादी वाला नानी वाला फार्मूला. पॉज बिफोर रिएक्टिंग, आस्क बिफोर एज्यूमिंग. उनसे पूछो तो सही हुआ क्या. आप एज्यूम करो, आप उसके ऊपर चढ़ जाओ and things get bad to us. Own your mistakes. अगर आपसे गलती हुई है, own it. Say yes, I was wrong. What you are saying is right. Say thank you. वो किसने बात की थी? डॉक्टर अतुल कोतवाल ने शायद बात की थी. Use this often. Lift others up. Keep your promises. If you promise something, keep that promise. Otherwise, they lose your trust. Then anything on emotional intelligence. I try to keep it brief क्योंकि ये 3 टॉपिक हैं, एक एक टॉपिक बड़ा लंबा है. So I just brought the gist to you. How are we doing on time? Okay. This is the last component. Critical thinking. What do you understand? Critical thinking should be criticizing everybody around you, no? That is what the word says, critical. You're always critical. You often come across such people who हमेशा गलतियां ही निकालते रहते हैं. They have no positive suggestion और गलतियां निकालते रहेंगे. ये भी गलत है, वो भी गलत है. वो घर में भी हैं, बाहर भी हैं, और सासू और बहू का तो बहुत चलता रहता है ना. So you have a problem, you think about it, and then you think of a solution. How do you do that? What is critical thinking? Reasonable, reflective thinking that is focused on deciding what to believe or do. Skillful, responsible thinking that is conducive to good judgment because it is sensitive to context, relies on criteria, and is self-correcting. We all have biases. And if you have critical thinking, you will take care of your biases. Thinking about thinking while you are thinking in order to make your thinking better. So these three definitions together make you understand. I used to be started my career as a teacher in a medical college. Definition batao. Definition batao. I have stopped doing that now. You should understand what it means. Even if you don't know definition, you should understand what is critical thinking. वो रट के आ जाएगा डेफिनेशन, उसको कुछ नहीं पता उसमें डेफिनेशन में क्या है. बहुत अच्छा किया. I learnt it after making lot of mistakes. बिल्कुल, that is true. And how does it help? Improve decision making, helps in problem solving, research skills. Research is all about critical thinking. Creativity and increases your curiosity. अच्छा बताओ आप क्या सोचते हो? You have thought something, but you want to listen to everyone in your team. आप बताओ मैडम आप नहीं बोले, आप क्यों चुप बैठे हो? You get everybody to speak. And as I said yesterday in conflict resolution, you encourage disagreement. अच्छा आप कुछ अलग बताओ. So that you and the other person doesn't feel offended कि आपने जो उसने बोला उससे अलग बताया. That is your skill as a leader. Encourage different points of view that will enrich the definition of the problem, and that will also enrich the decision you take. So listen to everybody. अपना मुंह बंद रखो, पहले सबकी बात सुनो, फिर उसके बाद उन्हीं से अच्छा, that's what you are saying. 5 of you are saying this, and then you move forward. What actions you can take? Be aware of the context of your situation. जैसे मैंने कहा ना, आप लोगों ने situational leadership की exercise की थी. And in each situation, you have to behave in a different manner. 6 styles of leadership, Daniel Goleman, you have to take a decision, adopt a style which is different. Ask questions and listen. Good leaders ask right questions. They don't have right answers, but they ask right questions so that they can collect all the information and then they will be able to take a decision. Take the time to understand the diversity of others' decisions, values, and opinions. I worked in many countries. हिंदुस्तान में तो हम किस नहीं करते ना, ज्यादा हाथ मिलाते हैं, ज्यादातर लेडीज से नहीं मिलाते, अब तो लेडीज से भी हाथ मिलाने लगे हैं. आई वेंट टू इराक. वहां पे you meet men, they will come and kiss you, wet kiss on your cheeks. 2 बार kiss करेंगे. So I used to feel uncomfortable. Then I went to Switzerland. They will touch the cheek thrice. 2 बार करे तो it is offending to the other person you are greeting. The rest of the Europe, they touch both men and women. Switzerland, Iraq was confined to only men. In Switzerland, both men and women touch. In rest of Europe, they touch it twice. 3 बार करोगे तो उसको suspicion हो जाएगा कुछ हो रहा है. You know, each culture is different, and then you have to keep in mind what are the values, what is the culture in which you, and in India is a big continent. Every state has different culture. So you need to understand the local context, and your patients come from different background. You have to understand their culture and then take a decision. Be flexible and open-minded in your decision making. accept, internalize and apply constructive criticism. बहुत मुश्किल है. बहुत मुश्किल है. I prefer to call it critique than criticism. क्रिटिक आप मूवीज के क्रिटिक करते हैं, इसका रोल अच्छा था, इसका रोल अच्छा था, स्टोरी ठीक थी, ठीक से फ्लो कर रही थी, दैट इज क्रिटिकिंग, नॉट क्रिटिसाइजिंग. तो प्रेफर द टर्म क्रिटिक. एंड व्हेन यू गो, आई यूज्ड टू गो फॉर पीआर डिस्कशन, मैं बॉस से यही पूछता था कि सर मेरे को बताओ मैं कौन कौन से एरिया में इम्प्रूव कर सकता हूँ. माई फर्स्ट पीआर डिस्कशन आफ्टर आई वेंट टू इराक वाज ए फ्रेंच लेडी. उसने 6 में से स्कोर होता था, तो अच्छा था, 4 4 5 5, एक में उसने 6 में से 6 दिए. सुपरवाइजरी स्किल्स, लीडरशिप स्किल नहीं होती थी. मैंने कहा ये कैसे आपने बोला मेरे को? हाउ इज इट? नो, आई हैव सीन यू वर्किंग विद योर टीम. यू आर वेरी गुड इन टेकिंग द होल टीम टुगेदर. यू टॉक टू एवरीबॉडी, यू रेस्पेक्ट एवरीबॉडी. तो पहली बार मुझे पता लगा अच्छा मेरे अंदर कुछ स्किल भी है. नहीं तो मैं सोचता था लीडरशिप भी तो स्पेलिंग भी बड़ी मुश्किल से याद होती है. एंड देन आई स्टार्टेड गेटिंग डीपर इनटू लीडरशिप. Evaluate assumption before you challenge. सोचो, नहीं नहीं गलत बोल रहे हो. Many times it happens. चुप कर तो मैं शायद से बोलता है. That kind of reaction is wrong. Listen to the person. Maybe the person has something more valuable than you know. Understand processes before you try to change them. बहुत सारे लोग आते हैं, they come and head organization, सब कुछ बदल दूंगा, मेरे से पहले सब बेकार थे, मैं ही आया हूँ सबसे knowledgeable, new head of the department. If he has grown in the department, then it happens. But if somebody comes from outside, वो सब बेकार था मेरे से पहले, मैं ही करूँगा सब कुछ. But you need to evaluate the processes before you think of changing. Maybe you don't need to change anything. You need to only make sure that those are implemented. Know strengths and weaknesses of your followers and empower them accordingly. Be purposeful and take into account your organization mission and value. Are we moving in that direction? Or are we becoming a hindrance? I'm only concerned about my department. I don't bother about where the institute goes. Many times you come up with such people. Engage others where they are, not where do you want them to be. वो आज जहाँ है अपनी स्ट्रेंथ और वीकनेसेस में, वहीं उसको यूज करो. बढ़ाने की कोशिश, ये ना तू तो ऐसा नहीं है वैसा नहीं है, वो नहीं हो सकता, वो ऐसा ही है जैसा आपने उसको देखा है. एनकरेज क्रिटिकल फॉलोअरशिप. अपने इंस्टीट्यूशन में, अपने डिपार्टमेंट में, अपनी टीम में एनकरेज क्रिटिकल थिंकिंग एंड फॉलोइंग दैट. टेक इन्फॉर्म्ड एक्शन. These are the 12 things which you can do as leaders in critical thinking. These are the 4 things. मैं आ रहा हूँ आपके पास. These are the 4 books I recommend you can read. The first 2 are emotional intelligence, working with emotion. He wrote one, first one was on emotional intelligence. पर ये वाली second book थी, उसमें आप अपनी emotional intelligence कैसे सुधारो में उसमें focus है, and available on Amazon. And primal leadership is how a leader should be with strong emotional competencies. So that is how he has defined leadership. Critical thinking, this is Harvard Business Review book. You can order it online. Don't order it in US. In India, it is cheaper. मैं वहाँ जाता हूँ तो वहाँ सिर्फ किताब का टाइटल और पब्लिशर देख के आता हूँ, खरीदता तो मैं यही हूँ. And then making better decisions on decision making. To conclude, take home messages. Decisions are taken thousands of times a day, not only at work, but also in personal and family life. Decision making essentially follows the same steps as we follow in diagnosing and treating patients in our medical practice. Emotional intelligence is important for making right decisions. We can all improve our emotional intelligence. Critical thinking removes personal and other biases and helps in taking better decisions. There is no best decision. Things may change. Today you have some resources. Tomorrow you may have another set of resources. You will take maybe decisions which are different. Now open for discussion.
No, I must say, again, a great talk.
Thank you, sir.
As usual, in a very informal way, you have communicated what emotional competence, what critical thinking, and what decision making is in a very right way. I think any comments are
Comment,
questions.
suggestion, reflection.
And you said you can always improve your critical thinking.
Oh, okay. Yes, sir. आप कुछ कहना चाह रहे हैं?
Venting out dealing with a person goes through a lot amount of situations in a day, as
Yeah,
you said, and have to take a lot amount of decisions. And emotional factor obviously is there, and it depends to whom you are meeting. Maybe you are meeting with your JRs, SRs, you are
Yeah.
dealing with faculties, maybe your dean or maybe director also. So a person goes through a lot amount of emotions in a single day also. And maybe all the emotions, whatever things happen may not be good. So the emotions build up.
Yeah.
Right? It build up. And so there should be a mechanism by which you can vent it
can
out,
release.
because if you don't vent it out,
Very
I mean,
important.
if you react at the same time, it
Yeah.
will be disastrous. Right. So what is your take on venting out emotion which has been built up? You know, you become angry, you become
Very important. You will come across people who are sitting with a senior and they have something else to say and they keep it to themselves. They don't open up. Oh, irritation, annoyance, or maybe anger that keeps building up.
Yeah.
The way out is emotional competence. You recognize you're getting annoyed. Why are you getting annoyed? What was the trigger? And don't behave. The word you use is reaction. That's very appropriate. Don't react, respond. And then you take a deep breath. 2-3 लंबे सांस लो या 10 से 1 तक उल्टी गिनती गिनो या pick up a glass of water, have a few sips, then you will cool down and then you can respond. If you do it immediately, you will react and that will not be good. और वो पाइल अप होते रहते हैं, आप रेस्पॉन्ड भी नहीं करते, चुप करके बैठ रहे तो जो कुछ भी हो रहा है ठीक है, जैसा हो रहा है, and then it piles up.
Yeah, obviously.
And then you may go into depression, which is very common. I have been on depression, treated with antidepressants for 2 years. That situation in the family, at workplace, and they all pile up. So you need to respond, not react. That is the right approach to it. It's easier said than done. Needs a lot of self-control, if I can say. Not emotional control, self-control. I will not behave. I will think about the situation carefully, critical thinking, and then I will respond. Thank you. Very, very appropriate question. We face it every day. Yes, please. Pick up the mic.
I'm administrator, sir. Many times what we expect subordinates will not do. You say something that will not happen by the next day. So I may lose self-control, how to manage it. Whereby I lose control and shout at them. I know that I'm shouting at them.
Right.
Because what we expect, they don't do. What is the seriousness of the issue that subordinates will not do? Many times it happens. How to control these emotions.
Yeah, the very, very common situation you come across that. And in the morning and yesterday also there was a discussion. When you go to an organization, there are 10% people वो आपने बोला भी नहीं, हाँ सर करेंगे, मैडम करेंगे, उन्हें आपने बोला भी नहीं क्या करेंगे, एंथुसियास्टिक, हाँ सर जो भी कहेंगे, मैडम जो भी कहेंगे करेंगे. इन लोगों को तो पकड़ के रखो, इन लोगों को पकड़ के रखो. उनको 80% आर फेंस सिटर्स. वो देख रहे हैं कि ये 10% लोग काम कर रहे हैं, रिकॉग्निशन मिल रहा है, वो आ जाएंगे. तो 90% लोग हो गए. 10% लोग थोड़े दिन तक तो बैठे रहेंगे, गलतियां निकालते रहेंगे, तू चमचा है, तो ये है, तो वो. उनको भी डिस्करेज करेंगे. ग्रेजुअली दे विल फॉल इन लाइन. अगर आप उनके साथ भिड़ गए ना शुरू में, ठीक कर दूंगा, वो बाकी बेचारे 80% फेंस सिटर हैं, तो कहेंगे कुछ काम ही नहीं है. वो 10% जो करना चाह रहे हो उनको भी कोई काम नहीं मिल रहा. आप तो लगे हो मैं तो इनको ठीक करूंगा. जो 10% है जो काम नहीं करना चाहते, बदमाश हैं, गलतियां ही निकालते रहते हैं. घर में भी होते हैं, नॉट ओनली एट वर्क, घर में भी होते हैं ऐसे लोग. तो focus on those 10% who are enthusiastic. वो सुनने की देर है, सर करेंगे करेंगे, दौड़ के आते हैं काम करने के लिए. 80% भी उनके साथ मिल जाते हैं. वो 10% थोड़े दिन तो सोचते रहेंगे. Then they will also become part of the mainstream. So don't focus on them. Don't react. नहीं तो तमाशा बन जाएगा. And one more thing I don't agree. If it is a behavior in public, you have to point it out in public. ये नहीं बोलो कि अच्छा चुप रहे, कमरे में आएगा तो बोलूंगा. Message goes to everyone. This behavior is not acceptable. In detailed discussion, you can have one-on-one. But if it is a behavior in public, you should tell this person, this behavior is not acceptable. Everybody gets the message. Otherwise, बाकी लोग सोचेंगे कि he behaves like this and gets away. सर तो कुछ बोलते ही नहीं इसको. So if it is a public behavior, you have to point it out in public. Otherwise, it will become difficult for the rest of them who are behaving properly. Any other comment? You have very rich experience. Madam ko phone, wo do microphone.
If you just tell someone that you are behaving badly, sometimes that is more than enough. You just have to tell them कि if somebody is in a meeting, is saying something bad, तो सिर्फ इतना सा ही बोल दो कि you are behaving badly. This is not the way to behave. That is enough. Don't even have to raise the voice and
I
suddenly the
will
person
take you
comes
a
in the backside.
step back.
Yeah, he will just take a step back.
Don't tell them you are behaving badly. Ask them what happened. वो खुद बोलेगा कि मैंने badly behave किया था.
अरे
So,
सर वो सारे टाइम
rather than pointing out, let the person say कि नहीं मेरे से गलत हो गया मैडम, मेरे को गुस्सा आ रहा था, and that will.
बहुत ही कम लोग हैं जो एक्सेप्ट करते हैं.
हो मिल जाए.
दूसरों से बुरा
आप उनसे पूछोगे तो हो सकता है वो मान. जैसे वो ये मेरी फैकल्टी सीनियर फैकल्टी मेंबर, शी वाज ए प्रोफेसर पब्लिक में, मे बी यू नो हर एज वेल. तो पब्लिक में ही वो शोर मचाने लगती थी. उसके बाद वो बिहेवियर उसका कम हो गया जब मैंने उसको बुला के बात की. Dr. Sood, you want to say something?
I think we can close the session if there are no more questions or comments. And what again Dr. Sanjeev said, give way to your emotions. Never keep your emotions pent up. It is only a critical decision when to tell, but if you are insulted or your emotional outburst of your other person is in public, don't keep it to your heart.
Evaluation.
It has to be conveyed. Think about it. That step is taken. Whatever Dr. Sanjeev said, cool down for a minute, but appropriate answer must be given. If it is in public, otherwise you will have your pent up feelings, which is not there. That is not not a good leader. If
Sir,
you
they have
keep
all-
the insult with you.
They have done an exercise on self-assessment of emotional intelligence. Go back to that. Identify where you can improve. And even with, I've been teaching emotional intelligence. That was the first topic I taught in UN. 20 साल से पढ़ा रहा हूँ. उसके बाद भी रात को मुझे कुछ लगता है कि मैंने बीवी को गलत बोल दिया या मैंने किसी कलीग को गलत बोल दिया. तो रात को जब रिफ्लेक्ट करेंगे ना, you will not repeat that. And it is continuous. Nobody can ever behave perfectly.
So I think, sir,
Thank
it was
you.
again a very learning and good experience for me. I sat through for 3 hours and I think I learned a lot from all the 3 speakers before. And I thank everyone and I thank the organizers for giving me this opportunity.
In fact, sir, it is our privilege that you came all the way and the half day with us. We are really grateful to you. And you are really source of intelligence.
Thank you very much.
Thank you so much, Father.
Thank you, sir.
Thank you. Thank you. Please, 5 minutes more. Please.
Yeah.
Now, if you look into your bag, we have a evaluation format which we have placed in the bag, and this has 3 parts. First part is your reaction. You need not write your name on any of it, because based upon your feedback, we will try to include some session in the follow-up session. So it is important that you spend some time on that. It has छोटा करो थोड़ा सा. So,
So it has just what are the topics which you think need to be repeated? What are new topics to be added? What are the topics which we can delete in the future session? So these are your suggestions for the future courses. And the second part of this performa is self-assessment. So on first column, we have the different topics which you have discussed. So give your score yourself. आगे ले लो यार दूसरा वाला और आगे लो और आगे लो. This. So the first column is the contents area of the topics which you have covered. So you score yourself out of 5. What was your knowledge level before you came to this program? And what was a score out of 5 after this training? Okay, so that will help us. What are the topics which you already know and what are the topics which you need to have more content? And the third part is a next one. Letter to myself. लिखा है उसमें. Yeah. So now after this training program, we want you to make, as Dr. Sanjeev said, 1 or 2 commitments. Don't make a commitment which you cannot do. Start from very simple thing. जैसे सर ने कहा कि मैं गुस्सा नहीं करूंगा. Whatever you think out of these messages which you have taken during this program, identify 1 or 2 messages which you can implement at your own level without other support.
So
And
this format also.
this we have put in there. And just after maybe after 3-4 weeks, we'll send this letter through email and we'll see what have you done. We'll remind you. Okay, so that will act as a important sort of stimulus for us also. That for are we successful? What are the areas which we need to sort of? And even you can give your suggestion to your colleagues also, and they can also join the course next time. So with these words, I thank you very much. We have finished on
डॉक्टर
time.
संजीव के लिए एक नहीं डॉक्टर संजीव के लिए एक फूड फॉर थॉट लीडर ये अच्छी लीडरशिप है या खराब लीडरशिप है इफ यू रीड फ्रीडम एट मिडनाइट आई थिंक मोस्ट ऑफ अस हैव रेड दैट डॉक्टर पटेल वाज द पर्सनल फिजिशियन टू जिन्ना नाउ वी ऑल नो that Jinnah also wanted to be the Prime Minister of India and Nehru also wanted to be Prime Minister of India. So it was decided that's good, that let's split it. So one becomes Prime Minister here, one becomes Prime Minister there. Jinnah developed tuberculosis. He had tuberculosis and those days there was no medicine for tuberculosis. INH came in 1950, streptomycin came later on. So we knew, everybody knew that Jinnah is going to die. And eventually, in January 48, Jinnah died because he went to a whatever rehabilitation centers and all. Now, this was the integrity of Dr. Patel. He did not convey this information to Nehru or anybody. Now, is this a professional secrecy? Yeah. So that is why I'm saying now this is what the one is, it's the integrity, and had possibly Patel, Dr. Patel conveyed this information to Nehru or others that he is going to die. It is possible, they say, that division would not have occurred. Anyway,
thank you.
Food for thought.
नहीं नहीं कल भरना है या भर के लाना है कल सुबह पहना है फिर मैं ये इसमें ले जाती हूँ ये नहीं लेके जाती है ये मैं यही छोड़ जाती हूँ इसको मैं छोड़ के जाती हूँ इसको नहीं ये ले जाती हूँ अब तो फोन तो भरना ही है ना फिर क्या होता है आज पाते तक हमारे yes
Oh, Oh, yeah, thank you for saying that.
Yeah. That's you must be aware of that. I think is that two shape of problem supporting the global enterprise of are you aware of it?
Very prolific leader. तो गीता प्रेस का जो स्टॉक है गाने भी वहाँ जाना है. I want to